Hello, doctors. Welcome to our Power Pack session where we dive into 100 high yield MCQs that can be game changers. And why are we doing those one-liners? Are they important? No, we are not promoting any rote learning. Those one-liner MCQs are, I can say, condensed clinical information. That's like bite-sized knowledge nuggets that have to be cracked in the exam. Honestly speaking, those three or four-liner questions are much more easier to solve because there would be some kind of hints possible in those questions. But like I said, those one-liner are like those bite-sized knowledge nuggets, as I say, or like very condensed clinical information where you either know it or you don't know it. So I personally find those one-liners much more difficult to handle, and that is why we're conducting this session today so that we can give you that heads up. I mean, I know it's like Republic Day. I know the fact that you guys would be in a little bit of relax and a chill mode, so that's okay. One should obviously relax on some particular days, but then at the same time, like we are giving you this information so that at any point of time, even later when you're watching this, you can you can get into that groove and then you can push your limits and exceed all expectations. So there are three important things, guys, for this particular session. First and foremost is that confidence building session. As I can say, the second objective is to give you an edge over the others and keep your core steady. I mean, hold your core steady. So let's just dive a little more deeper into the technical aspects of the nitty-gritties of the subject. Let me know if the audio and the visual part is fine, and then we can go get going as far as today is concerned. Okay, I can see a lot of names there. Dr. Sabin, thank you for logging in from Nepal. Dr. Abhishek, Dr. Syed, uh, Raj, Gautam, Swati. So, oh, Dr. Swati from Sri Lanka. Regards, doc. Love from India. And let's now focus on the core aspects. So lots of, it's I would say a medley of multiple aspects that I'll be discussing before you. And the first one-liner is very, very straightforward. I can expect a quick answers in the chat, and I want you to hit the connect button or the contact button or the right option immediately. This is gonna be like a pretty straightforward discussion that I'm doing. A drug of choice for a patient whose blood pressure is like outstandingly high, 220 by 120, and you can see that very classical bat-wing pulmonary edema present. So I can call this discussion as a cardiac emergency. And there are two MCQs that I want to handle in this. One is like hypertensive crisis when it's going to be cardiac emergency, and second I'm going to discuss is a neurological emergency. And he's asking you regarding the drug of choice because my patient is having left ventricular failure due to sudden onset hypertension, and that is going to contribute to development of bat-wing pulmonary edema. So I am having multiple inputs there. It's mainly like okay, I'm getting nicardipine as a primary answer, guys. Nicardipine is a primary answer for neurological emergencies. Nicardipine and labetalol are answer for neurological emergencies. In this particular case, because there is presence of a bat-wing pulmonary edema, what we are going to use is nitroglycerin for this patient. And before I mark the answer here, I just want to highlight this once again. I mean, if you go through the questions of previous years of NEET PG or even of the FMG exam, you will notice this common things being asked. Hypertensive crisis, whenever it is going to be asked to you, either it's going to be from the cardiac perspective or it's going to be from the neurological perspective. When I say cardiac perspective, there's going to be acute onset pulmonary edema developing in a patient because any hypertension, which is sudden onset or a spike of blood pressure, can then contribute to development of, it can contribute to problems in a patient. And to minimize that pulmonary edema component, it is nitroglycerin that would be used. That would be the primary drug. But another problem in our patient can be development of hemorrhagic stroke. So if you were saying nicardipine and labetalol, I take your point, but that would be when I'm going to be discussing with respect to hemorrhagic stroke before you. So two standard one-liners have been discussed at the moment. That was the opening statement from mine. And yeah, doctor, I'll keep on giving tips, but at the moment, let's just focus on I would say the theoretical information that has to be remembered. The first line question to be remembered in this case is nitroglycerin. Additional MCQ, two MCQs have been covered. The third MCQ that I'll cover here is with respect to sodium nitroprusside. I mean, when should you be answering sodium nitroprusside in MCQs? So there are again two MCQs where sodium nitroprusside is the answer. One is going to be like intraoperative hypertension with respect to pheochromocytoma surgery. I mean, that's a very standard question that comes intraoperative hypertension. We will talk about pheochromocytoma as we progress in our discussion, but that is one. And second, sodium nitroprusside would also be used. with respect to any patient who's having hypertensive encephalopathy. They don't ask hypertensive crisis. They always give you a scenario like it is always gonna be either a cardiac emergency or a neurological emergency or pheochromocytoma or hypertensive encephalopathy. So there is like a table given in Harrison in which he is picking up these answers, and now you know 3 MCQs spot on. I'll repeat them once again. Hypertensive crisis with respect to cardiac perspective, there's going to be nitroglycerin. There is no single drug of choice, doctor. As somebody was asking what to answer if there is hypertensive crisis, he will give you either an X-ray or he'll give you stroke presentation, or it's going to be pheochromocytoma surgery, or another possibility can be कि BP इतना बढ़ गया कि spasm हो गया यार. There's going to be spasm of the brain blood vessels. The guy is going to become unconscious. So to ensure that the guy regains consciousness in hypertensive encephalopathy, the drug that would be used is sodium nitroprusside. So with this, we are sorted. Hello, Shaheen. I'll not be able to answer or reply to everybody's, statements, but yeah, that's the first question that I mentioned. And now we move on to the second question. Actually, 3 questions were discussed, but anyway, I'm going to discuss like 100 bits before you, 100 multiplied by 2 into 3. So make it like 250 odd points that I'll be discussing with you in the next couple of hours. The next question is dealing with a patient who's having shortness of breath and bilateral crepitations, and then you can notice the very classical irregular RR interval present in this case, and you were also noticing that the P wave in the patient is in the ECG is absent. So this is going to be a case of atrial fibrillation. And once you have atrial fibrillation present, he's also mentioning regarding bilateral crepitations in the chest of this guy. So that tells us that the person has also gone into heart failure. If a person is having atrial fibrillation with heart failure, that's acute onset heart failure, then we cannot be using beta blockers. Beta blockers, as you know, are contraindicated in patients who are having acute heart failure. Apixaban will be used in the patient. DC shock would be used if the patient is hemodynamically unstable and is not responding to your conventional medication. And because the patient is in heart failure, I can also be using digoxin for this patient. And here he has asked which of the following is not used. This is a direct replica of NEET PG 2024 that I'm discussing with you. And the correct answer for this would be beta blockers. I mean, we do not use beta blockers or esmolol because person is already in heart failure. The permutation combinations are like this. If he says acute onset atrial fibrillation, if person has had a recent onset atrial fibrillation, that would be manifestations in the previous 48 hours, and there is a crashing of blood pressure of a patient, then in those circumstances, we can be using DC shock in the patient. But if it is like a persistent atrial fibrillation and echo shows clots, then DC shock is not to be given. DC shock is not given. I'm highlighting this fact. We will not give DC shock to somebody in whom the clots are already present in the heart. So in a recent FMG exam, they asked about acute onset, recent onset atrial fibrillation, then it is DC shock. But if person is demonstrated to be presentation, कि उसमें atrial fibrillation, yeah, Shailesh, you're perfectly right. Atrial fibrillation, heart failure is digoxin. That is what I've highlighted in my previous discussions and even in the rapid revision section. And if it is going to be presence of left atrial appendage clots, then left atrial appendage clots means that we will not give DC shock in this case. So here we will be doing that race thing. That is, we'll first go for esmolol, then subsequently after esmolol, that's a beta blocker. Then subsequently, the next step in this patient would be anticoagulation. That can be warfarin, or we can be using even apixaban or rivaroxaban. Then we'll go for amiodarone, that is chemical cardioversion in a patient. But this would only be done in those cases where there would be a presence of left atrial appendage clots. The most important thing is oral anticoagulation must be done in these patients for 6 weeks, and only after that amiodarone can be used. And then we can proceed if amiodarone is not working with DC shock. But don't give DC shock directly in the presence of clots, because then the clots will go into the brain of the person. And then he's also mentioned drug of choice for rate control in atrial fibrillation with asthma. Then asthma is a contraindication, so answer is verapamil. And last but not the least, what I want you guys to figure out in this particular case is that if he says atrial fibrillation patient with acute heart failure, in those circumstances, again, we will not be answering. We will not be answering as beta blockers. We'll be answering as digoxin for this patient. There are 4 permutation combinations, and these are the usual ones that he will put up in the exam for the topic of atrial fibrillation. Let's do a quick recap for this. If it is recent onset atrial fibrillation with crashing of blood pressure, I can be using DC shock, never a problem. But if it's gonna be atrial fibrillation and he mentions presence of clots in the heart, then you can't give DC shock. Then it is like race algorithm that would be used for management of the patient. In the race algorithm, the last is electrical cardioversion, but always give electrical cardioversion after 6 weeks of anticoagulation. That will take care of the clots in the patient, but don't directly give DC shock. That's the basic point. If he says asthma, then we are not gonna use because beta blockers are contraindicated. So both of these scenarios, I mean, ये वाला अब recent आजकल उसने पूछना शुरू कर दिया है, इन दोनों में beta blockers would not be given. Beta blockers are contraindicated in acute heart failure ना. अगर heart failure में beta blocker देके brakes लगा देंगे तो the person's pulmonary edema is not gonna clear. So that's the gist of the question that I want. Wine oral anticoagulant heparin daily तो नहीं दे सकते ना. We initially, when if the person is admitted with us for the first 5 days, we will give heparin and start on warfarin, and after 5 days it would be warfarin that would be given to this patient. So heparin is gonna be like the initial few days only, and then once we discharge the patient तो रोज तो injection नहीं लगवा सकता ना, even if you are giving a low molecular weight heparin. So patient would subsequently be discharged on beta blockers. So that's the point, Shailesh. I hope that answers your query. And this, guys, is an important aspect. I keep on getting messages on this that, sir, you said beta blockers are to be used in atrial fibrillation. Yeah, but he's trying to play it smart. He's trying to, either incorporate asthma in the MCQ or acute congestive heart failure. And he did not write the word acute heart failure. स्मार्टनेस क्या वन लाइनर की कि वो एक्यूट हार्ट फेलियर लिख ही नहीं रहा, वो बायलैटरल करपटेशन से लंग फील्ड बोल रहा है. So any patient who's going into heart failure, then we can be using digoxin in those patients. And digoxin has a vagotonic action also, na? But digoxin will have a action on the vagus also, so it will slow the heart, and that is why it would be able to control, at least do rate control in cases of atrial fibrillation. So that's the rationale behind the second question with multiple permutation combinations discussed. Moving to the third one for today, I'll zoom in for your convenience. Penetrating injury to the chest. There are muffled heart sounds and hypotension in a person, so you can pick up backstride coming in. This guy is having a penetrating injury to the chest, so it tells me that there is a hemopericardium, and he says that what will we be doing for medical management of this patient. Yes, very good, guys. I'm waiting. Hit the comment button, guys. I'm waiting for you to hit the comment button. On 26 January, we are studying. Okay, pumping you up. Okay. गुड, वेरी गुड. गाइस, मैं समझाया है बहुत बारी कि अगर ब्लड है, चाकू मार दिया यार छाती में ना, तो ऐसे केस में पेनिट्रेटिंग इंजरी टू द चेस्ट है, सो दे कुड बी ट्रॉमा टू द हार्ट. इफ यू विल डू पेरिकार्डियोसेंटेसिस, इवन इफ यू रिमूव दैट ब्लड और आ जाएगा ना, even if you remove that blood, more blood will come. And will this cure the patient? No, na. We need to open up the chest and ensure hemostasis. So the correct answer for this question is to do a thoracotomy in a patient. The correct answer, one liner question, guys, hemopericardium is always going to be answered as thoracotomy. If he gives you a scenario of lung cancer, like he says, person is having lung cancer and that has metastasized to the heart, is having first a pericardial effusion, and then the amount of fluid around the heart has increased very significantly that it is putting pressure on the heart. So in those circumstances, we can be doing a pericardiocentesis in a patient. So for those scenarios of lung cancer, or breast cancer, or any cancer that is metastasizing to the heart, or it could be extrapulmonary tuberculosis in India, in those circumstances, those pure general medicine causes like TB and lung cancer, we can do pericardiocentesis. But if it is gonna be hemopericardium, then because it is gonna be blood in the chest, even if you remove that blood, more blood will come, plus it will not repair the injury to the heart. So in those circumstances, what we need to do is ensure hemostasis by thoracotomy. We'll remove that blood, agreed, but we need to fix the damage in the cardiac tissue. We need to fix the damage in the possible damage to the aorta, or maybe to the lung blood vessels as well, because if it's a stab to the chest, then the knife could have landed anywhere, including trauma to the lungs of the patient, contributing to pneumothorax as well. So we need to fix the hemostasis component, fix the hemopericardium component. That is why the answer in this question is option number B, and only case where you will answer pericardiocentesis is what I've explained. So very good, guys. I think I got good answers in the middle. Moving to the fourth question for today, a patient with shortness of breath with irregular pulse. This is a classical statement for atrial fibrillation, and there's a loud diastolic sound that is given with a rapid Y descent, and he says what is the most likely diagnosis in this case. You can quickly comment in the chat box again with respect to the appropriate answers that you would be considering. Yes. Okay. So because the person is having presence of atrial fibrillation, that means that there is damage to the heart, there is damage to the atria. There is the auscultation of loud diastolic sound. So I am thinking to myself, is he saying loud diastolic murmur? Because if he will say loud diastolic murmur, and along with this, he also mentions that the person is having atrial fibrillation, then it can be mitral stenosis. Because mitral stenosis will be causing left atrial dilatation, and left atrial dilatation can trigger atrial fibrillation. So this is my first thought process in the case. But then in atrial fibrillation, why it is not, the answer is atrial fibrillation should be having absence of A waves in the JVP. And in this question, there is no mention of any absent A waves. Rather, the key word in this question is a rapid Y descent. The key word in this question is rapid Y descent. That is the word that you have to pick up. I've explained to the fact that rapid Y descent would mean that there would be rapid ventricular filling, and condition where we have a rapid ventricular filling is constrictive pericarditis. The correct answer for this question is option number B. That would be a constrictive pericarditis. That would solve the question here. This question cannot be solved on any kind of mnemonics, because when we say rapid Y descent in a person, that would be rapid ventricular filling in a patient. That mnemonics are not going to work in that case. The core aspect is कि इसके heart के आसपास calcification हो गया ना. Like if I just show the diagram here, what is happening in this patient is a thick zone of calcification outside the heart. That is going to limit the filling of blood outside the heart. That's the problem of this person. And because of this, the atria have to work against a resistance. So इस patient में क्या होगा कि atrial dilatation हो जाएगी. This person will be having structural damage to the atria, and due to structural damage in the atria, there is setting up of abnormal current in the heart. This abnormal current is the reason why this person is having atrial fibrillation, and that is why there is a irregular pulse in this patient. But what you have to pick up in this question is that keyword rapid Y descent. Now let's just analyze everything here. First and foremost is that what is this loud diastolic sound? This loud diastolic sound that he's talking about is pericardial shudder. This loud diastolic sound is what is called as pericardial shudder. So that is the keyword that is to be second keyword that is to be used to solve this question. There are two things that you have to understand. First and foremost is pericardial shudder, which is written as loud diastolic sound because of rapid ventricular filling. And the second word is rapid Y descent. The combination of the two is constrictive pericarditis. And in constrictive pericarditis, what will happen is that there would be a gross dilation of the atria, and that gross dilation of the atria is the one that would be responsible for atrial fibrillation being triggered, which is why the answer to this question will be option number B. Suppose this MCQ was mentioning loud diastolic murmur, then the answer for this question would have been option number A. So those are like the keywords which I want you guys to comprehend. And let's do another one. Let's see another question on rapid Y descent. Like in this case also, rapid Y descent is given in the question with the absent X. So let's look at now. People were applying mnemonics. Now apply the mnemonic, guys, and work out the answer here. Waiting for your inputs for the current question on the scene. That would be rapid Y descent in a question once again coming up, right? Yes, very good. For question number 5 on the agenda, that's the next one-liner that you need to remember would be rapid Y descent with an absent X, and that would be a feature of tricuspid insufficiency. Very good, guys. This is gonna be worked out very beautifully. That would be tricuspid insufficiency, where we get a rapid Y descent. So let's just do these MCQs. Steep X and steep Y, that's gonna be constrictive pericarditis, easy. Absent X and a steep Y descent, that's gonna be tricuspid regurgitation. And if I say steep X and absent Y descent, then it's gonna be cardiac tamponade. So these are like standard one-liners that they have asked in the exam, and I don't think so that anybody would be messing up on them. These two we are able to figure out, but once you get these two, steep X and steep Y, and steep X and absent Y, then it's gonna be absent X and a steep Y descent. The concept to be understood is constrictive pericarditis as the disease has rapid ventricular filling. That is the point, rapid ventricular filling. That is why there is a steep Y. And in cardiac tamponade, there is going to be absent ventricular filling. They're two different things. Tamponade is going to crush the heart. It's going to limit the filling of the blood heart. Therefore, absent, if there's going to be like absent ventricular filling, that is why there is an absent Y descent. And the reason for steep X in both of them is atria is dilated in both of them. The gross dilation of the atria in both of them can contribute to development of the steep X. Then is canon A waves. Yes, guys, you guys can help me. Conditions causing canon A waves. That's also called as frog sign. So what conditions are you aware of where you read about that big pulsations in the neck? Great. AV dissociation. So can you tell me a bradycardia that has a AV dissociation, as a tachycardia that has a AV dissociation? Very good. Great, great. So ventricular tachycardia has a AV dissociation, then is junctional tachycardia, and then is complete heart block. In all the three medical conditions that we're discussing at the moment, there is gonna be presence of AV dissociation, and that is gonna help you here, because if I say atrioventricular dissociation, that's gonna solve this aspect. Atrial ventricles जो है वो एक साथ contract कर रहे हैं ना, dissociation मतलब वो अलग अलग नहीं, so they're contracting together, and that is why this super large AV would be occurring in a patient. And yep, some doctors even mentioned this as third degree heart block. So that's perfectly cool. That third degree heart block is gonna be like complete heart block. So this is a table, guys, that we have to work out. But the previous question was, I would say, a much more easier one as compared to the fourth one. This is that typical NEET PG question where like one word can change the entire domain of the question. If it's gonna be mentioned as specifically, if it's going to talk about loud diastolic murmur, then it's going to be mitral stenosis, loud diastolic sound with the remaining aspects that I've said. Then it's going to be constrictive pericarditis. So I think we are sorted out with this one. Yes, PSVT is another one, doctor. You write, Soumya, PSVT can also contribute to development of Canon A waves in a patient, right? Okay, moving to the next one. Which of the following will not be seen in a large pericardial effusion due to hypothyroidism? The person is having myxedema heart. Myxedema heart would mean that there would be lymphedema, and he says which of the following is not going to be present. Yes, guys. Because lots of one-liners can be negative also, no? They are asked in the negative sense. That is why I said like we are not doing that rote learning, but we are trying to do that condensed clinical info. I mean, treat one-liner as that condensed, concise clinical information which has to be analyzed. Okay, most people got this right. We are going to get a low voltage ECG. We will be getting muffled heart sounds because there is large pericardial effusion. So the sound intensity will become less and the heart will appear bigger also. That is an increased cardiothoracic ratio, but we don't get pulsus paradoxus. Pulsus paradoxus is not seen in large pericardial effusion. It is seen in tamponade only, and tamponade means heart is crushed. There is no size criteria, volume criteria for tamponade. It could be developing over hours, it could be over days, it could be weeks, but it will crush the heart. It will cause a diastolic collapse of the ventricle. Pulsus paradoxus is only seen when there is cardiac tamponade. And what do you mean by the word cardiac tamponade is that there is a diastolic collapse of the atria. So filling cannot occur. Plus there is diastolic collapse of the ventricles also. So there is zero filling occurring. And that is why you would be getting obstructive shock. And because of the obstructive shock, the pulse of the person will practically disappear. And that is the reason why we get this inspiratory disappearance of the pulse, because the input into the heart is practically becoming zero. That's why we call it paradox. Heart is beating, the pulse is disappearing in the phase of inspiration. The correct answer for this one is option number D. I could have begun the question as pulsus paradoxus is a feature of, but वो उल्टा पूछता ना one liner में, so it's gonna be the negative. No, we not say pleural effusion, but yeah, myxedema can contribute to obviously a pleural effusion. That's okay, but not the tamponade part. But I can say that what you're trying to say is from pathology perspective. I mean, why is there a pleural effusion? Why is there a pericardial effusion in hypothyroidism? I think that is what you meant. I understand while tapping it could have been sounding like a total different aspect, but what you mean is the pathophysiology perspective, like a transliterative pleural effusion. Similarly here, there could be processes which could contribute to myxedema heart. Okay, let's move to the next one. A person is having breathing difficulty with significant weight loss, and the auscultation shows muffled breath sounds in the left infrascapular area. I mean, the question previous ones were based on muffled heart sounds, and now they're gonna be focused on muffled breath sounds in a patient. Yes, guys, pretty straightforward. Breathing difficulty, significant weight loss in a patient. Anytime you read about significant weight loss, either it's gonna be tuberculosis, or if it is not tuberculosis, it could be lung cancer. And both of them are conditions which could result in development of a pleural effusion of a patient. And I think that muffled breath sounds is the word which is to be understood in this particular case. It's the breath sounds that are being discussed, which is why the answer to this question is very simple and straightforward. That would be pleural effusion. And the type of pleural effusion that would be present here would be exudative. And that's why he will always talk about Light's criteria. I'll discuss the question on Light's criteria later, but I can mention two values at the moment. One is for protein in the ascitic fluid, and second would be for LDH in the pleural fluid. Sorry, the pleural fluid LDH more than 0.6, and I'll write it here. In fact, PF means pleural fluid LDH more than 0.6 times the serum LDH values, and the pleural fluid protein values to be more than 0.5 times the serum protein values. These are like two important criteria for exudative pleural effusion. So, yep. The correct answer for this one is option number C. The muffled breath sounds were the words that had to be picked up, and along with that, there would be reduced air entry also, and there would be most of the time a stony dull percussion note occurring in the case. The next one talked about next one-liner talks about a hypertensive patient. This is like a complication of hypertension. We call it a why we call hypertension silent killer can be obvious from this one. Patient is having excruciating chest pain with unequal radial pulses, and then you can see the huge tear that is occurring in the descending aorta. So the moment you see this image, you know that this would be type B aortic dissection. Type A aortic dissection would always need surgery. That's where the ascending aorta would be involved. But since in this particular case, it's the descending aorta and a type B aortic dissection, so what we are going to do in this case is blood pressure control and monitoring. The main aspect to be remembered for this particular question is that because our patient is having a type B aortic dissection, that's why BP control and monitoring is possible. But if it is type A aortic dissection, then it is straight over an emergency surgery. Only time when we will go ahead with surgery in type B is for mnemonic ACE, where there is a aortic rupture or there is a continuous chest pain or end organ ischemia described in the question. So if a type B aortic dissection question talks about a possible impending aortic rupture, persistence of symptoms or end organ ischemia, that is ACE mnemonic, then we will say we'll go for surgery, that is a thoracic endovascular aortic repair. Otherwise, it's medical management only. But for type A, it is emergent surgery that would be recommended. So this would be correct answer as option number B. And had this tear been shown in the ascending aorta, that's where the left ventricle would be, then our answer would have changed. The leading cause of this is hypertension, and there would be unequal radial pulses. Causes of unequal radial pulses, I can also mention here three important causes. If ever he mentions about an emergency situation of unequal radial pulses, then answer is always to be given as aortic dissection. That's a standard question. But if he says unequal radial pulses and the case description is given over a long-standing history, then you also have to take into consideration Takayasu's arteritis. Another condition that could be contributing to this can be coarctation of aorta as well. So those are like certain situations where you could be having unequal radial pulses, including supravalvular aortic stenosis. Four causes of unequal radial pulses. Aortic dissection is a medical emergency, but the remaining conditions would usually be having is a long-standing presentation. That's going to be like Takayasu, coarctation of aorta of the preductal variety. That preductal postductal is what I have discussed in the routine main videos, but at the moment, because we're doing revision of one-liners, so I'll just stick to the word preductal variety. And yes, Turner is associated with coarctation of aorta, so that's a good input. In the next question, patient is having joint swelling and pain, and on examination, there is a murmur also. If I say anything more, the answer becomes very obvious to this one-liner question. I have made it a little more elaborative so that you can think of the differentials in this particular case. The words are very classical. There is joint pain and swelling described, and then there is a pansystolic murmur that's occurring in the case. So okay, I'm hit the select button, man. You just need to comment quickly ABCD for this question. Yes, waiting. You see, because patient is having joint pain and there is a heart involvement also. Carditis is also there and arthritis is also there. And along with this, there is elevated ESR also. So I can say two major criteria are present. One minor is also there. Actually, we need one major by two minor. But here, at least you can see that the differential diagnosis that we'll be considering in this case is rheumatic fever. And he's himself saying no negative RA factor. So if RA factor is negative, it's not rheumatoid, it is the rheumatic that we're considering at the moment. So there are like two important criteria given in the question: pansystolic murmur or rheumatic heart disease, and similarly arthritis component plus ESR is also elevated. So he says what will be used for this management? Then the answer for this case would be steroids mainly. I mean, aspirin, not steroids. That was one of the answers that came, oral steroids. We need to give aspirin to these patients for mainly the joint swelling component. And steroids are not going to help in treating the murmur. No, like if it's going to be mitral regurgitation in this case, which is explaining the pansystolic murmur, then for this person's mitral regurgitation, it is a valve repair that would be done. That's a valvuloplasty that we are going to be undertaking, but steroids are not going to work in this. Yeah, patient having a mitral regurgitation, that would be correct, Gautam. Pansystolic murmur and valvuloplasty is the way forward for this one. But for the arthritis component, at least we can give steroids to these patients. Option number A would be answer for rheumatoid arthritis. Only if this MCQ was on a patient of rheumatoid arthritis and talked about anti-CCP antibody, even positive RA factor, then I would have thought in terms of option number A, that is triple therapy for this patient. So that sorts out this question. This is again a repeat of NEET PG. The question was between rheumatic and rheumatoid, and we had to figure out the correct one for this. Moving ahead, a patient with Cushing syndrome has hyperpigmentation over the knuckles and the IP joints, and the ACTH of the patient is ultra high. That's why the hyperpigmentation is occurring at the knuckles and the IP joints, and the MRI head in the patient is normal. He says, what is the possible etiology? Yes, yes, hit the comment button simultaneously. I think we usually get 30 seconds to 45 seconds actually to read a question and analyze an answer in the actual exam also. So you can take this as a session where you are testing your reflexes. Like I said, there are three objectives of today's discussion: building confidence, sharpen your reflexes, and get an edge over others. And sharpening reflexes is what you do in sessions like these. You might be sitting comfortably in your house in a relaxed mode at the moment, maybe relaxing in a couch and listening to me. But then I can say that reflexes have to be razor sharp. And let's work out the answer in this case. Because MRI head is normal, that is why answer cannot be pituitary adenoma. And if it is lung cancer, that the lung cancer that contributes to this is small cell cancer of the lung. And here it is written adenocarcinoma of the lung cancer. So yes, it is ectopic source, but what is that ectopic source? If you listen to the main video, you will notice that in the ectopic source, first I have mentioned carcinoid tumor, and second I have mentioned oat cell cancer. And in the question in the exam also, he smartly did not have oat cell cancer in the options. The correct answer for this one is option number A. In case you got this one wrong, I would suggest you to listen to initial 5 minutes of Cushing syndrome video once again, either from rapid revision or from the main video, whichever you feel comfortable. But then one of the leading causes that he loves to ask in the exam is ectopic source. So we'll do a quick input here. There are like 4 causes. I'll just quickly jot them down here. If he says leading cause, then it is iatrogenic steroids, which is easy to comprehend. This is like unlikely to be asked because it is a very, very simple and a straightforward situation. But then he loves to ask regarding one endogenous cause. That endogenous cause is what is called as Cushing disease. The highlight of this condition will be that there is a pituitary adenoma. Now, how will he mention this pituitary adenoma? Either he will mention findings on MRI head that there is a tumor. He may not write the tumor, he may say mass seen on a MRI head. Second, he will say CRS test is positive. What I mean by CRS test is because it's an adenoma, so it will produce much more higher levels of ACTH as compared to a normal individual. And the third thing would be that if we are going to do a high dose dexamethasone suppression test, if we do a high dose dexamethasone suppression, then high dose dexona suppression test, when done in this case, will show a partial suppression, because lung cancer will never show a suppression, but here he will always write the word high dose dexamethasone suppression test shows a partial suppression. 3 things I said: for endogenous, MRI head is normal, CRS test is positive, and high dose dexamethasone suppression test shows a partial suppression, and not like there is like pituitary will still I would say respect physiology and show a partial suppression of ACTH, but there is no suppression of ACTH with lung cancer. So ectopic sources, what I'm mentioning now, and there are 2 ectopic sources which I want you to remember. One of the ectopic source to be remembered would be carcinoid tumor, which was asked in this topic. And the second one is small cell cancer of the lung, that is oat cell cancer of the lung. The fourth and the last cause of Cushing syndrome I want you to remember would be written as ACTH independent Cushing syndrome. The moment you read this term, ACTH independent Cushing syndrome, this would be adrenal adenoma. There are like four possibilities with respect to causes of Cushing, and questions are based on this information only that I've currently mentioned before you. Especially for Cushing disease, you need to remember this information that I've said. That's for ACTH dependent Cushing syndrome. Okay, so we are sorted for this one, guys. Humble request to you is if you got it correct, cool. Otherwise, just check out the causes of Cushing syndrome, and ectopic source is the one which has been mentioned as carcinoma tumor, and then is the small cell cancer and not as adenocarcinoma. We sorted for 10. I've given a quick summary under like, I would say 3-4 minutes for Cushing syndrome topic. Okay, moving to the next one. Patient presents with hypotension, hyponatremia, blackening of palmar creases. Blackening of palmar creases tells us that ACTH of the patient is again spiking. And hyponatremia tells me, and hypotension tells me that the aldosterone in the patient would be, it would be available, doctor. And the values of aldosterone in the patient would be dropping. So considering the fact that aldosterone is low, ACTH is elevated, what we are thinking in this case would be a primary adrenal insufficiency. It is hydrocortisone that what we are suspecting. So Conn syndrome is ruled out immediately. There would be hypertension and hypovolemic alkalosis. Vitamin B12 deficiency will not have hypotension with hyponatremia. So it's between primary and a secondary adrenal insufficiency only. So we'll answer the common scenario that would be Addison disease. Cool. This is an easy one. The previous one was like, playing with English words, and that is why the answer became carcinoid. You'll always get a mixed bag. Like some questions are going to be like super, I would say, twisted, and some of them are going to be like super simple. Okay, one such an example of another question. Patient presents with ptosis and muscle weakness that worsens with rest, engorged veins on the chest, and CT scan reveals a mass in the thoracic region. So I am expecting your answers there. The reason for this engorged veins on the chest can be compression of the superior vena cava. The reason for this can be like a superior vena cava compression. Yes. Okay. So I'm getting Pancoast tumor. Pancoast tumor mainly causes Horner syndrome. No? Pancoast tumor causes Horner syndrome, and Horner syndrome is gonna be like along with ptosis, which is gonna be one-sided. There will be other things also described, no, like meiosis. He will mention regarding anhydrosis, loss of ciliospinal reflex. So he's not mentioning like on one side unilateral ptosis. He's just given a general statement of ptosis, which we are thinking could be bilateral, and then there is no mention of any information with the loss of ciliospinal reflex. So the answer cannot be option number B, and Pancoast tumor is related to adenocarcinoma. For people who are saying A, thymoma, just let me know, in thymoma, will the symptoms worsen with rest? With myasthenia gravis, will the symptoms worsen with rest? No, na. In myasthenia gravis, what will happen is the symptoms of the patient will improve with rest. Whereas in this case, it is mentioning that the features are worsening with rest. So this is Lambert-Eaton syndrome. This is Lambert-Eaton syndrome. And you are aware of the fact that Lambert-Eaton syndrome is linked with lung cancer. In Lambert-Eaton syndrome, we have the symptoms of the patient are not, are gonna worsen with rest, and they're gonna improve with exercise. Now it is reverse. The highlight of Lambert-Eaton syndrome is that this would be different from myasthenia gravis. In patients of myasthenia gravis, symptoms tend to increase with exercise. Here, the symptoms of the patient increase with rest, and the symptoms of the patient decrease with exercise. This is opposite. And the cause for this Lambert-Eaton syndrome, which is causing anti-P by Q antibodies. If you remember, Lambert-Eaton causes anti-P by Q antibodies. Those anti-P by Q antibodies will be causing a pre-junctional defect in a patient. So that is why there is a muscle weakness occurring. That would be small cell cancer. So the correct answer for this question is option number D. He just needs to twist a couple of words there. The answer is not A, guys. I again say, because if he was mentioning regarding a woman, and then he was specially talking about ptosis with a diurnal variation that is gonna worsen with activity, then I'll think in terms of myasthenia gravis and a thymoma. But considering the aspects that I mentioned at the moment, the answer in this question will become small cell cancer. And why the answer is not B is because even in Horner syndrome, we are having ptosis, but then he should also mention regarding features of meiosis, anhydrosis, loss of ciliospinal reflex. In fact, one more thing in favor of small cell cancer is the leading cause of superior vena cava syndrome. Leading cause of superior vena cava syndrome is small cell cancer. Another one-liner in a one-liner I can say is the leading cause of superior vena cava syndrome is small cell cancer of the lung, because वो central होता ना. So central lung cancer, when it will increase in size, it will press on the superior vena cava. That is explaining why like this person is having engorged veins on the thorax. So one of the key words that I could have picked up in this question is that engorged veins on the thorax. That tells me that it's a lesion in the mediastinum. It's a lesion which is gonna be centrally located, and adenocarcinoma is peripherally located, and thymoma is in the anterior part of the mediastinum again. So to contribute to SVC syndrome is less common. Even if I like don't get into anything else and I just focus on the second line of this question, engorged veins on the thorax, that is SVC syndrome, then I should think in terms of small cell cancer. And small cell cancer produces those antibodies, anti-PYQ, paraneoplastic manifestation, which causes decrease in the production of acetylcholine, and then a Lambert-Eaton syndrome. So the answer for this one is option number D. Another example of a twisted question, like you'll get these permutation combinations in the exam, and you just need to keep your focus on with respect to those questions. Another one, just giving you a taste of what the actual exam will do. There'll be like some easy ones, some twisted ones. So this is the easy one. Which cranial nerve is involved in Miller-Fisher syndrome? Miller-Fisher syndrome is a differential diagnosis, or it is like one of the variants of Guillain-Barré syndrome. The manifestations in this case is ophthalmoplegia, then is areflexia, and then is ataxia. And the cranial nerve that is involved in this case would be the third cranial nerve. It is the third cranial nerve that's involved in Miller-Fisher syndrome. Sixth nerve is what we answer for that Goa thing, no? That Wernicke's encephalopathy. Sixth cranial nerve involvement is what you get with Wernicke's encephalopathy. Another question of sixth cranial nerve would be most common cranial nerve involved in raised ICP. I'll repeat the questions once again. For sixth cranial nerve, there would be two MCQs to be remembered. One of them will say like which cranial nerve is involved in Wernicke's encephalopathy, global confusion, ophthalmoplegia, that ophthalmoplegia sixth nerve palsy. And if he says Miller-Fisher, it is third nerve, and GBS, like it is, if it is AIDP, then it is gonna be seventh cranial nerve involvement, that is facial diplegia in a patient. Yes, Sarvan Kumar, you are perfectly right. Yeah, and another one is cavernous sinus thrombosis also, agreed. But the current question that we are discussing is on Miller-Fisher syndrome, which is a differential where anti-GQ1 antibodies would be present. And this is going to be having third cranial nerve palsy. Conditions in which third nerve palsy would be given, one is Weber syndrome. Weber syndrome is always asked because of the occlusion of the P1 part of posterior cerebral artery. And in this particular case, we would be having ipsilateral third nerve palsy, and there would be a contralateral hemiplegia in the patient. The key features are contralateral hemiparesis, because brainstem stroke will always be having crossed features. Then diabetes mellitus, they've always asked, this time it will always say this phrase, third nerve palsy. This is again a NEET PG question with pupillary sparing. The light reflex would not be affected with pupillary sparing. That's a statement to be remembered. Then Miller-Fisher syndrome is like OAA. I've already mentioned the mnemonic before you. And Berry aneurysm, if it is PCOM, that's gonna be related. Posterior communicating artery, if it's gonna be posterior communicating artery Berry, is the only one that is gonna contribute to a third nerve palsy. Otherwise, with ACOM, the most common location, we do not get this. Yeah, it can, Raj. If I say vascular Parkinsonism, it will make more sense in a patient. Though I can say that the Parkinson disease manifestations are more common with Claude syndrome as compared to that of Weber syndrome. Weber is gonna be like much more anteriorly located. So I'll just say that if we go a little more posteriorly, like Claude syndrome, they are like that. That will have higher chances of causing vascular Parkinsonism. Yes, yes. Millard-Gubler would be having sixth and seventh nerve palsy, na bache. Millard-Gubler syndrome is sixth and seventh. Foville is also sixth and seventh nerve palsy. Na? Both Foville and Millard-Gubler, they are like features of sixth and seventh nerve palsy. So that's why we are not discussing it in this table. This table is only for third nerve palsy. But yeah, Millard-Gubler and Foville I can add here. Six and seven both is for Foville and Millard-Gubler. I would also suggest you to, whenever you get time, keep on listening to those bits of neurology from rapid revision part. That would help you, get those points right. Because otherwise, this is data only, na? Like which nerve is involved, which nerve is not involved. So that is why. Okay, fine. The next question is for ECG of a patient with chronic kidney disease. Again, a hot favorite. And let's look at what you guys have to say for this one. Non-Thenjal is another one for third nerve involvement. Good one. Good one, Karan. That was a good input. So let's look at possibilities. ECG of a patient with chronic kidney disease. Let's look at what you guys have to say. Normally, CKD will cause hyperkalemia, but hyperkalemia should be causing tall tented T waves. Here, the T waves are not looking to be spiked. No, it is limb leads, like they're very, very, I would say, rather very flat T waves present. I'll not call them tall tented T waves. So answer is unlikely to be A. As far as hypokalemia is concerned, hypokalemia should be causing a T wave inversion. T wave inversion. So it cannot be hypokalemia also. So I'm left with only one only. In all patients who are having CKD, either you can have hyper, or if the person is on diuretics, you would notice that patients of CKD are always put on diuretics, and when we put them on diuretics, they can end up with hypokalemia. So we're left with only one possibility only, and that is because CKD, there would be deficiency of vitamin D production, and vitamin D production will contribute to hypocalcemia, and that is why the QT of this patient will be prolonged. Let us also count the QT also, since we have the luxury of time. But in exam, like for CKD, no question, there can be three possibilities: hyper, hypo, or it can be hypocalcemia. There are three possibilities in a question of chronic CKD patient. Before I mark the answer, which you guys have been finally able to narrow down, I'll just zoom into this ECG, in which you can notice the tall tented T waves in a patient. So this is gonna be what, if this was the ECG given, the tall tented T waves, I'll say hyperkalemia. But if you're noticing that ST depression and at the same time a T wave inversion that is happening, then this is gonna be a feature, the T wave inversion component that is coming down. Then this is gonna be a ECG finding that would be seen with hypokalemia. And the reason for this is mainly the use of diuretics, because lots of time we might be using thiazide group of diuretics also. Initially, we might be using spironolactone, but later on the doctor decided to switch it over to hydrochlorothiazide, and that use of hydrochlorothiazide was contributing to the hypokalemia component. And now we look at the last possibility, where you notice the T wave is upright, and then at the same time, let's count the QT here. So this is going to be the starting of the Q, and this is going to be the end of the T wave. So this is fairly long, guys. I mean 10, 12, something like 13 small squares. So 13 into 40, this would make it like 520. Yeah, 13. I think my mathematics is bad, but I think this is what is coming approximately. 500 milliseconds is fairly long, because normally the QT interval will be in the range of, the QT interval is going to be in the range of 360 to 440 milliseconds. So even if you don't count na chalega, you still have to solve a lot of questions. Would be 9 to 11 is normal. Yes, 9 to 11 is normal. So even if you are not able to physically count all this, I'll just zoom it in once again for your convenience. This is like 5 large squares. Na? This is 5 squares, 5 squares. That is 5 and 5, 10. And then I've taken 3 approximately. So that makes it like something like 12, 13 approximately. So it's a little on the higher side. And that's why the answer for this question is hypocalcemia. But I hope I have been able to explain to you that every time you get a question on ECG with the CKD, keep three possibilities in your mind. Either it's going to be hyper K, or it's going to be hypo K, or it's going to be hypocalcemia, and give it the treatment on the basis of the things that I have said. Okay. 14th is sorted. Let's move to the next one. Patient presents with oral mucosa and palmar crease hyperpigmentation. Once again, question is dealing either with Addison or with increase of ACTH. I can say, I cannot say the diagnosis right away, but palmar crease hyperpigmentation, oral mucosa hyperpigmentation is increase of ACTH. Blood pressure is on the lower side. Sodium is also on the lower side, and potassium is elevated. Sodium and potassium have an inverse relation whenever aldosterone is playing a role. Aldosterone, whenever is gonna be less, then sodium in the patient will always be low, and potassium in the patient will always be elevated. Both have an inverse relation. There is also hypoglycemia, like on the lower side, 70 is like the lower limit of normal. So even the blood sugar is less. So I can say this question also talks about hypocortisolism. And since aldosterone and cortisol both are less, the best drug for management of this patient would be hydrocortisone. So two questions on Edison are what I've discussed, and they put it in various permutation combinations. I mean, one question on Edison and one question on Cushing syndrome will always come. Edison is much more easier and most people are able to solve it. But as far as Cushing is concerned, it can be a bit of tricky. So that's why I recommended you to listen to the rapid revision part for Cushing syndrome. It will just take 15-20 minutes, but that would give more firepower to your preparation. And meanwhile, you guys can comment regarding screening test for Edison and investigational choice also. Yes, guys. If you can quickly comment regarding screening test for Addison disease and then investigational choice for Addison. What test can be done in these patients? Okay, so let's not, even if I don't get into like the screening one, at least investigation choice one should be very, very clear, and that would be ACTH stimulation test. Very good. A co-syntropin test is another name. So at least one thing that we have to be clear is that we will be stimulating the gland, and the gland will refuse to be stimulated because it's totally destroyed in this case. I mean, Addison is gonna be literally like a moth-eaten gland. You can see the three layers, and then it's like literally the gland is ruined or moth-eaten, as I've shown at the moment. That's because of either disseminated tuberculosis or it can be due to autoimmunity as well. Yeah, saline infusion is for कौन syndrome, doctor? Here remember A और A ना, इसका हमेशा ये बोला है वो, तभी मैं पूछ रहा था IOC कर लेते हैं ना, because that's the primary thing. It is A and A to be remembered for Addison and ACTH. And in Con syndrome, because there is more salt in the body, so that's where we are giving salt and you are having a failure to suppress cortisol production. So try to remember either of them. Either it's gonna be like Addison and ACTH, A and A alphabets, and for Con syndrome, like I'll just write it for convenience of everybody, that for Con syndrome the investigational choice would be, because there's a tumor. तो ट्यूमर तो ऑटोनोमस होता है, वो मर्जी का मालिक है, मस्त मौला है, कहता है भाई मैं तो अपनी मर्जी से चलूंगा. So it's not gonna respect physiology, right? It's gonna do its own thing. So for Con syndrome per se, if he says like what is the test to be done, then it is gonna be like a salt loading, or it can be saline infusion test. And normally, like if we give saline to somebody, then we can suppress aldosterone production. But an autonomous tumor is gonna be like, भाई मैं तो मस्त मौला, मुझे कौन रोकेगा? Like that. So Con syndrome is gonna be like, you know, autonomous and is gonna be running like that. Yeah. For cortisol, 24 cortisol is for Cushing, doctor. That's for Cushing. जो 24-hour urinary cortisol है ना, that's for Cushing syndrome. So you write it down by yourself, and that's why I said. And I made this table in the rapid revision section also. But I would suggest you to just make it in your own handwriting for the IOC for all endocrine. Because अगर endocrine में आप investigation choice लिख लेते हो ना, तो you are sorted for like the main most of the aspects. Okay. Moving to the next question, we have like cough and foul smelling sputum, plus he gave digital clubbing in a person, and then he's giving an X-ray also. So the questions are based on those permutation combinations. You can see the paratypic appearance of the nails. The person is having cough and a foul smelling sputum coming up. That would be because of pneumonia also. That can be due to lung abscess also. And then the X-ray is shown in this patient. He says like, what is the possibility? So what you can see is the whiteness present in both the lung fields, in the left lung field in this patient. And you can notice that this area is like a little convex here. This is because of the pus which is present here. So this is going to be empyema. The correct answer for this one is going to be empyema. And that would make option number C. Guys, it's not a lung abscess, because lung abscess should always be having an air fluid level. Lung abscess should always be having an air fluid level present like this, because the pus due to gravity will always settle down like this. The pus due to gravity will always settle down like this, and in this case, like there is no air fluid level described. If you check out the X-ray that I mentioned, there is no air fluid level. Rather, what you're noticing is a blunting. Two aspects I want to highlight. One is the blunting of the costophrenic angle that can be noticed in the patient. And at the same time, like we are not getting a Ellis curve, like rather what we are getting is a convexity, because the pus is gonna like, you know, be accumulating in this area. एंड क्लबिंग पढ़ के सीधा आपने लंग एब्सेस नहीं सोचना, बिकॉज क्लबिंग कैन बी सीन इन बोथ ऑफ देम. क्लबिंग कैन बी seen in empyema also, and clubbing can be seen in lung abscess also. So all separative conditions. Answer would be C. And pneumocele is a precursor for lung abscess. Like somebody mentioned regarding pneumocele, so pneumocele is a radiological finding of Staph aureus. Yeah, split sura sign. Yes, yeah, right. That split pleura is what radiologist will say. Na more appropriate is for you. What you have to understand is कि ये this is not convex. This is not concave, right? If it was concave like this, then it would have been pleural effusion. Then it would have been water. But what you can see, what there is a splaying between the two layers of the pleura. There is pus accumulating with the visceral and the parietal pleura. So what you're gonna get in this case is the convexity part. Like this part is not gonna be like concave. It's gonna be, I'll use two different colors. If it's gonna be like the one that I've shown in yellow, then it's gonna be pleural effusion. There's gonna be fluid present. But if it's gonna be the one that I've shown the convex part, then in those circumstances we are gonna be having this empyema present. So this is pus in the pleural cavity, and this can be a two-step question also. So you guys can tell me the management. Obviously, we need to give IV fluids to this patient, but what is the main treatment for empyema quickly? Yes, guys. Treatment for empyema, it can be two-step, like you can say X-ray is shown in this case. What would be the treatment that would be done apart from IV antibiotics? Yeah, we'll put in a chest tube. Yeah. So we have to put in a chest tube, intercostal drainage tube, but the default in the fifth intercostal space in the triangle of safety has to be put in this case, because the pus has to be evacuated on a topmost priority. And along with this, obviously IV antibiotics would be given, because most of the time empyema would be a complication seen with pneumonia. So we need to give IV antibiotics to this person also. Yes, fifth intercostal space, triangle of safety, anterior to the mid-axillary line is where the chest tube would be put, because empyema would need a drainage. So clubbing can be seen in lung abscess, but you need a air fluid level for it. That's why there's no air fluid level in this question. B is ruled out because that's a precursor to lung abscess. So B and D would basically mean the same thing. And community acquired pneumonia is lobar pneumonia, but then I'm not able to see that classical patch of a pneumonia. What I'm seeing in this case is that that convexity coming up on the side where there's the blunting of the CP angle. Okay. Moving to the next one, pleural fluid LDH shows values greater than 0.6 times the serum LDH protein is greater than 0.5. So this tells me, in fact, if I say anything more, the answer will become obvious. So you guys can quickly help me with the 17th question on the slide. Yes, guys. I'm waiting for your answers meanwhile. Okay, very good. So this is gonna be an exudate, and once I say Light's criteria and exudate, so this would mean that the answer in this question will turn out to be lung malignancy, because all other things are gonna be mainly transudate, no? Constrictive pericarditis, end-stage liver disease, and nephrotic syndrome are all transudate, but lung malignancy is always an example of an exudate. So good, guys. The answer for this one is option number B. We had to just pick up exudate on the basis of Light's criteria. And I had already given you a heads up for these two mathematical values even in the earlier part of one of my slides, where I said protein value is more than 0.5 and the LDH value is more than 0.6. Both of them are more than written. That's what gives credibility to diagnosis as exudate. Okay. Moving to the next question. Polytrauma case on day 2 is deteriorating, and the SpO2 of the patient is falling immediately. So he says, and he's given a PO2 FiO2 ratio also. He says the X-ray of the patient is showing which of the following possibilities. You guys can comment in the chat box with respect to this. Polytrauma patient deteriorating with fall in SpO2, and then I'll interpret the X-ray before you. Yeah, this goes more in favor of ARDS in a patient that is acute respiratory distress syndrome, that is ARDS, because bilateral infiltrates are present in both the lung fields. Both lung fields are basically totally white. So bilateral infiltrates, like fat embolism is not a diagnosis. It's called as fat embolism syndrome, because fat embolism can occur even while nailing a patient, or even in orthopedic surgeries, fat embolism occurs, but it does not cause any problem. So actually the disease is not fat embolism, it is fat embolism syndrome. Option number A is not the correct answer. The main aspect or pickup point of this MCQ is PO2 FiO2 ratio. PO2 FiO2 ratio normally should be more than 500. Write this once again. normal PaO2 FiO2 ratio should always be turning out to be more than 500, or like most of the time it is like higher than this, but if it is less than 300, that is one of the diagnostic features for ARDS in a patient. Any value less than 300 is a feature that we encounter for acute respiratory distress syndrome, plus we are having bilateral infiltrates. So the correct answer for this one would be non-cardiogenic pulmonary edema. Option number B is embolism or clots into pulmonary artery. In that we'll be having is this Hampton hump. If in this question in the X-ray there was a triangular wedge-shaped opacity, then we would have third in terms of a Hampton hump. That would be embolism or clots into pulmonary artery, where there's a a triangular area of a wedge-shaped infarction seen because there's a clot which is occluding the pulmonary artery. Aspiration pneumonia can occur in both in any patient, but considering that he is specifically mentioned regarding any critically sick patient can have aspiration pneumonia. But then considering that he's mentioned PO2, FiO2, he's mentioned polytrauma patient. So I'll first think in terms of ARDS. So pretty close options in this one. The answer is C. फैट एम्बोलिज्म में यार अगर एक्सरे होता भी है ना, अगर मैं इसको फैट एम्बोलिज्म सिंड्रोम भी लिख दूंगा, तो फैट एम्बोलिज्म सिंड्रोम में जो एक्सरे होता है दैट वुड बी हैविंग दैट मिलरी पिक्चर. That would be that multiple white spots in both the lung fits that can be free. X-ray can be normal in cases of fat embolism, or it can be showing multiple white spots in this patient. And acute pancreatitis, the reason is the inflammatory, the pancreatic enzymes are leaking into blood circulation. Normally, amylase lipase do not, there's the limited amount of those enzymes in the blood circulation, but those pancreatic enzymes are now present in blood circulation, so they cause damage to the lung also. They cause lung damage to the blood vessels of the lungs, and the damage to the blood vessels of the lungs by products like trypsin, etc., they can cause the blood vessels to become leaky. And because the blood vessels of the lungs are becoming leaky, that's why there is a non-cardiogenic pulmonary edema in the patient. Yeah, capillary leak due to multi-organ dysfunction is another way to put it. Moving to the next question. Correct about first degree heart block. The PR interval in this case would always be more than 200 milliseconds. This is not to be mixed with the Mobet's 1 heart block. You guys can comment regarding the answer in this question. Correct about first degree heart block. Yep. Prolonged PR interval, yeah, and there would be a normal RR interval in a patient. So this would be option number C. Unequal number of P waves and QRS complex would be third degree heart block. That would be, I'll be showing you ECGs of the same also in like a couple of minutes from now, but then you need to be patient for that. Then is normal PR interval of missed beats. That's gonna be seen with Mobitz 2. And serial prolongation of PR interval with missed beats is a feature of Mobitz 1. So yeah, also called as Stokes-Adams syndrome. Fatima, you are right. And FMG January. Okay. Prolonged PR. This came in NEET PG also. उसमें value पूछा था ना, PR interval 210 milliseconds, and what is correct? Prolonged PR with normal RR interval. That is value there. 210. He said interpret what is correct, and that would be first degree heart block. Okay, answer to 19 is option number C. Wenkeback is a term for Mobitz 1. Na? Wenkeback is a term for Mobitz 1 heart block, Wenkeback phenomenon. Okay. Young athlete went for testing for a competition and found to have hypertrophic cardiomyopathy. You can see that helter-skelter appearance or the crisscross appearance of the myocytes. That's again a very classical finding that you get on a postmortem biopsy in this patient or cardiac biopsy. He says which of the following will be increasing. Hypertrophic cardiomyopathy तो लिखा ही हुआ है ना, तो उसने बोला कि which of the following will increase the intensity of murmur in this condition. So all murmurs decrease with Valsalva, standing and amyl nitrate except HOCM. Your answer in this question is option number B. Normally क्या होता है कि Valsalva maneuver के साथ में the murmur should be decreasing in intensity. That is the statement that I say always. I'll just repeat it once again, that all murmurs will decrease with respect to Valsalva, and with standing and amyl nitrate, the logic or rationale for that is going to be कि जो venous return to the heart होता है वो less हो जाता है. But in hypertrophic cardiomyopathy, because there is a gradient in the heart, because of that gradient, the behavior will be opposite of what will happen in normal physiology. All murmurs decrease with Valsalva, standing and amyl nitrate except for hypertrophic cardiomyopathy and mitral valve prolapse. Yes, Sachin, you are spot on in picking up that aspect. Okay, So this was again a very standard one-liner question of NEET PG. हाइपरट्रॉफिक कार्डियोमायोपैथी पूछना ही है उसको, वो सडन डेथ करके नहीं पूछेगा, तो वो मर्मर इंटेंसिटी के बारे में पूछ लेता. तो मर्मर दैट वी टॉकिंग अबाउट इन दिस केस इज अ इजेक्शन सिस्टोलिक murmur because there is a subvalvular aortic stenosis, so the intensity of the murmur will become more louder. I mean the noise that is created would be increased. Diuretics are contraindicated in cardiomyopathy in a sense that all cardiomyopathies will be having hypotension now. So if I'm gonna give drugs to this patient, they can lower the blood pressure. So I can be using low dose spironolactone in very judicious usage, but routinely, like if I give any medicine that will lower the BP, it would not be recommended. Yes, propranolol is the drug of choice ना. Hypertrophic cardiomyopathy में diuretics नहीं देते ना. The drug of choice for hypertrophic cardiomyopathy is propranolol. It is like why we give beta blockers is because that will decrease the oxygen consumption of the heart rather than giving rather than giving diuretics to the patient. Okay. No. At the moment, I think you have to run a cycle on rapid revision only. Otherwise, it will become too much to remember. Okay, Ji. So we are going to discuss 6 ECGs here quickly, and I want you to quickly comment in the ECG. Yeah, pulses bis variance is a good answer for this one. I'll mention the pulse examination finding of this patient also. That's what they love to ask. ABCD of the pulse, alternance, then bis variance. So pulses bis variance is a pulse finding that is seen in hypertrophic cardiomyopathy. Okay. We look at the first ECG that is given, and you can check out that there is a variable error interval in a patient and there is absence of P waves. So since I don't have a P wave, I can be sure about the first case with irregular error interval, that is going to be atrial fibrillation. For any tachyarrhythmias, yeah, septal ablation and implantable cardioverter. The main treatment would be implantable cardioverter defibrillator. डॉक्टर तिशा, यू मेंशन रिगार्डिंग सेप्टल एब्लेशन प्लस आईसीडी. वो सेप्टल एब्लेशन पेशेंट करवाने के लिए रेडी नहीं होगा ना, बिकॉज दैट वुड बी अ लिटिल, आई वुड से, इन्वेसिव प्रोसीजर. सो मोस्ट पेशेंट्स वुड बी कंफर्टेबल विद द implantable cardioverter defibrillator. So we'll select the one which will be having the least, I mean, acceptability on the part of the patient. In the second ECG, you can see the sawtooth waves which are present. That would be atrial flutter. So that's the easy one. In the third ECG, you can notice that there is a reduced RR interval, that is obvious. Along with reduced RR interval, the P and the T cannot be seen separately. Normally, if P and T can be seen separately, then I will say sinus tachycardia. But if I zoom into this ECG, you can see that there is hidden P waves. Considering that there is hidden P waves because they are buried in the P, then I would think in terms of a PSVT, that is a paroxysmal supraventricular tachycardia. That is also written as AVNRT, AV nodal reentrant tachycardia. It's a macro re-entrant circuit. Na? In atrial flutter, it's a macro re-entrant circuit around the cavo-tricuspid isthmus. Atrial fibrillation treatment algorithm I've already mentioned. I'll say this once again. Atrial fibrillation, if they ask you acute onset atrial fibrillation, you can give a DC shock. Don't give it in chronic or long-standing atrial fibrillation because clots are there. Then first anticoagulate and then be deciding for rhythm control in a patient. Okay, let's okay, since you are putting it up here, I am putting a question before you. If a person is having recurrent episodes of atrial fibrillation, what is the best management for this person? Person is having recurrent episodes of atrial fibrillation. Can you tell me any treatment strategy that can be used for this patient? It can resolve by itself also, doctor. PSVT can resolve by itself. Yes. Atrial fibrillation can be resolved by two methods. One is catheter ablation. But apart from catheter ablation, another strategy for recurrent can be ICD, implantable cardioverter defibrillator. So there are two operations which can help us. One is catheter ablation. That's a good answer. Catheter ablation for recurrent atrial fibrillation in a patient. Otherwise, we can go in for implantable cardioverter defibrillator for the person. In atrial fibrillation, I repeat once again, if there are clots, don't give DC shock. We can give DC shock only in acute onset atrial fibrillation, not in chronic onset, because there, if you give, then the clots will go into the brain circulation of the patient. Okay, fine. Let's move on to the next one. In this particular ECG, the problem is that the RR interval of the patient is again changing. There is a variation in the RR interval of this chap. And along with the variation in the RR interval, there is change in the height of the P wave also. Like I'm putting red pointers to the variation in the height of the P wave. This is like a very small P wave, a very tall P wave, and then it's literally coming inverted. Here it's almost coming inverted P wave, right? I mean, if you focus on this box, I have zoomed it in, so I think the resolution is pretty decent. Okay, I'll just mark it here also. So you can see that because there is a varying morphology of the P wave in the patient, the answer in this case will vary. The answer in this case would be given as multifocal atrial tachycardia, MAT. Yes, COPD is the reason for it, and you guys can help me with the drug of choice for multifocal atrial tachycardia while I describe the next one. The next one is broad RS complex tachycardia. You can see that R, what is going up is R, what is coming down is S. And you can see that it's really, really broad. I mean, almost going up to 1 large square in a patient, the R and the S. So that broad RS complex tachy is there. That's gonna be VT. Yes, I think I got the correct answer from majority of students. Most doctors have answered that correctly. For multifocal atrial tachycardia, it is verapamil that would be used. Monomorphic ventricular tachycardia, the preferred drug to be used is amiodarone. So if it's a crashing patient, then it's always going to be DC shock that would be administered to the patient. It is R and S waves, broad RS complex tachycardia. Okay, the answer for this is amiodarone in case it is structural heart disease that is present in the case. Moving ahead, the next question is on a bradycardia component, and you can notice that the PR interval of the patient does not change much, almost remains the same, and then there is like P followed by a drop, and then the same thing is continuing once again also. Whereas in the inferior one, if you look at it, you will notice that there is a drop occurring in this one also. Yeah, so yes, first one, I think because both are being mentioned by the patient, you can mention each one of them individually. You can notice the PR interval of the patient is constant and then there is a drop, whereas in another one, you will notice that the PR interval of the patient. Okay, even in this one, no, a drop happening. Okay, yes. So the main thing which I want to bring to your attention for the second one is this is an interesting one. This is a differential diagnosis of Mobitz 2. In fact, let me just write down the name first. Okay, Mobitz 2. This is perfectly fine. What you can see is a Mobitz 2 heart block, easy to identify, simple and straightforward. The PR interval before the drop and the PR interval after the drop is equal. That's why we're gonna call it a Mobitz 2 heart block. And in the second one, what I can say is that there are drops occurring in a patient, but then you can see that it's like P wave not being conducted. This P wave is not being conducted, right? Not conducted. Yes. Okay. Yes, so goes more in favor of like, 2:1 or a differential that I can say that the P wave is not getting conducted in this person. That is like more a logical statement I can say like one P wave, this P wave is being conducted where I put the star mark, the P wave is being conducted, but then the P wave is not getting conducted. So that would be a differential diagnosis that would come up and that would be called as a 2:1 block. This was like that initial question, I think, and that's why I wanted to give you a bit of more time to analyze this in the patient. Uh, the main point is like Mobitz 2 and 2:1 block will always be having two close aspects, and the one that I've highlighted at the moment is conducted and non-conducted waves occurring alternatively, which makes the answer a little different. Okay, moving to the next one. Karan, you will notice that there would be alternative, like PR interval will be constant. The drops may not be on a regular basis. The drops may occur intermittently in both Mobitz 1 and Mobitz 2. We cannot say that in none of the heart blocks, the drops occur on alternate basis. The drops would always be occurring intermittently. That's one thing that I've always highlighted. And therefore, every time you get a PR interval constant, always check out whether it's alternative conduction and non-conduction that is happening. Okay, moving to the next one, a patient with shortness of breath, vitals are 120, BP is 120 by 80, and echo shows diastolic collapse of the right atria. So, collapse of the right atria is telling me that the process of cardiac tamponade is starting in this case. At the moment, the BP is 120 by 80 because only atria are getting compressed. So, this presentation is of low pressure cardiac tamponade. Very soon, the person will deteriorate and the BP of this person will crash. But currently, like we have done an early diagnosis, why the BP is normal, because tradition, if I would have straight away said the word cardiac tamponade, the query of everybody would have been that, sir, how can it be cardiac tamponade with BP of 120 by 80? It's a low pressure cardiac tamponade at the moment, and that is why in this particular case I want to preempt and prevent the crashing, and therefore the best management for this patient would be given as pericardiocentesis. Initially, I thought it is a question that could be going into cardiogenic shock, but then the blood pressure was very decent. So that is why like intra-aortic balloon pump is always used whenever there is a cardiogenic shock. The word is shock, right? The BP should be unrecordable. But in this case, like there is no unrecordable blood pressure. So what we have to understand is that this is a preemptive step that I'm taking, because very soon the person will deteriorate from low pressure cardiac tamponade into cardiac tamponade. That's why pericardiocentesis would be present. ब्रोकन हार्ट ईसीजी विल बी सेम एज दैट ऑफ एसटी एलिवेशन एमआई ना, टाको-टसुबो कार्डियोमायोपैथी में जो ईसीजी होता है, दैट ईसीजी इज सेम एज दैट ऑफ एसटी एलिवेशन मायोकार्डियल इंफार्क्शन, and even the biomarkers in the patient are elevated. So a wrong diagnosis can be made of that. That's a query that came in the chat, so I'm answering that. टाको-टसुबो कार्डियोमायोपैथी में ईसीजी में एसटी एलिवेशन होगा, बायोमार्कर्स एलिवेटेड होंगे. So you will misdiagnose this case as ST elevation MI and take him in the cath lab. But cath lab में लेके आएगा तो cath lab में जाके we will be able to notice that the coronary artery anatomy of this person will be perfectly normal. And that is when the diagnosis of Takotsubo cardiomyopathy is suspected, because the coronary artery flow is normal. Now you will be doing a bedside echo, and the bedside echo will be showing that bulge of the apex of the left ventricle, which looks like a head of an octopus. So that's where the apical ballooning would be occurring. And that is when most of the time the diagnosis of this patient is made, and then we'll abort the PCI procedure and we'll manage the patient conservatively. It is catecholamine toxicity. So Takotsubo cardiomyopathy or broken heart is what I have mentioned at the moment. Takotsubo cardiomyopathy or broken heart is not diagnosed in the is not diagnosed in the casualty, but only in the cath lab, when the cath lab is showing a coronary artery flow to be normal. That's when the differential would be made. Okay, so doctor, I think that emotional distress is the predisposition. You'll talk about like a fight or death of a loved one. That's when this would happen. Shortness of breath. Dr. Thakur, can you rephrase once again? Shortness of breath in a person. You mean pulmonary edema? That will worsen over a period of time. Like, initially you'll get up in the bed, then walk to the window, open the window, breathe, hyperventilate in pulmonary edema. Then subsequently, like even lying in the bed or changing clothes will cause breathing difficulty. Okay. Next best step in a management of a patient of a pulseless VT. The question is on PVT, and he says what is to be done. So we anyway have to defibrillate. And after defibrillation, the next step which is to be done in the patient is CPR only. That is what he has asked here. That in PVT, what is the step to be done? It is CPR, and then it is continue chest compression. That's the standard statement that is done every single time. Okay, we'll not give synchronized DC na. Like D also came up in the chat, so I'll just say synchronized DC shock to baki sab mein dete hain na. Synchronized DC shock is given in like pulseless ventricular in PSVT or atrial fibrillation or atrial flutter, but here it is defibrillation only. Why BP is that is because doctor, it's a low pressure cardiac tamponade. Na low pressure cardiac tamponade में सिर्फ atria get compressed, so only like at the moment the filling of the blood in the ventricles is little compromised, and how's the BP maintained is because of the tachycardia component. Low pressure cardiac tamponade, I agree, will cause low BP, but sympathomimetic stimulation will result in that blood pressure values to be hitting like towards normal only, but the preemptive action had to be done because there was a collapse occurring in the atria. Yeah, there is no R wave present here. Yeah, there is no pulsus paradoxus in cardiac tamponade. That's the point ना. Pulsus paradoxus नहीं है तो बीपी तो यार normal to low हो सकता है, but unrecordable नहीं हो सकता ना. There are two diagrams that I have made while describing cardiac tamponade. One is low pressure cardiac tamponade, and second I'm saying unofficially high pressure cardiac tamponade. Meaning of the word high pressure is that the atria and ventricles both will get crushed, and if it's low pressure, then only the atria will get crushed. Okay. Moving to more classical ones, what is the leading cause of absent white descent? Ajay, you are right. What is the leading cause of hypercalcemia in a hospitalized patient? Is it parathyroid adenoma? Yes, guys. Hypercalcemia in a hospitalized patient. Chest compressions, Dr. Mani Babu, patient has PVT like most of the time in our government hospitals, not with that defibrillator may not be available anyway. So chest compressions are straight away. Don't answer check pulse, just answer CPR to be given. Checking pulse would be a waste of time if ECG is showing a VT and the patient's BP is crushing on the display, or you physically checked. I mean, if the BP is not recordable, that means there would be no pulse. So searching for pulse would be a waste of time. So that's why straight away CPR would be done in those circumstances. Still you get a DC shock because that's the only way to save that guy. हाँ हाँ, कौन सा malignancy बताओगे ना? Your answer would be malignancy, and your answer would be that this could either be lung cancer or it can be breast cancer. You guys can help me. Which lung cancer, small, squamous, adeno, and large, is responsible for causing hypercalcemia? Yeah, hospitalized may it is malignancy that would be responsible. Lung cancer, the one that is responsible is squamous cell cancer of the lung. It is squamous cell cancer of the lung that would be answered. And in both of these conditions, there is release of PTH-RP, that is parathormone related peptide, which is not going to be PTH but will look like PTH, and that is why it will cause a spike in calcium of these patients. So it's squamous cell cancer. Next is two causes of steroid responsive hypercalcemia. You guys can help me out with it. Leading cause of hypercalcemia is malignancy. And the malignancy can either be lung cancer or can be breast cancer respectively. That would be squamous cell causing PTH-RP. Yes, one of them is vitamin D toxicity. That is one possibility for steroid responsive hypercalcemia. Any more common ones? Steroid responsive hypercalcemia, sarcoidosis. Yes. Sarcoidosis, vitamin D toxicity, and multiple myeloma. These are three examples of steroid responsive hypercalcemia. Sarcoidosis, vitamin D toxicity, and multiple myeloma are three causes of steroid responsive hypercalcemia in a patient. For hypocalcemia, it is that thyroid surgery thing ना, but अभी तो हम hypo तो पढ़ नहीं रहे ना, अभी तो हम hyper पढ़ रहे. Yes. No, acromegaly is unlikely to cause PTH production, no. मोस्ट कॉमन कॉज ऑफ डेथ इन इडियोपैथिक पल्मरी फाइब्रोसिस, जितने भी लंग डिजीजेज होते हैं सभी में जो कॉज ऑफ डेथ होता है दैट वुड बी रेस्पिरेटरी फेलियर. And after respiratory failure due to pulmonary artery hypertension, there are two reasons why you would be answering it. Primary answer is respiratory failure. Second would be pulmonary artery hypertension for all lung diseases. That's a universal thing that would be happening: respiratory failure and pulmonary artery hypertension. Okay, so somebody was talking about acromegaly. Here it is, that patient having large sweaty hands and feet, or you might write the word spade-like hands. And then he will say thick palms and soles in this chap. Macroglassia, gap in the central incisors. So that is where the question is regarding acromegaly. And he's saying like, what is the investigational choice for diagnosis of this condition? I'm getting varied responses, guys. I hope you are reading it carefully. In all cases of acromegaly, we'll do a test called as glucose challenge test. And in glucose challenge test, there would be failure. Like we will make the patient do, we will make the patient drink 75 gram of glucose, and we will be having failure to suppress growth hormone levels. The values will always remain like more than 0.4 nanogram. The failure to suppress growth hormone levels, which would remain permanently more than 0.5, 0.4 nanograms, despite 75 grams of glucose challenge that has been given to the patient. In a normal individual, when you give a glucose challenge, it can cause a suppression. Between B and C, I think a lot of guys are answering this question from the screening perspective. Like another additional thing to be done by you after you've done the list of investigation choice in endocrinology is to work out the screening test for these conditions as well. So if we say screening test, then it is IGF-1, and if it's gonna be like the investigation choice, then it is a glucose challenge test that would be done. Shailesh, that arginine challenge test is done for hypopituitarism. That arginine challenge test is done for hypopituitarism. That's the opposite now. That is arginine challenge test. Earlier we used to do insulin challenge test. Now we do arginine challenge. So I'll just write it here because that came up in the chat. If he's gonna be talking about decrease of growth hormone in a patient, that would be written as hypopituitarism. Hypopituitarism implies deficiency of growth hormone. If I say pan-hypopituitarism, then all the 6 hormones are less, like in Sheehan syndrome. So that is where in hypopituitarism, we'll be doing a arginine challenge, or we'll be doing a insulin challenge test. Not a problem. The screening part in the investigation, I have made a list यार, खुद ही तो लिस्ट बनाई है ना मैंने. For each one of them I made a invest. पहले तभी तो मैंने बोला दो अलग अलग करना ना. पहले अगर हर डिजीज का दो दो इन्फॉर्मेशन याद करोगे तो याद ही नहीं होगा. वन ऑप्शन इज कि सबका पहले आप इन्वेस्टिगेशन चॉइस करो. दैट इज व्हेन यू डू द स्क्रीनिंग टेस्ट. अदरवाइज तभी तो गलती होता है ना बेसिकली. तो इट इज़ लाइक आई मेड अ लिस्ट इन माई ओन हैंड राइटिंग इन द टेबल, बिकॉज मैंने वो सारा प्रैक्टिस किया हुआ एक बारी खुद से. बट यू नीड टू डू दैट इन योर ओन हैंड राइटिंग, बिकॉज यू गाइज हैव दैट सॉफ्ट कॉपी ऑफ द नोट्स एक्सेट्रा और PDF. बट दैट जब तक आप अपने हाथ से नहीं लिखते हो तो इट इज़ नॉट गोना लाइक वर्क द सेम वे. Yeah, both arginine and insulin, they normally cause like stimulation of the growth hormone, but in this case, the stimulation will not happen because there's a pituitary damage or there's a pituitary developmental defect in hypopituitarism. Okay, next is the star of death, spotter that you can pick up, star of death. Very classical image. In the actual exam, it was not exactly a star. It looked more like a spider, like you can see here. No? It looked more like a spider, you can see. And then he also helped by describing that there is a berry aneurysm which has probably resulted in this manifestation. Yeah. He's not asking the diagnosis. I mean, I put the star of death before you. It looked more like a spider in the actual exam. He said like, what is the treatment or choice for this condition? And I've hinted you with the image also. We'll be doing a coiling of this aneurysm so that it does not re-bleed in again. So the answer for the treatment of choice for this Potter answer would be given as endovascular coiling. We will do a cerebral angiography, that is the invasive cerebral angiography in this patient. First test to be done in this guy is a CT scan. And after a CT scan, the next thing to be done would be a cerebral angiography. This would help us identify where is the berry located, and because this will be having a high chances of re-rupture, that is why, or re-bleeding, that we want to do a endovascular coiling in this patient. Even if nimodipine is given in the question, even then the answer is given as endovascular coiling. Even if the BP of these patients will be elevated. In this MCQ, deliberately the blood pressure value will be elevated. Do not lower the BP of the patient, because that if you lower the BP, it will decrease the cerebral perfusion. If you lower the blood pressure of the patient, it is going to decrease the cerebral perfusion of this patient. That's what I've highlighted. I'll do it once again. It looked more like a spider, as you can see, rather than a star. But anyway, that's the point that I wanted to bring to your attention. And even if the BP is elevated, don't try to lower the BP, because you will lose the cerebral perfusion pressure of this patient. So nimodipine is like to prevent the subsequent vasospasm that would be occurring, but initial treatment is endovascular coiling. Next is the spot diagnosis. You can pick up that I can call it a crescentric hypodensity. If I say anything more, the answer will become obvious. So you can help me out here. Yes, this is a crescentric hypodensity present. Yes, and this is left and this is right. So your answer would be, the patient of mine is having a right-sided chronic. I'm calling it chronic because it's appearing black in color, and there would be chronic subdural hemorrhage. And like he has asked the treatment of choice, so actually you should be mentioning the treatment of choice spot on. Craniotomy is there and burr hole surgery is also there. So what would be recommended? Why nicardipine is not given in nimodipine subarachnoid hemorrhage? Because we don't need to lower the blood pressure. ना berry aneurysm में nicardipine या nimodipine मतलब निमोडिपिन जो होता है उसका सिलेक्टिव एक्शन होता है ब्रेन की ब्लड वेसल्स पे, तो वो प्रेफर करी जाती है। निकार्डिपिन तो ब्लड प्रेशर लोअरिंग के लिए देते हैं ना। तो सबरेकड हेमरेज में तो कोई बीपी लोअरिंग की जरूरत नहीं है ना। सबरेकड हेमरेज इज बैरियरिज्म विच इज अ स्ट्रक्चरल एबनॉर्मेलिटी, तो उसमें बीपी लोअरिंग करने की जरूरत ही नहीं होती। सर क्रॉनिक सबड्यूरल हेमरेज है ना, क्रॉनिक सबड्यूरल हेमरेज में क्रेनियोटमी नहीं करेंगे सर। It is a burr hole that would be done, and along with burr hole, we'll be putting drains. So burr hole surgery with drains would be put in this patient. Yeah, we are just neutralizing the vasospasm. That's all. We are not treating, trying to lower the blood pressure of a patient. In chronic subdural hemorrhage guys, the treatment choice is burr hole surgery with drains. इसको एक बार देख लेना, मतलब जो एक्स्ट्राड्यूरल हेमरेज होता है EDH, extradural hemorrhage में it is decompressive hemicraniectomy that is to be done, or a craniotomy, and along with craniotomy the answer for treatment of choice is ligation of the bleeder. The bleeding would be from the middle meningeal artery, so without the ligation of the bleeder it will not work. If he says acute subdural hemorrhage, then again in this case the answer would be given as craniotomy. And in chronic subdural hemorrhage it is burr hole with drains, because otherwise that gel wala blood jo hai, because it's chronic now, so the blood would be in a gel shape, so it's gonna like clot. So burr hole and drains would be required so that we can handle the chronic subdural hemorrhage. Just check it out from your surgery notes as well, as far as the treatment part for the various types of CNS bleeds are given. Advanced stage treatment choice of ischemic stroke, patient is above the window period. We can do, not a problem. Patient is out of the window period. We will not do thrombolysis. Na? We'll do mercy, thrombectomy. Even if the patient is the advanced stage, even like 80-year-old man, we can be doing a thrombectomy in a patient if his patient is outside the window period. हाँ कंजर्वेटिव करते हैं अगर वो स्मॉल है ना, ये तो लार्ज है ना, आप देखो ना इतना बड़ा ब्लीड है, उसने ब्रेन को इतना दबा दिया है। Frontal lobe is also compressed, temporal lobe is also compressed, occipital lobe. So it's a large hematoma, na? It's a large hematoma in a patient. So it will be creating symptoms in a patient. So अगर वो conservative है, डार्क है इसलिए क्रॉनिक है, और क्योंकि यहाँ पे तो लार्ज ब्लीड है ना, तो लार्ज ब्लीड में तो कंजर्वेटिव का रोल नहीं है. बेसिकली यू मॉनिटर द GCS ऑफ अ पेशेंट. सो ऑल द थिंग्स दैट हैव सेड इज फॉर फास्ट फॉल ऑफ GCS. यहाँ पे लाइक इन ऑल द सिचुएशंस दैट आई मेंशन्ड, the intervention that would be done is based on GCS fall. अगर वो पोस्टरिंग लिख दे फिर तो EDH में भी बर होल कर देंगे. अगर वो बोलता है कि EDH का पेशेंट है एक्स्ट्राड्यूरल हेमरेज का, उसको पोस्टरिंग हो रही है, डीकॉर्टिकेट डीसेरिब्रेट, तो बर होल तो इज अ टाइम बाइंग प्रोसीजर. मेन ट्रीटमेंट वुड बी क्रेनियोटमी विद लाइगेशन ऑफ ब्लीडर, बट टू मेक हिम सर्वाइव इनिशियली बर होल कर सकते हैं. But then this all the situations are for like fast evolving GCS in a patient, and lucid interval is seen in both of them. Lucid interval is seen in EDH also, and lucid interval is seen in acute subdural hemorrhage also. Okay, next case, the guy was like T-bone accident, like the car was jumping a red light, and this guy had these punctuate bleeds. As you can see, the MRI head in this, the CT scan in this patient shows multiple punctuate bleeds. Yes, there is multiple punctuate bleeds which are present, and the multiple punctuate bleeds are present at the junction of the gray matter and the white matter. Gray matter is outside and white matter is inside. So multiple punctuate bleeds at the junction of the gray and the white matter is gonna be the answer in this case. Yes. The first answer of mine would be TAI. TAI stands for traumatic axonal injury. The first answer of yours is TAI, that is traumatic axonal injury. अब डिफ्यूज बोलना है या नहीं बोलना है, तो डिफ्यूज के लिए हम काउंट करते हैं कि कितने ब्लीड्स हमें दिखाई दे रहे होते हैं. अकॉर्डिंग टू हैरिसन वो बोलता है कि अगर आपको 4 से ज़्यादा ब्लीड दिख रहे हैं, जैसे एक हो गया, 2, 3, 4 और उसके ऊपर भी आ रहे हैं, सो हाँ हाँ वो तो ठीक है शैलेश, बट वही तो बोल रहा हूँ ना, GCS तभी तो फॉल करेगा ना, यही तो बोल रहा हूँ कि एक्यूट सबड्यूरल हेमरेज में कंजर्वेटिव नहीं, SDH में कंजर्वेटिव ही होता है. अगर GCS फॉल कर रहा है तभी तो ऑपरेशन करेंगे ना यार, अदरवाइज तो कोई रोल ही नहीं है ना. तो वो डायग्नोस्टिक क्राइटेरिया है ना उसका, लार्ज ब्लीड है तो वॉल्यूम यहाँ तो हो गया ना, जैसे आपने बोला थिकनेस ऑफ हेमाटोमा, तो ये मोटा हो गया ना हेमाटोमा, ये देखो दिस इज अ बिग बिग हेमाटोमा, इट्स अ बिग थिकनेस विच इज प्रेजेंट, तो वही हो गया ना, दिस दिस कैन नॉट बी कंजर्वेटिव ना. इफ यू लुक एट द साइज ऑफ ब्लीड, आपने जो क्राइटेरिया मेंशन किए जो सर ने आपको बताया वही वाले क्राइटेरिया तो यहाँ पे भी सेटिस्फाई हो रहे हैं ना. यू कैन सी दैट ह्यूज ह्यूज बिग ब्लीड प्रेजेंट. थिकनेस ऑफ दिस, आप वाइडस्ट डायमीटर पे देखो तो अब यहाँ पे स्केल से तो मेजर नहीं करेंगे, बट ये तो दिस इज लाइक ऑलमोस्ट 1 इंच जा रहा है, 1 सेंटीमीटर भी नहीं मैं बोल रहा. दिस इज गोइंग अप टू लाइक ऑलमोस्ट अ इंच और सो. So that is why in this patient the GCS was falling, and that is why the intervention of the patient has to be done. Okay. मूविंग अहेड, अगर 4 से ज़्यादा ऐसे पंक्चुएट ब्लीड्स दिखते हैं, मोर देन 4 सच ब्लीड्स प्रेजेंट, देन वी विल कॉल इट डिफ्यूज एक्सोनल इंजरी. सो द टेक्निकल आंसर इज ट्रॉमेटिक एक्सोनल इंजरी. कंजर्वेटिव मैनेजमेंट वुड बी डन, and to call it diffuse at least 4 or such 4 bleeds would be present. Yeah, we can do a MRI also, but वो तो तभी करेंगे ना अगर if CT scan is normal. Like, when do we answer MRI in this case? The MRI to be answered is only if the bleeds are very very small and are not visible. I mean, if the non-contrast CT head of the patient is perfectly normal because the bleeds are very chota, that is when we'll do a MRI in this case. Otherwise it does not make sense to do, because अगर bleed दिखाई दे गया फिर तो कोई दिक्कत ही नहीं है ना. Then if it's punctuate bleeds, micro bleeds, that is when we'll be going ahead with MRI in the case. Okay, so these are like spotters that are always given in the brain. Then is extradural hemorrhage. You can see that it would be biconvex. So he will always say the word lenticular. पिछली बार मैंने crycentric बोला था, इस बार lenticular है, and because it is hyperdensity. So he will say what is the treatment to be done in this case. The treatment is a craniotomy along with ligation of the bleeder, as has been highlighted on the previous slide. No, this would not be bridging veins. This time it is middle meningeal artery. The bleed, the cortical bridging veins are here. This is the site where we were talking about cortical bridging veins, and he'll always give history here. Like यहाँ पे हमेशा deterioration होती है, and deterioration would be like a gradual onset deterioration. Like person fell in the bathroom and then there's a gradual deterioration, forgetfulness, irritability, incoherence. Those are the kind of features that would be present. The features would be like जो patient बोल रहा है यहाँ पे, जैसे ऋतिक रोशन के केस में था ना, उसे सबड्यूरल हेमरेज हुआ था, तो वो मतलब आवाज़ में थोड़ा चेंज आया होगा, तो डायलॉग डिलीवरी में प्रॉब्लम हुई होगी, तो लॉस ऑफ कोहेरेंस, and along with that irritability, drowsiness, and all these things would be after few days of a fall. The main point is all these manifestations will be present after a fall. That fall may have occurred like couple of days back, and these are the features that would be seen for subdural hemorrhage. लूसिड इंटरवल दोनों में होता है, तो लूसिड इंटरवल से सॉल्व नहीं करते हैं. नॉर्मल प्रेशर हाइड्रोसेफलस मैं अभी नीचे मेंशन कर देता हूँ यहाँ पे. आई डेडिकेट वन स्लाइड टू नॉर्मल प्रेशर हाइड्रोसेफलस इन फ्यू सेकंड्स. Burhole surgery is to be done if he says ADH patient is having posturing. And I called up the neurosurgeon. उसने बोला कि सर अभी तो मैं OT में अवेलेबल नहीं, अभी मैं OT में बिजी हूँ और मुझे आने में आधा घंटा 1 घंटा लगेगा. By that time the person can deteriorate very fast. The GCS of the patient will fall. So in those cases, like the role of burhole also comes in ADH with posturing as well. Otherwise, like if there is no posturing present, we'll take up the patient subsequently for craniotomy. Axonal injury is conservative ICU care only. Like there is no definitive treatment for those punctuate micro bleeds ना, because वो concussion जब गाड़ी पे hit मारा ना उसको बीच में, तो पूरा सिर हिल गया. He was using the seat belt, and apart from using the seat belt, the guy was even like airbags were deployed because it was a good quality car. So the airbags got deployed and the seat belt was very much, he was secured in the seat belt. But that violent concussion, एकदम से गाड़ी जोर से impact हुआ था. Violent concussion on the head is causing a shearing stress on the axon. So on that there would be no definitive treatment available. So I hope that answers your query that came up. Okay. So between the two answers, this is craniotomy to be answered with ligation, and burhole is only in case of a posturing, as I mentioned, for extradural hemorrhage. Okay, NPH. We'll do a quick slide on NPH, and then we move on to our next question. Normal pressure hydrocephalus can be remembered by wet, wacky, and wobbly. Wet, wacky, and wobbly. And if you don't want to remember that wet, wacky, and wobbly, then there's another mnemonic that I can mention before you, that is AID. So A would be for ataxia, or they would be gait abnormalities. I'll tell you the reason for that gait abnormalities also once I'm done with the mnemonic. या वेट वैकी वॉबली इज वन तरीका, या एड से कर लो, बिकॉज वो एमसीक्यूज में, हमारे वाले एमसीक्यूज में तो वो अमेरिकन वाले जैसे वो वैकी वैकी वर्ड लिखता नहीं है ना, So it is incontinence of urine. I'll tell you the reason for the same. And then is the development of dementia in this patient. Yeah, we call it Hakim's triad. So AID is a mnemonic that can help you to remember this. Now I'll tell you the reason. In normal pressure hydrocephalus, there is a distension of the ventricles. So वो जो ventricular dilatation होगा, that ventricular dilation that is happening in this condition will cause dissipation of pressure. तो pressure तो normal हो गया, क्यों? क्योंकि ventricles dilate कर जाएंगे तो pressure dissipate हो जाएगा. Physics I'm saying volume is the ventricles are getting dilated, so pressure is getting is gonna be like dissipated. And the ventricular dilatation will mainly cause damage to the frontal lobe, and frontal lobe जो होता है वो it plays a role in gait, and it also plays a role with respect to paracentral lobule. Paracentral lobule is an area related to the frontal lobe that is responsible for bladder continence in a patient. So because of the damage to the frontal lobe and paracentral lobule, urinary incontinence will occur. And similarly, you could be having is a gait abnormality in this patient. The gait abnormality will mostly be in the form of a magnetic gait. The person will walk as if the feet are stuck to the ground. The gait abnormality can be like as if the patient's feet are stuck to the ground, that is magnetic gait. And there would be dementia because the ventricles जब वो dilate करेंगे तो they will press the gray matter against the calvarium. When the gray matter is pushed against the calvarium, so dementia component will occur in this case. For treatment in this condition, we can be using Fisher test. Your question was difference from benign intracranial hypertension. In benign intracranial hypertension, pressure in the ventricles will be more, and here the pressure in the ventricles is normal. How can you differentiate between the two? You can do a Fisher test. Fisher test means that you will do lumbar puncture and you will remove 30 ml of CSF. And when you remove that CSF, then pressure on the frontal lobe is less. So the gait abnormalities will show a improvement in this patient. If we are having a gait improvement on a person who's having NPH, that gives more credibility to the diagnosis. And difference in benign intracranial hypertension is that that condition would be having increase in pressure in the brain. This is NPH, then is gonna be benign intracranial hypertension. And the third thing is hydrocephalus, which is seen in like tubercular meningitis. तो difference देख लेते हैं तीनों के बीच में with respect to the size of the ventricles and the pressure. Everything that I'm talking about here is with respect to the ventricles and the size of the ventricles. So when it comes to size of the ventricles in normal pressure hydrocephalus, the size would be increased and pressure is normal. In benign intracranial hypertension उल्टा होता है, pressure is more and the size of the ventricles is normal. और अगर दोनों दोनों बढ़ जाते हैं तो उसे hydrocephalus बोलते हैं. Benign intracranial hypertension का दूसरा नाम होता है सूडो ट्यूमर सेरिब्राई. मोस्ट स्टूडेंट्स को इन तीनों के बीच में कंफ्यूजन रहता है, लेकिन आई होप इस टेबल से क्लियर हो जाता है. Hydrocephalus is what you get usually with like tubercular meningitis में जो pus होती है, that will block the flow of CSF. So you could be having like a obstructive or a communicating hydrocephalus occurring where pressure and size of the ventricles both will increase. बट अगर सिर्फ प्रेशर बढ़ता है और साइज नॉर्मल रहता है उसे बोलते हैं सूडो ट्यूमर सेरिब्राई, और अगर सिर्फ साइज बढ़ता है प्रेशर नॉर्मल होता है तो उसे नॉर्मल प्रेशर हाइड्रोसेफलस बोलते हैं. तो ये डिफरेंसेस हैं जो मैंने यहाँ पर मेंशन किए हैं. And then most of the time normal pressure hydrocephalus is an idiopathic condition in which that manifestation would be occurring, which I've explained, that wet, wacky and wobbly scenario that I described before you. The wet is the incontinence, wacky is the dementia component, and wobbly is the gait abnormality that would be occurring. The mostly usually scenario for this would be vitamin A toxicity. So we need to stop vitamin A, or it can be sudden stoppage of steroids. I mean, there are multiple reasons why pseudotumor cerebri can occur. So in this condition, we need to stop the offending cause. And then initially, because the pressure in the brain is elevated, we can be giving mannitol to this patient. So for normal pressure hydrocephalus, the drug that we give is only acetazolamide. Whereas for patients of pseudotumor cerebri or benign intracranial hypertension, initially we might have to give mannitol to the patient also. Yeah, benign intracranial hypertension can be occurring in young female also. That is young obese female. One more scenario. Young obese female. Young female but would be grossly obese. That is another scenario that can be given. Three scenarios for benign intracranial hypertension: young obese female, sudden stoppage of steroids, vitamin A toxicity. And for hydrocephalus, we will be having for hydrocephalus in a patient, it is ventriculoperitoneal shunting, VP shunting. There is no rule of shunting. There is no rule of shunting with respect to the remaining two scenarios. But shunting is must for patients of Yeah, when I'm saying female, like OCP aspect can be present in a patient. So anytime he says young female obese, with or without usage of OCP, those are like the causes for the scenarios that I mentioned. Okay, so this table helps us differentiate between NPH versus benign intracranial hypertension, pseudotumor cerebri, and then hydrocephalus. And we are sorted for 34. So let's look at 35. This you guys can help me out. You can see a big bleed. The ventricles are hyperdensity. It's a ill-defined one. It is pressing on the same-sided ventricle also. So your answer would be given as intracerebral hemorrhage. And the leading cause for development of this would be intracerebral hemorrhage. And the leading cause for this would always, yeah, intraparenchymal is another one, Mukul, you're perfectly right. We can call it intraparenchymal or we can call it intracerebral hemorrhage. And the most common cause for this can be hypertensive crisis in majority of cases. That's the neurological emergency that I was talking about. Or it can be oral anti-clotting drugs overdosage or oral anti-clotting drug toxicity that could be responsible. It is for hypertensive crisis. For this neurological emergency, the drug that we'll be using is nicardipine. And that is what I had said in the initial part, that if he specializes or specifies the cardiac emergency, then it is going to be nitroglycerin with pulmonary edema. And if he mentions neurological one, then it is going to be nicardipine or labetalol, as the answer has been mentioned correctly. In this case, the answer is not lenticulostriate artery. I think this is what you meant. It is lenticulostriate artery की भी जो छोटी छोटी ब्रांचेस होती है ना, क्योंकि इट इज lenticulostriate artery खुद नहीं बर्स्ट करेगा, उसका जो आगे और छोटा छोटा ब्रांचेस होता है, दे विल बर्स्ट. सो द टेक्निकल आंसर फॉर वेयर व्हाट इज द सोर्स ऑफ ब्लीडिंग इन दिस केस, इफ यू से सोर्स ऑफ ब्लीडिंग इन इंट्रासेरेब्रल हेमरेज, देन इट इज बर्स्टिंग ऑफ द पेनिट्रेटिंग ब्रांचेस. It is penetrating branches of the lenticulostriate artery. एंड द मोस्ट कॉमन साइट इज ऑब्वियसली जहाँ पे लेंटिकुलर स्ट्राइट से पता चल गया कि कॉर्पस स्ट्रैटम की बात कर रहा है और पुटामेन की बात कर रहा है. सो द साइट वेयर इट वुड बी हैपनिंग, द साइट वेयर दिस वुड बी हैपनिंग is what you will answer as the putamen. So putamen is the most common site where this would be happening, and that's when the posterior capsule or the posterior limb of the internal capsule will get involved. I'll just draw that internal capsule here also. यहाँ से that internal capsule is going. So because internal capsule will get involved, that is why we will be having pure motor stroke developing in this patient of sudden onset. A separate question of pure motor stroke I'll just discuss in a couple of minutes from now. But at the moment, the main message is कि यहाँ पे, yeah, it is lacunar stroke presentation that we're talking. That is like the posterior limb of the internal capsule is the one that would be involved there. यहाँ पे face के fibers, arm के fibers, legs के fibers are the ones which will get involved, and that is why pure motor stroke would be occurring in these patients. So very classical presentation of either hypertensive crisis, or it's gonna be why it's not a CNS lymphoma. A CNS lymphoma would be seen in immunocompromised patients, and then if it's gonna be lymphoma, it's gonna be long-standing history present in a patient. Here it is like sudden onset, everything that has happened. So if you say that the patient is having symptoms for 3 months, then I'll not consider stroke. If I say like patient was okay in the morning and just now 1 hour ago there was a deterioration with face. Pure motor paralysis is a classical presentation of small vessel stroke, that is lacunar stroke, if it is going to be sudden onset. Okay, fine. Yes, Dr. Mani Babu, you're perfectly right. Hypertensive crisis, it is putamen, and the blood vessel that would be involved is the penetrating branches of the lenticulostriate artery. That it's not the lenticulostriate artery itself that is bursting, it is the chota branches of that which are getting affected. Okay. Somebody was mentioning regarding AIDS patient in between. I missed that chat, but I think ये तो आ गया अभी यहाँ पे. AIDS patient with features of meningitis. This is MRI head. You guys can comment here quickly. MRI head का जो finding दिख रहा है यहाँ पे, that would be called as a soap bubble appearance. If I'm saying meningitis, then it would not be a lymphoma, na? If I'm saying meningitis, then it would not be a lymphoma. It is the MRI head showing a soap bubble appearance. And that soap bubble appearance that would be occurring is mainly because of cryptococcal meningitis. Two times we read about soap bubble appearance. One is for giant cell tumor or osteoclastoma, and second is for cryptococcal meningitis. The investigation choice for this condition is CSF ELISA for cryptococcal antigen. The main investigation choice for this condition is CSF ELISA for cryptococcal antigen. This is superior as compared to the second investigation for this condition, that is lateral flow assay. Yeah, doc. Anywhere you do, just get done with the images. No, lateral flow assay. And then is India ink preparation. India ink preparation is the least reliable method for identification of cryptococcal meningitis, as you guys are aware of. And as far as the treatment is concerned, it's gonna be liposomal amphotericin B with 5-flucytosine for management. And on discharge, we give fluconazole for this patient. Fluconazole is like on discharge, and initially is 5-flucytosine. PCR नहीं डॉक्टर साहब, यहाँ पे CSF ELISA एंटीजन डिटेक्ट कर लो तो easier है ना. It's not about like PCR we can use, but then we go by the conventional data. So CSF ELISA for cryptococcal antigen is the one which is used. Main aspect was to get you an idea regarding this dirty looking masses in the brain, which are gonna be not a lymphoma, but is rather features of meningitis are given in the question. So that's why the answer changed dramatically. Okay, another patient who's AIDS positive, and we are having a MRI head. You can see some lesions in the brain, which are having a bit of, I would say, calcification also present. The location of these are in the area of the basal ganglia. The location of this is like basal ganglia. So this is like a whitish lesion, or you can see like two eyes in this one. Okay. The CD4 count of the patient is low. Putamen is the site of the basal ganglia that is involved. So we will think in terms of cerebral toxoplasmosis. Yes. And cerebral toxoplasmosis most of the time is associated with development of SIADH. Because of the SIADH in this patient, there can be development of euvolemic hyponatremia. And because of the euvolemic hyponatremia, the sodium in these patients will become less. That itself can contribute to seizure. So there are two reasons why the patient can be having a seizure. One is like the irritation of the brain, and second would be like the hyponatremia component. In this patient, in the CSF, I can check for antibody, that is IgG antibody for toxoplasma. And yeah, for the treatment of this condition, we will be using pyrimethamine with sulfadoxine. The drug that we use for management is pyrimethamine, and along with this, sulfadoxine can be used. Sulfamethoxazole, sulfadoxine, those are the drugs that would be used for management. The first answer would be pyrimethamine for cerebral toxoplasmosis. So these are like usually the spotters that are given, the one-liners, and especially with immunocompromised state, AIDS patient, CD4 count of 100, presence of seizures. So we discussed two questions. One is AIDS positive patient with the meningitis, and the second is AIDS positive patient with the seizure, and the specific treatment in this patient would be done. Yeah, differentiation from neurocysticercosis would be neurocysticercosis will always be having a lesion like this. Now it will be black hole. Neurocysticercosis will be having a black hole. Neurocysticercosis will be having a black hole with eccentric scolex. And in some cases, he might be giving you a black hole. Along with the black hole, you might be able to notice ring enhancement given. That ring enhancement would be two images, that ring enhancement given. This is white now, so it is calcification occurring, whereas neurocysticercosis, the lesion would be black with a dot. In neurocysticercosis, if you're saying, no, sir, how would you differentiate from neurocysticercosis? In neurocysticercosis, it would be a black area on a MRI, NCC. I'll just write it here because that's again something that most guys would, say that I could not pick it up in the exam, but it can be picked up, guys. In a neurocysticercosis, one, they will give you a MRI head, and MRI head will be showing one presence of black area. This is white area. No? This is the calcification which is occurring in the basal ganglia. But in neurocysticercosis, in the initial stages, we will be having that black area. Sometimes we can be having this eccentric scolex, as you can see, which will appear white. Along with that, you will also be having ring enhancement. And if I'm confused with neurocysticercosis, then I can say neurocysticercosis can occur in people with normal immunity also. But in AIDS positive patient, it's like I don't dispute the fact that it cannot be neurocysticercosis, but the physical appearance would be totally different. That difference is what I mentioned. Doxycycline in for treatment of cerebral toxoplasmosis, एक बार दोबारा से चेक कर लेना, वो स्क्रब टाइफस का ड्रग चॉइस होता है. Doxycycline is used for treatment of scrub typhus and not for cerebral toxoplasmosis. The DOC for cerebral toxoplasmosis is pyrimethamine and sulfadoxine. Otherwise Harrison से चेक कर लो, मतलब उसमें क्या है, वो तो दिया ही होता है. डॉक्सीसाइक्लिन बच्चे जो आंसर है दैट इज फॉर स्क्रब टाइफस. रिसेंट एफएमजी क्वेश्चन एम्फोटेरेसिन विद 5 फ्लू. हाँ जी हाँ जी डॉक्टर खान, वो आपने ना शायद 5 फ्लोरोयूरेसिल लिख दिया. वो आई थिंक क्वेश्चन वाज 5 फ्लू साइटोसिन. आई थिंक फ्लोरोयूरेसिल भी दिया होगा उसने, बट इट इज 5 फ्लू साइटोसिन. आई थिंक दैट्स स्लाइटली अ टाइपो होगा, बट इट इज, आई थिंक यू मेंट द सेम ओनली 5 एफसी ओनली 5 फ्लू साइटोसिन. हाँ जी हाँ जी, इट विल रिमेन ऑन यूट्यूब. नेक्स्ट क्वेश्चन इज रिगार्डिंग विल्सन डिजीज. उसने कहानी सुना दी, बोला न्यूरो डिजनरेशन ड्यू टू एक्सेस कॉपर. And he's saying like what test would be done for Wilson disease. Ideally we can do a PCR. The defect would be an ATP7B gene. Chromosome 13 is involved, as you know, autosomal recessive. So we can do a PCR in the patient, but that is not in the options. So then I'll go for an invasive test. And the invasive test that I'll be doing, diagnostic modality पूछा ना बच्चे. Best diagnostic modality for this patient is first is PCR. Genetic study कर लो, PCR for ATP7B gene. But otherwise, the second option that I can use in this patient is I can go for a liver biopsy. And this liver biopsy will be with estimation of hepatic copper content. It is liver biopsy with estimation of hepatic copper content. That is the line to line from Harrison that he is asked. Ideally तो PCR है, but अब invasive पूछ रहा तो फिर hepatic copper content कर लेंगे. Ceruloplasmin तो is done only for initial screening, वो भी अगर positive family history हो. अगर स्क्रीनिंग के लिए भी पूछेगा ना तो आंसर सीरम सेरोप्लाज्मिन नहीं है भाई. द स्क्रीनिंग टेस्ट फॉर दिस कंडीशन इज यूरिनरी कॉपर इन द पेशेंट. सेरोप्लाज्मिन कब आंसर करना होता है? सेरोप्लाज्मिन इज ओनली टू बी आंसर्ड अगर वो क्वेश्चन में खुद ही बोलता है दैट द एल्डर ब्रदर और सिस्टर वाज हैविंग सेम फिजिकल कंप्लेंट्स, न्यूरोलॉजिकल इलनेस, लिवर डैमेज एंड द एल्डर ब्रदर डाइड. So if there is a positive family history described in the question in the sibling, only then the screening test to be answered should be given as serum ceruloplasmin levels, because ceruloplasmin levels can be low even in nephrotic syndrome, sir. Serum ceruloplasmin levels can be less in nephrotic syndrome also, क्योंकि यूरिन के रास्ते निकल जाएगा ना. आप अगर मेरा नेफ्रोटिक सिंड्रोम का डिस्कशन सुनोगे तो उसमें मैंने बोला कि सर्लोप्लाज्मिन इज लेस इन पेशेंट्स ऑफ मेम्ब्रेनस ग्लोमेरुलोपैथी एमजीएन. तो क्योंकि किडनी के रास्ते निकल जाएगा ना, तो दैट डज नॉट मीन कि उसको विल्सन हो गया. So serum ceruloplasmin is only to be given if it is positive family history given in the siblings. So screening के मैंने 2 टेस्ट लिखे हैं, अगर कुछ भी नहीं लिखा हो ना एग्जाम में, if it does not mention anything like family history in sibling, पहला बच्चा है and he says कि भाई क्या करोगे, then the answer would be given as urinary copper. Okay guys, moving to the next one. MR patient presents with GTCS and MRI imaging is showing multiple lesions. So you can see these lesions which are having calcification, central dot present, and because they're scattered all over the brain parenchyma, so there can be two possibilities. One can be, it could be tuberculoma, or it can be neurocysticercosis. This person is having neurocysticercosis. This could be tubercular meningitis manifestation of tuberculoma, or the third possibility can be, it can even be cerebral toxoplasmosis. So in case I want to differentiate between them, the leading cause of acquired epilepsy, if he says what is the leading cause of acquired epilepsy in adults, leading cause of acquired epilepsy in adult population is neurocysticercosis. I repeat my statement, leading cause of acquired epilepsy in adult is neurocysticercosis. And if we are not sure about the lesion, then what we can do is a MR spectroscopy that would help us in analyzing the case, because in neurocysticercosis, the report will always say amino acid peak. The word will always say amino acid peak described. And tuberculoma, he will always mention lipid peak. That would be features, the cell wall of Mycobacterium tuberculosis is having mycolic acid, it is rich in lipids. So that is why the word described would be like lipid peak. A similar picture in tuberous sclerosis. Tisha, in tuberous sclerosis, the lesions are present here, periventricular. In tuberous sclerosis, I'll just highlight this with a separate color in gray. Tuberous sclerosis, the lesions would be present in periventricular area. In fact, I'll have to draw it in yellow only so that you can remember. This is like a potato in the brain, periventricular lesions. This that I've shown before you is tumors in the brain. These tumors in the brain can be seen in patients of tuberous sclerosis. And since you've asked it, I can mention one more lesion here, which would be looking like fingers, periventricular fingers. These fingers that I've shown before you are what are called as Dawson fingers. These that I've shown are periventricular damage in the form of demyelination and remyelination, that is Dawson finger. And Dawson finger is a feature that you encounter with multiple sclerosis. Dawson finger is multiple sclerosis. Okay. So there are like four things that are said: tuberous sclerosis, Dawson finger, and then is these lesions in the brain, which can be NCC versus a tuberculoma, and the differentiation between these can be made. Okay, guys. So we are sorted for MR spectroscopy. Moving to the next one, the 40th bit, though I've done more bits than that, I think like we're still on the 40th one. Child has recurrent lung infections with delayed milestones, and the auscultation shows widespread second heart sound. Spotter, straightforward one. Main aspect is recurrent lung infections and delayed milestones. Yes, guys, you guys can comment there. ओके, डाइजॉक सिंड्रोम जो होता है उसमें सेल मीटेड इम्यूनिटी कम होती है, और साथ में क्योंकि थाइमस ग्लैंड की एबनॉर्मेलिटी खोलने के साथ साथ में पैराथायरॉइड ग्लैंड की भी एबनॉर्मेलिटी होती है, तो पर्सन विल ऑल्सो बी हैविंग हाइपोकैल्सीमिया. Dijot syndrome will be having developmental defects with respect to thymus, and cell-mediated immunity will be less because the thymus के साथ में problem हो रहा है. Thymus development is affected. Thymic development is affected, and the same time the parathyroid development is also affected. So that would be ruled out. बी फॉर बॉम्बे. ओके, सिस्टिक फाइब्रोसिस में क्या होता है कि उसमें रिकरेंट निमोनियाज होते हैं और साथ में मैल अब्जॉर्प्शन सिंड्रोम होता है. आप मेन वर्ड मिस कर रहे हो क्वेश्चन में, उसमें लिखा हुआ है वाइड फिक्स स्प्लिट सेकेंड हार्ट साउंड, उसी से क्वेश्चन सॉल्व हो जाएगा. रिकरेंट निमोनिया विद मैल अब्जॉर्प्शन, यहाँ पे तो कोई मैल अब्जॉर्प्शन का फीचर नहीं दिया हुआ ना, उसने तो सिर्फ माइलस्टोन्स दे रखे हैं. और कार्टेनेगर सिंड्रोम जो है, कार्टेनेगर सिंड्रोम में डेक्स्ट्रोकार्डिया होता है, टाइटस इन्वर्सस होता है. आपको सिर्फ पकड़ना था वाइड फिक्स स्प्लिट सेकेंड हार्ट साउंड. वाइड फिक्स स्प्लिट सेकेंड हार्ट साउंड जो होता है दैट इज अ फीचर ऑफ एएसटी, और एएसटी के साथ में अगर ज्वाइन करो, एएसटी भी है, डिलेड माइलस्टोन्स भी है, रिकरेंट लंग इन्फेक्शंस भी है, तो दैट इज अ फीचर दैट इज सीन इन केसेस ऑफ डाउन सिंड्रोम. डाउन सिंड्रोम में ये तीनों चीज़ें फिट हो जाती हैं. द आंसर टू दिस क्वेश्चन इज डाउन सिंड्रोम. डाउन सिंड्रोम में क्योंकि हाइपोटोनिया होता है तो रिकरेंट लंग इन्फेक्शंस होते हैं. उसका रीज़न क्या है? बिकॉज देर इज डिक्रीज इन द मसल टोन ऑफ द रेस्पिरेटरी मसल्स. तो क्योंकि टोन ऑफ मसल्स लेस होती है डाउन सिंड्रोम में, तो चेस्ट मसल्स की टोन कम होने की वजह से पेशेंट का जो कफ करने का कैपेसिटी है वो लेस होगा. अगर कफ करने का कैपेसिटी लेस होगा तो इट विल कंट्रीब्यूट टू रिकरेंट लंग इन्फेक्शंस. और रिकरेंट लंग इन्फेक्शन का एक और रीज़न है, अपार्ट फ्रॉम डिक्रीज इन द टोन ऑफ द मसल, the heart of this patient can be having left to right sided shunting, and the left to right sided shunting will cause pulmonary edema, that is AST. How AST was given in this question was wide fixed split second heart sound. Why? How AST was given in this question was wide fixed split second heart sound. And along with this, AST, all patients of Down syndrome will be having brachycephaly. उसकी वजह से वो delayed milestone, उसकी वजह से there would be brachycephaly. Brachycephaly will explain that they will be having is delayed, क्यों brain grow नहीं कर पाएगा ना, so that will explain the delayed milestones of these patients. So answer to this question is option number D. जब भी रिकरेंट निमोनिया आए ना तो सीधा मत सोचो कि डाइजॉस सिंड्रोम है, या सीधा मत सोचो सिस्टिक फाइब्रोसिस है. इस इंफॉर्मेशन को यूज करना. Though this is like a one-liner discussion, what I have done in this question is give you 4 questions solved in one question. So it's like what we are doing today is like 40 into like 2-3 bits I'm giving per question. So already we are hitting the 100 mark, but we'll keep on pushing it to like 200 bits for today. Oh, great, great. Doc, your name says no name, so I cannot congratulate you by name, but okay, Dr. No Name, heartiest congratulations. Okay. Then this is a question which was asked in last time's NEET PG. Patient is having Vivax infection and falciparum infection and what treatment is given on day 2. So इसमें ना नंबर ऑफ टैबलेट्स में उसने घुमाया था 4 टैबलेट 6 टैबलेट और नॉर्मली वी से कि किसी चीज़ का डोज नहीं पूछेगा बट 3 चीज़ का डोज हमेशा पूछता है। एड्रेनलिन का डोज, एट्रोपिन का डोज। एड्रेनलिन और एट्रोपिन का डोज 1 मिलीग्राम है और दूसरा वो मलेरिया की दवाई का मलेरिया का इलाज पूछता है, वो भी कॉम्प्लिकेटेड मलेरिया का। सो द पॉइंट इज ये एक चार्ट है, ये दिस चार्ट इज द वन विच आई वांट यू टू गेट यूज टू, जिसमें आपको मेनली अडल्ट्स के लिए, पूरा बच्चे का तो याद नहीं करना बट अडल्ट्स के लिए याद करना है। दैट इज द नंबर्स टू बी टैबलेट्स टू बी टेकन, आर्टिसोनेट एंड एसपी टैबलेट्स which are to be taken and then it is pyrimethamine subsequently। तो numbers याद करने हैं and this is what he picked up the question from कि भाई आप इसका जो मैनेजमेंट कर रहे हो, this is the treatment that he had asked, that is day 2 पे it is 4 and 6 tablets which are to be given। So good evening Dr. Sid and thanks for, I could not answer a couple of people in the middle, but this is the table guys on the mixed infection for falciparum malaria। So because this would be available in the PDF for thoda rectification hai, so I just want you to get these values right and based on this 4-6 data the correct answer in this particular case, yes, is saying which is the treatment which is to be given to these patients। So answer would be given as option number C। नहीं मैं तो पेपर वाला नहीं बना यार ये तो पेपर ऐसे ही दिया था नीट पीजी का पिछली बार वाला, तभी तो परसेंटाइल कम कर दिया ना उसने, क्योंकि पेपर ही तो ऐसा बनाया था उसने नेस्टी वाला। दिस इज अ डायरेक्ट रेप्लिकेशन ऑफ द क्वेश्चन दैट केम इन नीट पीजी इन 2024 एंड दैट इज द रीजन वाई जो टॉपर्स हैं यार, देखो ब्रिलियंट वाले लड़के वो तो लेकर आएंगे, यू नो दे विल गेट गुड स्कोर्स, बट फॉर एवरेज पीपल लाइक यू एंड मी, आई वॉज माई सेल्फ एन एवरेज पर्सन, तो मैं तो आई यूज टू स्ट्रगल, तो मैं तो आई कैन रिलेट टू द स्ट्रगल दैट यू गैस गो थ्रू एंड बेस्ड ऑन दैट आई कैन से कि थोड़ा बहुत रट्टाफिकेशन इज ऑलवेज रिक्वायर्ड। ओके, तो दिस का फोटो भी ले लेना यार, अदरवाइज कई बार सोर्सेज नहीं मिलते हैं, तो इफ यू कैन क्लिक अ पिक्चर ऑफ दिस दैट इज ग्रेट। द ट्रीटमेंट ऑफ इन्फेक्शन फॉर अ मिक्स्ड इन्फेक्शन विद मलेरिया, और ये ऐसे पूरा कहानी सुनाया, राजस्थान से पेशेंट आया है, उसको डे 2 का ट्रीटमेंट क्या देंगे, वो डे 3 में थोड़ा सा डिफरेंस हो गया ना, सिर्फ 4-3-6 था, ये 4-6 है, तो बेसिकली यू जस्ट नीड टू गेट यूज टू दिस। ओके फाइन, वी कैन मूव ऑन टू द नेक्स्ट क्वेश्चन। A 25-year-old woman comes with weight loss, palpitations and heat intolerance and tremors and she has exophthalmos on examination। अब इसको पढ़ के ये मत बोलना कि सर 20% मार्क आएंगे इसको पढ़ के तो भाई 70-80% मार्क्स आने वाले होंगे, इससे आसान क्या हो सकता है। देखो देखो 25-year-old वुमन विद वेट लॉस विद पैल्पिटेशंस विद हीट इंटॉलरेंस, तो सीधा ग्रेव्स डिजीज दे दिया ना आंसर वो, तो आई थिंक ऐसे मतलब पता, जब व्हेन आई स्पोक टू पीपल हु गेव द पेपर दे वर लाइक कि सर इतना मतलब सरप्राइजिंग था कि कई क्वेश्चन तो ऐसे थे कि पढ़ने का जरूरत भी नहीं था, कई बार तो डर लग रहा था कि यार इतना आसान भी हो सकता है, राइट। दिस वाज लाइक द क्वेश्चन वाज लाइक गाइस वर हैविंग अ सेल्फ डाउट, क्योंकि पिछला वाला क्वेश्चन जो था वो था बाउंसर कि मतलब यार 4 टैबलेट 6 टैबलेट कौन याद करेगा, मतलब एट द एंड ऑफ द पेपर पीपल लाइक जैप्ड कि यार टैबलेट भी याद करनी पड़ने के लिए बोलेगा, एंड देन देवर लाइक सेल्फ डाउट हो जाता है कि इसके लिए कोचिंग करनी पड़ेगी, इसके लिए मतलब ऐप लेना पड़ गया, ऐसे खुद ही पढ़ लेते ऐसे ही पास हो जाते। तो पिक अप द इजी क्वेश्चंस गाइस एंड ट्राई टू मिनिमाइज द नेगेटिव मार्किंग द एंटायर गेम। हाँ नहीं, एफएमजे एग्जाम में तो मतलब एफएमजे एग्जाम भी अच्छा खासा पूछा यार इस बारी, तो मतलब इट्स नॉट एन इजी पेपर, आई वुड नॉट कॉल इट, सम पीपल आर सेइंग कि बड़ा इजी था एफएमजे एग्जाम का, बट दे वर ट्रिकी, वेरी क्लोज ऑप्शंस। Okay, which of the following is correct about pheochromocytoma? So the question is based on rule of 10. For pheochromocytoma, the question is on rule of 10, और वो ये होता है कि 10% of the cases are gonna be malignant और 10% cases are bilateral। इसमें उल्टा लिखा हुआ है, 10% are malignant, 10% are bilateral। Again, inversion of the data was done। Like ये सब कुछ 10-10% होता है, all of these things are 10-10% and is written 90% for the same, so answer would be associated with Sippel syndrome, that is PPM। सिप्पल सिंड्रोम में 3 चीज़ें होती हैं, आई विल मेंशन इट सब्सिक्वेंटली एज वी प्रोग्रेस इन आवर डिस्कशन, बट आई विल से इट वर्बली। पैराथ्रोइड एडिनोमा, पैपिलरी कैंसर, पैराथ्रोइड एडिनोमा, pheochromocytoma and medullary cancer of thyroid, they are the 3 associations which would be present। Yeah, Shailesh, you're right for that, that men 2A and men 2B would be having a pheochromocytoma। Okay, Next is a question on a female patient and बच्चा दे दिया था. Surprisingly, he mentioned the workup of the patient is showing low hemoglobin. Platelet count was only 25,000. I double checked also कि platelet count 2.5 लाख था या 25,000 था. तो the platelet count of the patient is low with raised PT and APTT. So what is trying to tell us is regarding DIC. What is trying to tell us in the question is regarding disseminated intravascular coagulation, DIC. DIC is called as consumptive coagulopathy, so platelet count will become less, prothrombin time would be elevated, and international normalized ratio would be elevated. The moment I read about DIC, it clicks in my mind that is probably talking about a blood cancer which is called as M3 variety of acute myeloid leukemia. M3 variety of acute myeloid leukemia has a chromosomal swap of 15:17. That is for the chromosomal translocation, that is PML RARA. The correct answer for this question is option number A. A question is on blood cancer. वो ऑयर रॉड्स वगैरह ना कुछ क्लियर नहीं था. मतलब आप इस इमेज में भी देखोगे तो आई स्पोक टू लॉट ऑफ पीपल, वो बोले सर कुछ ऑयर रॉड वगैरह तो दिख नहीं रहा था क्योंकि हम AML आइडेंटिफाई कैसे करते. BCR ABL तो निकाल दिया. BCR ABL is gonna be chronic myeloid leukemia, so one option everybody could rule out. But between the remaining 3 options, they were all features of acute myeloid leukemia. So पहली बात तो देखो मैं ऐसे बोलूँगा कि acute myeloid leukemia जब भी मैंने डिस्कस किया ना, मैंने इस पॉइंट को हमेशा हाईलाइट किया कि बाकी सारी चार पूरी हेमाट एक तरफ और ये वाला क्वेश्चन एक तरफ है. ऐसे है कि M3 variety of AML with 15:17 translocation is gonna be simply like to be picked up in a question. I mean, दो blood cancer और leukemias के लिए we can talk 1 hour about it. बट देन आई सेड पूरा लुकीमिया एक तरफ कर दो, पूरा डिस्कशन, और एक एक क्वेश्चन एक तरफ पे कि M3 वैरायटी ऑफ एक्यूट माइलर लुकीमिया पूछता ही है कि उसकी वो दवाई पूछ लेगा. वो ज़्यादा पूछ लेगा भाई एट्रा इसमें देते हैं, ऑल ट्रांस रेटिनोइक एसिड, इसमें आर्सेनिक ट्रॉक्साइड देते हैं, विच इज़ वेरी अनकन्वेंशनल अप्रोच ना. विटामिन ए डेरिवेटिव बीइंग यूज्ड और लाइक वी आर यूजिंग आर्सेनिक ट्रॉक्साइड फॉर दिस पेशेंट. सो दैट इज व्हाई लाइक दिस क्वेश्चन वुड बी easy to identify. Answer to 44 is option number A. Then is mortality reducing beta blocker in a patient of heart failure with reduced ejection fraction. I think पीछे अभी डॉक्टर अंकित ने फार्मा में लाइक हार्ट फेलियर के ऊपर सेमिनार भी कंडक्ट किया था. सो दिस इज अ क्वेश्चन दैट विल ऑलवेज बी आस्क्ड टू यू. दैट इज बीसोपरलॉल. 3 ही होते हैं, बीसोपरलॉल होता है ना, या मेटोपरलॉल यूज़ कर रहे होते हैं या कार्बेडोलॉल यूज़ कर रहे होते हैं. सो इट इज़ बीसोपरलॉल, कार्बेडोलॉल और मेटोपरलॉल. दीज आर द ओनली 3 FDA approved drugs that we use. I'll just mention first alphabets for the remaining ones. Betoprolol, mesoprolol, metoprolol, and carvedilol, BMC. They are the 3 FDA approved beta blockers that would be used for chronic heart failure. What I'll do next is I'll do 30 seconds into acute heart failure and I'll do 30 seconds into chronic heart failure because they asked for drugs for it. So acute heart failure के लिए तो it is a easy mnemonic, that is LMNOP, where L is for Lasix, that is furosemide. Diuretic, M would be morphine, N would be nitroglycerin drip. Then is O is oxygen and P is the positioning part in a patient where the head will be higher and the feet will be relatively lower. Yeah, Dr. Sangeeta, this was lorazepam, no? I think this question was mentioning like an alcoholic, and then I think it was not exactly altered sensorium. He was having delirium tremens. And he said that in this guy with delirium tremens who's not in his senses at the moment, which drug can be used? So we can use lorazepam because it has a shorter, I mean, it has a shorter, quicker metabolism and shorter duration of action. So it would be safer in that alcoholic. Okay. So I think the question was on altered sensorium due to alcohol. You are right, Raj. Benzodiazepine देंगे, but it is not diazepam, na? That's the point. And for chronic heart failure, it would be ACE inhibitor or angiotensin receptor blockers. Then it's gonna be beta blockers, the 3 that I mentioned. It can be like carvedilol or it can be metoprolol or bisoprolol. And then it's gonna be mineralocorticoid receptor antagonist. That mineralocorticoid receptor antagonist is gonna be like spironolactone or it can be finerenone. And the 4th entry here is SGLT2 inhibitors. SGLT2 inhibitors were initially designed for treatment of diabetes, but now they are cardioprotective because they cause salt loss in the urine and they cause a systolic BP to fall by 5 millimeter of mercury. So that's why they are found to be cardioprotective as well. And now I'm putting a bracket around this A to say that if this A cannot be used, then instead of this A, we can also be using ARNI in a patient. ARNI would be like ARB, that is, we can use angiotensin receptor blocker like valsartan with the sacubitril. So he mentions that if ACE inhibitor or ARB cannot be used, maybe because of angioedema that is occurring with them, then it is Arni, valsartan with sacubitril that can be used in the patient. Okay, so these are like drugs that we are cardiac from the cardiac perspective that are always asked. And when I've said chronic heart failure here, the discussion is mainly for heart failure with reduced ejection fraction. It is HF-ref that I wanted to focus upon. For HF-PEF, for preserved ejection fraction, it's ARNI all the way. No drug has been shown to reduce mortality in heart failure with preserved ejection fraction. But the first best answer for HF-PEF is ARNIs only. Okay. So we are sorted for 45. Let's move to 46. He gave a curve where like up to 120 months का data was given. 10 साल तो वैसे ही क्लियर हो जाता है कि बीच में वायरस में देखो ALT नॉर्मल हो गया, पहले स्पाइक आया, फिर ALT नॉर्मल हो गया, फिर लेटर स्टेज में फिर से स्पाइक दिखा रहा है. And you can also see that person is having a antibody, that is IgM, which is falling. Antibody to the core antigen is persisting for a very long time. So considering that antibody to the core antigen is present and 10 साल का data दे रखा है at 10 years, so this would be answered as chronic hepatitis B. I was waiting for answers, guys. Maybe my chat became a little slow, but then considering the fact that it's a very long duration and antibody is present. If it was surface antigen only, I could have thought in terms of carrier also. But considering like 10-year data, antibody also present, that would be total antibody. Antibody to core antigen means IgG antibody only. That goes in favor of chronic hepatitis B. And anyway, like this would be a single curve. Acute hepatitis B का जो curve होता है, acute hepatitis B के curve में surface antigen जो होगा वो clear हो जाएगा. And then you will come across a protective antibody coming up like this. So it's gonna be like a curve. There would be two curves given. One curve in blue is regarding what I've shown is surface antigen, and the surface antigen in the patient will then get cleared and the protective antibody would be developing. That protective antibody is the antibody against the surface antigen that I'll mention in green. So if they give you a curve like this with a gap period visible, they give you a curve like this with a gap period available. This is the gap period when surface antigen is disappearing. The antibody against surface antigen would also be disappearing. इसके against antibody भी बनेगी. There would be an antibody against it. I can show in red. IgM class of antibody to core antigen. So this would also get cleared in this patient. So between that period, there would be a gap combination. Yeah, doctor. Two only. दो biphasic ही बनेगा. एक अगर biphasic वाला दे रहा है और short duration दे रहा है, within 1 year ही पूरा situation दिया हुआ है या 6 months का data दिया हुआ है, and there are two curves that are given in a question, then it would be thought of as like your answer would be acute hepatitis B. That's the easiest way to solve it. Two curves described, one for clearance surface antigen and the antibody against it, and the security system coming, because security system will take some time to appear. That's gonna be a situation of acute hep B. But if it's gonna be a case where it's like a 10-year ka data, only two diagrams are there, a uniphasic curve and a biphasic curve, that helps in differentiating between the two. Acute hepatitis B will not require any treatment. For chronic hepatitis B, specific treatment would be required. It is total wala antibody na. This is IgG antibody only. This is written as total. Total means it is IgG class of antibody only. Like he may not write IgG class of antibody. That is the point. यहाँ पे ना he may not write the word IgG class of antibody. He may write the word total antibody in this case. नहीं lamivudine नहीं देते यार. For treatment of this patient, either your answer would be tenofovir, or instead of tenofovir, the second drug that we'll be using in the patient is anticavir. Either of the two. That would be the treatment of choice for this patient. और acute hepatitis B में majority of cases में तो self resolution ही हो जाता है. Majority of cases of acute hepatitis B, it is self-resolution. Only if acute hepatitis B is causing progression to fulminant hepatic failure, that is when we might have to give antiviral drugs. Otherwise, in acute hepatitis B, most of the time self-resolution occurs. Only if the patient is showing a progression to fulminant hepatic failure, that would be in less than 10% of cases, that's when we give antiviral drugs. इंटरफेरॉन अब तो देंगे नहीं ना. इंटरफेरॉन देते हैं. ओके, इंटरफेरॉन अल्फा कब देते हैं? तो इंटरफेरॉन अल्फा इज गिवन जब हेपेटाइटिस बी और डी का को इन्फेक्शन लिखा होता है ना. दैट इज व्हेन इंटरफेरॉन अल्फा वुड बी गिवन. नाउ अल्फा इंटरफेरॉन इज नॉट फॉर मैनेजमेंट ऑफ हेपेटाइटिस बी. अल्फा इंटरफेरॉन इज इफ देयर इज बी एंड डी का को इन्फेक्शन दैट इज डिस्क्राइब्ड. The final summary is if they give you a uniphasic curve over 10 years with total antibody to core antigen, answer it as chronic. If it's going to be two curves given with appearance of the protective antibody subsequently with clearance of the antigen, that is when you will say that person is having acute hepatitis B. हाँ पहले देते थे, अब नहीं देते. Then the next image, what you can pick up is our case is having that owl-eye appearance, very classical for Hodgkin's lymphoma. Considering that there is gonna be like Hodgkin's lymphoma described in the question, I mean Reed-Sternberg cell described in this question, you can pick up the answer for this one as ABVD regimen. For non-Hodgkin's, it is R-CHOP. And anyway, I mean, the main point is Potter only, that Reed-Sternberg cell can be picked, and then adriamycin, bleomycin, vinblastine, and dacarbazine can be used in the patient. Yeah, transfusion-associated hepatitis is hepatitis B only, doctor. Leading cause of transfusion-associated hepatitis is hepatitis B. Okay. Moving to the next question, what is most likely based on the lab values? There were 4 possibilities of renal tubular acidosis. This is a question of last time's NEET PG. You can pick up metabolic acidosis. I mean, there is a acidosis, there is bicarbonate that is lesser. There is no value given of CO2. But considering bicarbonate is low and blood pH is also low, it becomes metabolic acidosis. The second thing was that in this person, there was hypokalemia. Because of hypokalemia component, RTA4 can be ruled out and there is no RTA3. RTA3 is a dummy choice, so it can be ruled out. RTA4 is ruled out because RTA4 will be having hyperkalemia. Now we have to select between RTA1 and RTA2. Now the main aspect is in RTA1 there is inability to acidify the urine. If you cannot acidify the urine will be highly alkaline. I mean, if you look at the pH of this patient, the pH of this urine of this person is 9.4. Why that is because in RTA1 what happens is कि protons will not be excreted at all in spite of metabolic acidosis. Body में खत्म ही हो गया सारा का सारा. There would be like a inability to acidify the urine of this patient. There would be, the main aspect is RTA1 will have inability to acidify the urine, and because of this acidifying the urine pH of this patient is turning out to be elevated. So the correct answer for this one is option number A, that is RTA1. It is RTA1. RTA2 में bicarbonate होता है, लेकिन subsequently there would be a total depletion of bicarbonate from the body. I agree to the fact, initially लगता है कि यार alkaline urine है तो it can be answered as RTA2 also because of bicarbonate, but ultimately in those patients there is a complete depletion that is occurring. So between RTA1 and RTA2, it is RTA1 where we will be having inability to acidify the urine for these patients. Like वो CMDT का reference वगैरह तो है वो, that is okay. That urine pH जो होता है ना, basically if you check it out, in this case the urine pH always is more than 5.5. In RTA1 urine pH is always more than 5.5, and in RTA2 the urine pH is always less than 5.5. वो बस एक एरो का फर्क है, और वो क्यों है उसका मैंने रीजन आपको बताया कि क्यों मोर देन 5.5 है, वो समझना है कि it is more than 5.5 because there is inability to acidify the urine. So in spite of that, I mean, there would be like the person is not gonna be though the patient is having metabolic logic ऐसे है कि metabolic acidosis में acidic urine protons should be excreted, लेकिन यहाँ पे तो खराबी है, जो अल्फा इंटरकैलकुलेट सेल है वो excrete ही नहीं कर पाएंगे. So that is why alkaline urine यहाँ पर मिल जाता है. So that is why the answer to this question is option number A. Okay, coming to a easy one, prognostic test for dengue fever. Learning point is RTA1 and RTA2 both have hypokalemia. The differentiation is urine pH. I'll write it on this slide only. RTA1 and RTA2 both will be having hypokalemia, and RTA4 will be having hyperkalemia. Metabolic acidosis is common between them. Now how to differentiate between the two is just check out the urine pH. If it is more than 5.5, then your answer would be given as RTA1. इसको इतना याद कर लेना. And the second aspect is, which I have not written but is understandable, if urine pH is less than 5.5, we call it RTA2. Metabolic acidosis will be present in all of them. That is the shortest I can explain, like the analysis of the table which is given in the book. Yeah, metabolic acidosis तो सभी में होना है. All varieties will be having metabolic acidosis, and that would be normal and NGAP. NAGMA would be normal and NGAP metabolic acidosis. Yes, prognostic test for dengue fever. I waited for a few seconds. I wanted you guys to answer because one of the biggest complications of dengue fever is dengue shock syndrome. And in these patients of dengue shock syndrome, there would be like DSS. There would always be fluid leak from the capillaries, there would be hemoconcentration. So hematocrit rising by more than 20% over the baseline admission value. Like patient had a whatever was the baseline value. Whatever is the baseline admission value, if you have an increase of hematocrit by more than 20%, it means fluid is leaking. So it would be the main test that would be useful to identify the hemoconcentration which is occurring. Okay. Moving to the next aspect, sudden onset pure motor paralysis. I mentioned this word already. It is sudden onset that is happening. Pure motor paralysis with spasticity would be seen in. Amyotrophic lateral sclerosis will always be gradual onset. Like it will take a long time for manifestations to occur. Acute inflammatory demyelinating polyneuropathy will be causing flaccidity. So option number A is ruled out because it will cause flaccidity. And amyotrophic lateral sclerosis, that's going to be gradual onset, so again can be ruled out. Miller-Fisher syndrome, we discussed a triad. Ophthalmoplegia not given in a question, so by exclusion also, the correct answer for this would be option number B. What about platelets in cases of dengue? Okay, so platelets are only to be given if the platelet count is less than 10,000. Otherwise, there is no need for giving platelets in a patient, because there were queries on this. So I'll just address one more slide here. जो डेंगू फीवर पे क्वेश्चन आता है उसमें क्या होता है कि जो NS1 एंटीजन होता है वो NS1 एंटीजन डिक्लाइनिंग ट्रेंड पे होता है बाय डे 5. दिस विल हेल्प यू सॉल्व दैट क्वेश्चन ऑफ इनिसट एग्जाम और नवंबर ऑल्सो. जो NS1 एंटीजन होता है, NS1 एंटीजन इज ऑन अ डिक्लाइनिंग ट्रेंड विद रिस्पेक्ट टू डे 5. लेकिन जो एंटीबॉडी होती है, वो एंटीबॉडी का जो लेवल होता है, वो एंटीबॉडी दैट इज डेवलपिंग IgM क्लास ऑफ एंटीबॉडी टू डेंगू वायरस, that antibody is showing a increasing trend. IgM antibody to the dengue virus, it could be any variety 1 2 3 4, is showing a increasing trend. So on day 5, क्योंकि NS1 antigen is on a declining trend and antibody is on a rising trend, so the antibody answer should be preferred. That is like one question that came कि day 5 पे अगर पेशेंट आ रहे तो आप क्या करोगे, NS1 एंटीजन करोगे या एंटीबॉडी? देखो आइडली तो दोनों होने चाहिए, आइडली वी शुड डू both of them, but NS1 antigen is gonna be decreasing and IgM class of antibody is showing a increasing trend. So single best answer would be IgM class of antibody for dengue. सेकेंड एस्पेक्ट इज कि डेंगू के जो पेशेंट्स होते हैं उनमें बाइफेजिक फीवर होता है. ऑल पेशेंट्स ऑफ डेंगू विल बी हैविंग बाइफेजिक फीवर. व्हेन द फीवर इज कमिंग डाउन, व्हेन द फीवर इज शोइंग अ डिक्लाइनिंग ट्रेंड, जैसे 2 या 3 दिन का बुखार है, तो जब वो बुखार कम होगा इसका, तो व्हेन द फीवर विल डिक्लाइन, व्हेन द फीवर डिक्लाइंस, उस टाइम पे कॉम्प्लिकेशंस आती हैं. व्हेन फीवर डिक्लाइंस, दैट इज व्हेन कॉम्प्लिकेशंस अकर. And the complications that occur are two. One is DSS, dengue shock syndrome, which is more common, and second is dengue hemorrhagic fever. That's the second one. तो डेंगू शॉक सिंड्रोम में तो क्या होगा कि जो हेमाटोक्रिट की वैल्यू है वो बढ़ती रहेगी, इंक्रीजिंग ट्रेंड देती रहेगी. तो इस वजह से यहाँ पर मैनेजमेंट के लिए हम सलाइन देते हैं, फ्लूइड्स देते हैं. अगर फ्लूइड से भी काम नहीं बनता तो हम यहाँ पे कोलॉइड्स देते हैं. लेकिन डेंगू हेमरेजिक फीवर में तो ब्लीडिंग होगी. तो अगर वो एमसीक्यू में बोलता है कि हेमाटोक्रेट ऑफ द पेशेंट इज फॉलिंग, इफ द हेमाटोक्रेट ऑफ द पेशेंट इज फॉलिंग, और हेमाटोक्रेट फॉल के करने के साथ साथ में प्लेटलेट काउंट भी फॉल करता जा रहा है, एंड इफ द प्लेटलेट काउंट ऑफ द पेशेंट इज लेस देन 10K, दैट इज व्हेन वी विल बी गिविंग इन दिस पेशेंट प्लेटलेट ट्रांसफ्यूजन. द मेन एस्पेक्ट इज हेमाटोक्रेट से हेमो कॉन्सेंट्रेशन भी पता चल जाती है और ब्लीडिंग भी पता चल जाती है ना. हेमाटोक्रेट क्यों मैंने आंसर बोला, बिकॉज हेमाटोक्रेट बढ़ रहा है तो हेमो कॉन्सेंट्रेशन DSS, और अगर हेमाटोक्रेट कम हो रहा है तो ब्लीडिंग स्टार्ट हो गई है. तो वाई द आंसर इज नॉट प्लेटलेट काउंट इज बिकॉज प्लेटलेट काउंट तो एक ही कॉम्प्लिकेशन बताएगा, एंड दैट इज गोना बी डेंगू हेमरेजिक फीवर, बट इट हेमाटोक्रेट कैन टेल यू बोथ द कॉम्प्लिकेशंस दैट आर अकरिंग इन द क्वेश्चन. यस यस यस, या वो तो ठीक है. टॉर्निकोइट टेस्ट तो यार मतलब डायग्नोस्टिक, मतलब डायग्नोसिस के लिए है ना, वो इंडिकेशन फॉर प्लेटलेट ट्रांसफ्यूजन नहीं है. मैं व्हाट आई एम ट्राइंग टू एक्सप्लेन टू यू इज कि अगर मैं सिर्फ प्लेटलेट काउंट करूंगा तो उसमें तो मुझे सिर्फ DHF का पता चलेगा ना, DSS का तो पता चलेगा नहीं. लेकिन अगर मैं हेमाटोक्रेट करता हूँ तो मुझे दोनों का पता चल सकता है, बिकॉज हेमाटोक्रेट से अगर वो राइज करता है तो वो DSS में चला गया, अगर वो फॉल करना शुरू हो गया तो वो DHF में चला जाता है, विच इज वाई हेमाटोक्रेट इज बीइंग मेंशन्ड, एंड दैट इज वाई लाइक द we will be giving on those circumstances platelet transfusion if the platelet count is less than 10K. That's the rationale behind the aspects of intervention. Okay, 50th is sorted. Let's do 51. 10 petechial tourniquet test is sufficient for diagnosis. It's a range 10 से 20. Anything more than 10 is abnormal. Fever for 1 day with altered sensorium, CSF shows lymphocytosis with normal sugar and increased protein. तो यहाँ पे मोस्टली तो मोनोन्यूक्लियर सेल्स ही हैं. लाइक वी आर डूइंग अ स्टेनिंग ऑफ द CSF. सम न्यूट्रोफिल्स कैन बी सीन. यहाँ पे कुछ तो न्यूट्रोफिल्स हैं, बट मोस्टली इज मोनोन्यूक्लियर सेल्स दैट आर lymphocytes which are present. नहीं नहीं नहीं, देर इज नो रोल ऑफ डॉक्सीसाइक्लिन. यार, देर इज नो रोल ऑफ डॉक्सीसाइक्लिन. देर इज नो रोल ऑफ पपाया, नो रोल ऑफ डॉक्सीसाइक्लिन दैट हैज बीन शोन इन एनी क्लिनिकल स्टडीज. यस. लिम्फोसाइटोसिस विद इंक्रीज प्रोटीन. सो योर आंसर वुड नॉट बी गिवन एज, क्योंकि नॉर्मल शुगर है ना, तो इस वजह से इसको बैक्टीरियल नहीं बोलेंगे. दैट इज वायरल मेनिंजाइटिस वुड बी आंसर्ड इन दिस केस. तो करेक्ट आंसर इज वायरल मेनिंजाइटिस. शुगर इन द CSF जब भी कम हो जाती है, शुगर इन द CSF जब भी कम हो जाती है तो उसको हम हाइपोग्लाइकोरैकिया बोलते हैं. Hypoglycorrhea is seen in pyogenic meningitis. In this, the CSF sugar can become zero. Then it is seen in tubercular meningitis, and third can be seen in fungal meningitis also. Hypoglycorrhea can be seen in pyogenic meningitis, tubercular meningitis, and fungal meningitis. ये तीनों में ही we can be having is hypoglycorrhea occurring in the patient, even in the fungal meningitis. But viral meningitis में the sugar in the patient will always be normal. क्लोराइड का लेवल आर यूज्ड फॉर इवेल्युएशन ऑफ पायोजेनिक. इन दोनों में क्लोराइड देखते हैं. इन दोनों में क्लोराइड इन द CSF. लेकिन आजकल तो ज़रूरत नहीं है ना, क्लोराइड इन द CSF देखने की ज़रूरत ही नहीं है, क्योंकि क्लोराइड CSF इज लो इन बोथ ऑफ देम, बट ट्यूबरकुलर के फेवर में ज़्यादा जाता है, क्योंकि आजकल तो PCR कर लेते हैं ना. सो क्लोराइड इन द CSF इज यूजफुल फॉर डिफरेंशिएटिंग बिटवीन bacterial etiology versus fungal etiology. You can just put a differentiator here to say that chloride CSF is useful for bacterial versus fungal, and more specifically for tubercular. Sugar is low in all three varieties of meningitis, but not in viral meningitis, is the main take-home message from this particular one-liner. Then is CSF lymphocytosis with grossly increased proteins, and then they have given this image, which I think everybody is familiar now. This image from Instagram is famous, cobweb coagulum, and that helps you identify this as tubercular meningitis. Yeah, virus is on lean mode is a good point there. That would be tubercular meningitis. We'll be giving 880 to these patients with steroids. Steroids are mainly to treat the vasogenic cerebral edema in these patients. स्टेरॉइड्स CNS इन्फेक्शंस में देते हैं. कहाँ कहाँ देते हैं? तो न्यूरोसिस्टिक सर्कोसिस में देते हैं, ट्यूबरकुलर मेनिंजाइटिस में देते हैं, एंड दे आर ऑल्सो रिकमेंडेड इन पायोजेनिक मेनिंजाइटिस विद रिस्पेक्ट टू अमेरिका, बट नॉट इन इंडिया. डेवलपिंग कंट्रीज़ में पायोजेनिक मेनिंजाइटिस में हम स्टेरॉइड्स नहीं देते हैं. मैंने यहाँ पे प्लस माइनस लिखा है पायोजेनिक मेनिंजाइटिस के लिए. हारिसन में से लिखा है कि वेस्टर्न कंट्रीज़ में अगर किसी को पायोजेनिक मेनिंजाइटिस है तो स्टेरॉइड्स देने से सिक्वेले रिलेटिवली लेस कॉमन होते हैं. बट इंडिया के लिए, डेवलपिंग कंट्रीज़ के लिए सेज कि देर इज़ नो एडवांटेज ऑफ गिविंग स्टेरॉइड्स, क्योंकि उसके साथ फिर वो मोर्टेलिटी पार्ट, क्योंकि इम्यूनिटी वैसे ही लेसर रहती है, तो इज़ इंक्रीज्ड. But steroids are given even for pyogenic meningitis in Western scenario, and then we also give steroids for management of brain tumor, क्योंकि vasogenics इन सभी में ही vasogenic cerebral edema है. Steroids are not given in head injury. Steroids are not useful in head injury, but they are used. Steroids is useful for vasogenic cerebral edema. Steroids are useful for vasogenic cerebral edema. डिफ्रेंशिएट कैसे करते हैं? रेडियोलॉजी से बताओ, तुम लोग तो रेडियोलॉजी पढ़ते रहते हो. What is no, steroids are not given to prevent epilepsy, man. Steroids are given to reduce the cerebral edema component. In all of these, there would be perilesional edema. तो ये बताओ ना, how do you radiologically differentiate between cytotoxic cerebral edema and vasogenic cerebral edema? A general question to everybody listening to this discussion. How do you differentiate radiologically between, like अगर वो CT scan दे देगा तो आप कैसे डिफरेंशिएट करोगे? अगर वो हिस्ट्री दे दे फिर तो आसान है ना, कि भाई TB बोल दिया तो फिर तो आसान है, वेजोजेनिक सेरेब्रल एडीमा. और स्ट्रोक बोल दे तो फिर वो साइटोटॉक्सिक सेरेब्रल एडीमा. साइटोटॉक्सिक सेरेब्रल एडीमा इज हेड इंजरी. साइटोटॉक्सिक सेरेब्रल एडीमा इज स्ट्रोक. वेजोजेनिक सेरेब्रल एडीमा इज लाइक ट्यूबरकुलर मेनिंजाइटिस और ब्रेन ट्यूमर और न्यूरोसिस्टिक सर्कोसिस. या CT स्कैन करेंगे. मैं क्वेश्चन पूछ रहा हूँ भाई, फाइंडिंग क्या फाइंडिंग मिलेगी CT स्कैन में? साइटोटॉक्सिक सेरेब्रल एडीमा. Yes, guys, I've been speaking continuously. You guys need to comment. Cytotoxic cerebral edema को कैसे differentiate करते हैं? वेसोजेनिक सेरेब्रल एडीमा से। सर जो साइटोटॉक्सिक सेरेब्रल एडीमा होता है उसमें जो मेन रेडियोलॉजिकल फाइंडिंग होगी वो होगी लॉस ऑफ ग्रे मैटर एंड वाइट मैटर डिफरेंशिएशन, कि नॉर्मली ग्रे मैटर और वाइट मैटर अलग अलग दिखाई देता है, तो दिस इज लॉस ऑफ ग्रे मैटर वाइट मैटर डिफरेंशिएशन। और जो वेसोजेनिक सेरेब्रल एडीमा होता है वो सिर्फ वाइट मैटर को इन्वॉल्व करता है। वेसोजेनिक सेरेब्रल एडीमा ओनली कॉजेज वाइट मैटर का इन्वॉल्वमेंट, और इसमें जो ग्रे मैटर होता है वो स्पेड होता है, ग्रे मैटर की इन्वॉल्वमेंट नहीं होती है। इस पे मोस्ट स्टूडेंट्स की क्वेरी होती है कि सर ये तो बता दो कि ये होता क्या है, साइटोटॉक्सिक का मतलब क्या है, तो इंग्लिश लगाओ ना। साइटोटॉक्सिक का मतलब है कि सेल्स डिस्ट्रॉय हो रहे हैं, तो सेल की न्यूरॉन्स की स्वेलिंग हो गई। यहाँ पे हो क्या रहा है, अगर सिंपल भाषा में बताऊँ तो जो न्यूरॉन्स हैं, न्यूरॉन्स के अंदर स्वेलिंग है, इट इज़ द न्यूरोनल स्वेलिंग, कि न्यूरॉन बर्स्ट करने वाला है उसके अंदर स्वेलिंग हो गई है। और वेसोजेनिक सेरेब्रल एडीमा क्या होती है, दैट इज इंट्रा न्यूरोनल, मतलब दो न्यूरॉन्स के बीच का जो इंटरस्टिशियल स्पेस होता है ना, जो इंटरस्टिशियल स्पेस होता है वहां पे पानी भर जाता है। सो एक इंट्रा न्यूरोनल स्वेलिंग है दैट इज बिटवीन द न्यूरॉन्स, और एक में है न्यूरोनल सेल इटसेल्फ इज स्वोलन, दैट वुड बी साइटोटॉक्सिक एंड दैट इज वेसोजेनिक सेरेब्रल एडीमा। हाइपो इंटेंस वर्सेस हाइपर इंटेंस, नहीं, हाँ ठीक है, मतलब मैं ऐसे बोल सकता हूँ कि एक वाले में मतलब जो मोर है ये वाला एरिया ब्लैक दिखाई देगा, दैट्स ओके, क्योंकि स्ट्रोक है तो हाइपोडेंसिटी तो आनी ही आनी है। बट आई एग्री टू दैट कि एक में वाइट हो जाएगा एक में ब्लैक हो जाएगा, मतलब इसमें एरिया ब्लैक हो जाएगा। बट मेन जो रेडियोलॉजिकल फाइंडिंग है वो है कि अगर ग्रे मैटर वाइट मैटर का कंप्लीट डिफरेंशिएशन का लॉस है देन इट इज साइटोटॉक्सिक, एंड इफ इट इज ओनली वाइट मैटर की इन्वॉल्वमेंट एंड स्वेलिंग प्रेजेंट देन इट इज गोना बी लाइक वेसोजेनिक सेरेब्रल एडीमा। ओके। नहीं सर, इट्स नॉट, बोथ आर नॉट कॉज्ड बाय इश्कीमिया। वेसोजेनिक सेरेब्रल एडीमा इज ड्यू टू डैमेज टू द ब्लड ब्रेन बैरियर की परमेबिलिटी। जब भी ब्लड ब्रेन बैरियर की परमेबिलिटी चेंज हो जाती है तो इंटरस्टिशियल स्पेस में पानी भर जाता है, और वो जो इंटरस्टिशियल स्पेस में पानी भरता है उस ब्लड ब्रेन बैरियर की परमेबिलिटी को कम करने के लिए, इस ब्लड ब्रेन बैरियर की परमेबिलिटी को कम करने के लिए हम यहाँ पर स्टेरॉइड्स देते हैं। The condition right hand side is because there is increased permeability of blood-brain barrier, so water will accumulate between the neurons, and once the water is accumulating between the neurons, to prevent the further, accumulation of water, we give steroids because they reduce the permeability of the blood-brain barrier. हाँ, इंटर बोल दो, इंग्लिश लगा लो, बिटवीन में लिख देता हूँ ना, बिटवीन द न्यूरॉन्स। तो स्वेलिंग विच इज प्रेजेंट इज बिटवीन, ये मतलब इंटरस्टिशियल स्पेस है। इस यहाँ पे जो एडीमा प्रेजेंट है वो इंटरस्टिशियल एडीमा। आई थिंक दैट मेक्स इट मोर क्लियर। दो न्यूरॉन्स के बीच में जो जगह है इंटरस्टिशियल स्पेस, वहाँ पे स्वेलिंग प्रेजेंट है, तो ब्लड ब्रेन बैरियर की परमेबिलिटी कम करने के लिए हम स्टेरॉइड्स दे देंगे। लेकिन यहाँ तो हमें ब्रेन से बाहर पानी खींचना ही पड़ेगा, तो इसमें हम यूज़ करते हैं मैनिटॉल या हाइपरटोनिक सलाइन। और हाइपरटोनिक सलाइन तो मतलब जितनी ज़्यादा कॉन्सेंट्रेशन का यूज़ कर सके उतना ज़्यादा पॉसिबल है। जैसे बहुत बारी तो सिर्फ 30 cc देंगे, 23.4% का हाइपरटोनिक सलाइन कैन बी गिवन। इट कैन बी ऑब्वियसली बहुत बारी तो अवेलेबल नहीं होगा, बट आई जस्ट वांट टू ब्रिंग टू योर अटेंशन दैट हाई कॉन्सेंट्रेशन का बोलस दे देते हैं। इट इज़ लाइक 23% हाइपरटोनिक सलाइन। वो आपसे परसेंटेज नहीं पूछेगा, ही विल जस्ट एक्सपेक्ट यू टू आंसर दिस एज हाइपरटोनिक सलाइन फॉर मैनेजमेंट। बट या आई मीन दैट परसेंटेज इफ इट इज गिवन तो देन सिलेक्ट द हाईएस्ट परसेंटेज। तो दोनों में मैनिटॉल नहीं दे सकते बच्चे, मैनिटॉल दोनों में काम नहीं करेगा ना। मैनिटॉल जो होता है वो मेनली साइटोटॉक्सिक में काम करता है जिसमें न्यूरॉन के अंदर से पानी खींच रहा है। बट अगर इंटरस्टिशियल स्पेस में है ना तो वहां पे मेनली है कि वो मतलब मैनिटॉल अपना पानी तो खींचेगा, वो मैं मानता हूँ आपकी बात, लेकिन ब्लड ब्रेन बैरियर की परमेबिलिटी कम करने के लिए दवाई क्या दे सकते हैं, तो ब्लड ब्रेन बैरियर की परमेबिलिटी को कम, देखो मैनिटॉल तो एक ऑस्मोटिक एजेंट है तो उसने तो पानी खींचना है, तो अब मैं ये नहीं कह रहा कि मैनिटॉल विल नॉट वर्क ऑन द राइट हैंड साइड, इट विल वर्क ऑन द राइट हैंड साइड ऑल्सो, बट इट विल नॉट चेंज द रूट ऑफ द डिजीज। हम सिर्फ सिम्टम को ट्रीट नहीं करते ना, हम तो बीमारी का इलाज करते हैं। तो डिजीज का जो इलाज है वो है ब्लड ब्रेन परमेबिलिटी को कम करना। ओके जी, तो थोड़ा मिसलेनियस हो गया डिस्कशन, बट या आई थिंक यू गाइस वुड बी रीडिंग दिस इन रेडियोलॉजी ऑल्सो, दैट इज द कॉबवेब कोएगुलम पिक्ड अप। देन इज अ क्वेश्चन ऑन जीबीएस, आई थिंक ये तो मुझे पूछने की भी जरूरत नहीं है। द मूवमेंट यू गाइस विल रीड दिस information given on the slide, you will be able to identify the question is on Guillain-Barré syndrome। so मैं आपको सिर्फ एक निमोनिक से, फेम निमोनिक से यहाँ पे गुलियन-बारे सिंड्रोम का प्रैक्टिस करवा रहा हूँ। लेट्स डू अ क्विक प्रैक्टिस हेयर फॉर ब्राइटन क्राइटेरिया फॉर डायग्नोसिस ऑफ जीबीएस। where there would be a flaccid ascending symmetrical paralysis. तो F alphabet से आपने याद करना है that there is a flaccid ascending symmetrical paralysis that is occurring in this patient. Diaphragmatic paralysis भी हो सकता है, which can result in even death of this person. Then would be areflexia, because there is a lower motor neuron lesion. And alphabet A is also used to remember the albuminocytological dissociation. Albuminocytological dissociation mainly would mean that the proteins would be elevated लेकिन cells normal होते हैं. Alphabet M in this particular case is for monophasic course. M is for monophasic course. Monophasic course means the progression of paralysis can be so fast that person may go on a ventilator within 12 hours. But in some cases, the progression can be relatively over a couple of weeks. So the progression can be over 28 days. And alphabet E is electrodiagnostic studies. Comment in the chat box. Those guys who are silent, please comment in the chat box. Electrodiagnostic studies क्या करते हैं Guillain-Barré syndrome में? What is the electrodiagnostic studies that you will be doing in this particular case? Yes, guys. बोलो बोलो यार. Yes, nerve conduction velocity, and nerve conduction velocity में the latency period in this case is going to be increased. So fame mnemonic is used to remember regarding GBS, that is Guillain-Barré syndrome, for which intravenous immunoglobulin is always to be answered superior to plex, that is plasmapheresis. Efficacy of both of them is equal. ये इन्हीं सेट में पूछा था. Efficacy of both of them is equal, but which one is preferred is, then what Harrison says is intravenous immunoglobulin over plasmapheresis, because plasmapheresis would require a much more extensive I would say setup to be used. Okay, child from village is brought with fever with altered sensorium for 1 day. The CSF study is normal, but there is anemia, and ABG shows metabolic acidosis in this particular case. Looks to be a metabolic encephalopathy initially to me, but there is no mention of like metabolic encephalopathy. Diabetic ketoacidosis के लिए तो I need to use a triad. I mean, the sugar should demonstrated to be elevated. There should be ketonemia, ketonuria, and acidosis. So because there is anemia, that is one hint. And because in malaria the RBCs become sluggish, so there can be microcirculation which can become sluggish in malaria. That sluggish microcirculation can explain the metabolic acidosis component. So the correct answer in this case would be option number C, that is cerebral malaria. Viral meningitis is ruled out because at least cells should be there, proteins should be elevated. So in both kinds of meningitis, there would be like a cellular response. CSS study will not be normal. Diabetic ketoacidosis will need triad or decay to be solved. So you can solve this question by exclusion capability. And a reason for cerebral malaria is because cerebral malaria is caused by Plasmodium falciparum, and falciparum क्या करेगा कि वो अनीमिया भी कर देगा और वो साथ में सर्कुलेशन स्लगिश रखता है, क्योंकि मलेरिया पैरासाइट के जैसे आरबीसी स्टिकी हो जाते हैं, तो इसलिए क्योंकि स्टिकी आरबीसीज है तो देयर वुड बी लाइक अ स्लगिश सर्कुलेशन, एंड दैट्स गोना इंटरफेयर विद I would say gas exchange of the cells को ऑक्सीजन नहीं मिलेगी तो they'll go into anaerobic mode of respiration which will contribute to this manifestation. प्रोटोजोआ वो उसमें होते हैं यार ब्रेन ईटिंग अमीबा में ना, वो जो ब्रेन ईटिंग अमीबा होता है ना नेगलेरिया फाउलेरिया, उसमें ट्रोफोजाइट्स इन द सीएसएफ होता है. इफ आई हैव सेड ट्रोफोजाइट्स इन द सीएसएफ एंड इंक्रीज प्रोटीन, दैट वुड बी विद नेगलेरिया फाउलेरिया, दैट इज प्राइमरी अमीबिक मेनिंगोएन्सेफलाइटिस. सो एट द मोमेंट व्हाट वी आर डिस्कसिंग इज अ केस ऑफ typical complicated malaria, cerebral malaria. 1 day ka history with anemia with microcirculation that is sluggish. Okay, ji, we now come to a very favorite aspect with NEET PG people also love to ask, that is APG analysis. We'll try to do fast here. You're all aware of that Rome mnemonic and all those things. So I'll go like this. pH is low, PCO2 is also low. All three arrows are going down, down, down. So because all three are going down, it becomes metabolic acidosis. Now, once I know it is metabolic acidosis, I will apply the modified Winters formula. And modified Winters formula is used to calculate the expected PCO2. This formula is used to calculate the expected PCO2. The expected PCO2 of this patient would be turning out to be 25 millimeters of mercury. But actual PCO2 is not 25. If you check out the report here, you will notice that the actual PCO2 of the patient is relatively much higher, because the actual PCO2 and the expected PCO2 is not matching. That is why this is not a compensation. I repeat this once again. because the expected PCO2 and the actual PCO2 is not matching, so it is not a compensation. You cannot answer it as respiratory alkalosis. Rather, in this patient there is two types of acidosis, metabolic and respiratory. When I say like this, the query of a lot of people is, sir, what are you saying? PCO2 is 30 only. PCO2 should be more than 45 for respiratory acidosis. That is the point, guys, that respiratory acidosis 45 के ऊपर जाके होता है, but यहाँ पे तो PCO2 30 है ना. आपको comparison में देखना है that 30 value is higher than the value 25. That means person is having hypoventilation, and because of the hypoventilation component, the carbon dioxide could not be kicked out, and therefore it is higher than what it is present at the moment. That is why we are calling this as metabolic acidosis with respiratory acidosis. I repeat this once again. In all questions of metabolic acidosis, always apply the Winter's formula. I think this is easier to apply, modified Winter's formula, and you have to add 15 to the value of bicarbonate. Both values should be matching, because both values are not matching, so you will say the person is having metabolic acidosis with respiratory acidosis. Reason for that hypoventilation could be person could be having hypokalemia, so the diaphragm could not be compensating properly. That is why PCO2 की वैल्यू 30 है. मैं मानता हूं कि 45 से ज्यादा पे हम रेस्पिरेटरी एसिडोसिस बोलते हैं, लेकिन यहाँ पे 45 ना होने के बावजूद भी, उससे ज्यादा ना होने के बावजूद भी रेस्पिरेटरी एसिडोसिस बोल रहे हैं, बिकॉज पर्सन को हमने डेमोन्स्ट्रेट किया हाइपोवेंटिलेशन है. क्योंकि वैल्यू 30 एक्चुअल वैल्यू है 30, उसको हो जानी चाहिए थी 25, तो बॉडी उसको कर नहीं पाई ना, तो कॉम्पेंसेटरी यहाँ पर नहीं है. सो इट इज अ मिक्स्ड डिसऑर्डर गाइस. यहाँ पे दिस इज नॉट अ क्वेश्चन ऑफ कॉम्पेंसेटरी. तो आपको बेसिक कंसेप्ट ये सीखना है कि कॉम्पेंसेशन और मिक्स में डिफरेंशिएट कैसे करते हैं. विंटर्स फॉर्मूला लगा के अगर दोनों वैल्यूज मैच कर गई तो बोलते हैं कॉम्पेंसेशन, और अगर मैच नहीं करती हैं तो बोलते हैं मिक्स्ड डिसऑर्डर. द आंसर टू दिस वन इज ए. अब इसको अगले वाले से कंपैरिजन करो. जो अगला सवाल है उसमें भी यू कैन सी ऑल द थ्री एरोज आर गोइंग डाउन डाउन एंड डाउन, सो इट ऑल्सो बिकम्स मेटाबॉलिक एसिडोसिस. बट नाउ व्हाट आई विल डू इज आई विल अप्लाई द सेम मैथमेटिकल फॉर्मूला इन माई माइंड, बिकॉज एग्जाम में कोई पेपर पेंसिल तो मिलता नहीं है. सो व्हाट यू नीड टू डू इज एक्सपेक्टेड PCO2 वट एवर इज द वैल्यू गिवन इन द क्वेश्चन ऑफ बाइकार्बोनेट, लाइक द वैल्यू ऑफ द बाइकार्बोनेट इन दिस क्वेश्चन इज 15 + 15 करना है. सो द टोटल वैल्यू विल टर्न आउट टू बी 30 मिलीक्यूलेंट. यू कैन सी कि एक तो एक्चुअल PCO2 है. The actual PCO2 of the patient is also 30, and the expected value is also turning out to be 30, because both mathematical values in this case are matching. That is when now you will say there is a compensation occurring in this case. So this time you will say like this: person is having metabolic acidosis with compensatory. That's the point, with compensatory रेस्पिरेटरी एल्कोलोसिस. वो तो आपको पता ही है कि कॉम्पेंसेशन गोज ऑपोजिट टू द प्राइमरी चेंज, तो उसमें कोई दिक्कत नहीं है. बट द मेन एस्पेक्ट टू बी रिमेंबर्ड इज कि अगर ये वैल्यूज जैसे मैंने मैचिंग दिखाई है, दोनों वैल्यूज मैच हो जाए तभी कॉम्पेंसेशन बोलना. अगर वैल्यूज मैच नहीं होंगी एंड द वैल्यू गिवन इन द क्वेश्चन इज टर्निंग आउट टू बी हायर देन व्हाट यू हैव कैलकुलेटेड, देन इट इज लाइक द बॉडी उस लेवल तक लेकर ही नहीं पाई. वो बॉडी क्यों नहीं ला पाई? क्योंकि वहाँ पे मिक्स डिसऑर्डर है, पढ़ने को कार्डियो रेस्पिरेटरी अरेस्ट रहा होगा. सो बेसिक पॉइंट याद रखना है कि दिस वुड बी the first question is on mixed disorder and the second one is on compensatory disorder. अभी देखो uncompensated भी बताता हूँ, अभी uncompensated भी पढ़ेंगे. यहाँ तो compensation होगी ना, क्योंकि पर्सन का PCO2 कम हो गया, 30 हो गया, तो मतलब नॉर्मल से कम हो गया ना, तो compensation तो वर्क कर रही है, बट it's a compensatory PCO2 that is occurring in the patient. So the point to be understood is, yeah, it's partial compensation. Actually, yes, you are right, it is partial compensation that is happening, but at the same time what you have to understand is दैट कॉम्पेंसेशन या मिक्स्ड बोलने के लिए आपको मेन डिफरेंस याद रखना है, एंड दैट मेन डिफरेंस वुड बी दैट इफ द वैल्यूज, जो दोनों वैल्यूज हैं वो मैच करनी चाहिए. मैचिंग हो रही है तो आप बोलना कॉम्पेंसेशन, मैच नहीं होगी तो आप बोल देना मिक्स्ड डिसऑर्डर. ओके, नाउ वर्कआउट करते हैं एक और सवाल. ये इन्हीं सेट का था. इन दिस सवाल व्हाट इज हैपनिंग इज दैट complete compensation, everything will normalize, man. That is perfectly okay. pH will normalize. Previous question, uncompensated metabolic acidosis. No. This is again PCO2 कम हो गया ना, 30 तो है, 35 से तो कम ही है ना यार, तो इट इज स्टिल अ मिक्स्ड डिसऑर्डर. इट्स अ मिक्स्ड डिसऑर्डर. मैंने जिस तरीके से मैंने बताया ना, इसको मैथमेटिक्स तरीके से सॉल्व करना, देन यू विल बी एबल टू फिगर इट आउट. ओके, in the next question what happened was pH was normal, PCO2 was normal and bicarbonate was normal. तो लग रहा था कि नॉर्मल रिपोर्ट है. Initial impression is everything is normal. But when you calculate the anion gap of the patient, the anion gap of the patient is significantly elevated. So elevated anion gap is telling me that in this particular case, there is some kind of error of judgment present, in a sense that the report is factitiously normal. Now, why is the report normal? Uska reason dekhte hain. The reason why the report is normal in this case is because CKD will contribute to metabolic acidosis in this case. Chronic kidney disease will contribute to metabolic acidosis, and vomiting will cause loss of acid from the body. When the person will be doing vomiting multiple times, then loss of acid will contribute to metabolic alkalosis. So though the ABG report of this person is normal, the point to be understood is that metabolic acidosis is counterbalancing metabolic alkalosis, which is why in this case the report is falsely normal. This is a falsely normal report. The reason for that falsely normal report is that there is metabolic acidosis and metabolic alkalosis both occurring in a patient. So the interpretation in this case is HAGMA, high anion gap metabolic acidosis, plus there is a HAGMA, that is a high anion gap metabolic acidosis, and along with that metabolic alkalosis. In the MCQ he mentioned normal report also, लेकिन मुझे पता कैसे चला कि रिपोर्ट falsely normal है कि anion gap बढ़ा हुआ था. ट्रेडिशनली तो इसको इवेल्युएट करने के लिए डेल्टा रेशो कैलकुलेट करनी होती है. डेल्टा रेशो इज चेंज ऑफ anion gap डिवाइडेड बाय चेंज ऑफ बाइकार्बोनेट, लेकिन ऑल दैट कैलकुलेशन वुड बी टू मच टू डू इन अ एग्जाम. सो माय पॉइंट वुड सिंपली बी दैट एनी पेशेंट ऑफ CKD, क्योंकि CKD में किडनी खराब हो जाता है, सो देयर इज इनएबिलिटी टू एक्सक्रीट हाइड्रोजन, there is inability to excrete potassium. Yes, CKD causes hyperkalemia. CKD causes hyperkalemia, but because we give diuretics to this patient, they can be hypokalemia also. Point is, CKD has hyperkalemia, I agree to it. There are two reasons why in this MCQ potassium is low. There are two reasons why potassium is low in this question. I think that is the query that one doctor is asking, sir, potassium kam kaise ho gaya? So one reason for hypokalemia in this patient is GI losses, because patient has been having vomiting, so GI losses ho sakte hain. The second reason for this patient's hypokalemia can be because the person was started on treatment with furosemide for the renal shutdown, or was put on thiazides. Maybe we might not be giving furosemide, we might be giving thiazides on long-term basis. That can contribute to it. So I agree to the fact that CKD should be causing a hyperkalemic metabolic acidosis. But in this question, why is potassium low and value of only 3 is given? Is I have given explanation for the same. One can be vomiting ho raha hai, and second is furosemide or thiazide that has been used in this patient. But the main point is कि ABG in this condition is falsely normal. We will not say normal ABG report because there are two things which are gonna be counterbalancing each other. So at the moment, 3 concepts have been added. One is a question on metabolic acidosis where actual and expected PCO2 values are not matching. One is 30 and 25, as you can see. So if they're not matching, mixed disorder. If they're matching, then you say compensation. That is partial compensation. This is also written as, इसी का दूसरा नाम होता है जो मैंने रूटीन ऐप में समझाया हुआ है कि हम इसको बोलते हैं partially compensated metabolic acidosis. This is alternative term for partially compensated metabolic acidosis. Both of these statements mean the same. Both are going to be identical. In the third report, as I said, it's HAGMA with metabolic alkalosis, reasons explained. Now comes that questions of like uncompensated COPD exacerbation. Patient is having PCO2 of 60. So I know it is respiratory acidosis. But at the same time, in this chap, bicarbonate abhi normal hai. That bicarbonate is turning out to be normal in this patient because the kidneys have not started compensation. So you will say uncompensated respiratory acidosis. The key word in this particular question is normal value bicarbonate. That's why we're calling it uncompensated. अब इसको compare करना अगले question से. Here pH is less and PCO2 is elevated 60. Same question, but with a slight difference of value. You can see that in this question there is still respiratory acidosis. इतना तो सबने वर्कआउट कर ही लिया होगा क्योंकि वैसे भी तो एस्थमा बोल रहा है, नेबुलाइजेशन सल्बुटामोल बोल रहा है. So there has to be like respiratory acidosis subsequently occurring or can occur because of patient progressing to status asthmaticus. But now the kidney is helping. तो इसमें बाइकार्बोनेट धीरे धीरे बढ़ना शुरू हो गया. 26 अपर लिमिट होती है, 28 हो गया. यहाँ पे रूल लगाते हैं 10:1 का. फॉर एवरी 10 पॉइंट इंक्रीज इन कार्बन डाइऑक्साइड, अगर कार्बन डाइऑक्साइड 40 से 50 होता है तो बाइकार्बोनेट की जो वैल्यू है इट शुड इंक्रीज बाय 1 मिली इक्विवेलेंट। ये एक बेसिक रूल होता है रेस्पिरेटरी कॉम्पनसेशन का कि कार्बन डाइऑक्साइड 10 पॉइंट बढ़ेगी तो बाइकार्बोनेट 1 पॉइंट बढ़ना चाहिए। अगर कार्बन डाइऑक्साइड 40 से 60 हो गई, 20 पॉइंट का इंक्रीमेंट, तो बाइकार्बोनेट 2 पॉइंट इंक्रीज होना चाहिए। सो बिकॉज दिस रूल इज बीइंग सैटिस्फाइड, वी विल से पर्सन इज हैविंग पार्शियली कॉम्पनसेटेड। We'll say the person is having yes, Sachin, you're right. This would be partially compensated respiratory acidosis in a patient. The reason for that being why partially compensated, because bicarbonate सिर्फ 2 पॉइंट का राइज है, सिर्फ 2 पॉइंट का राइज है, बट दैट 2 पॉइंट का राइज अलोन इज सफिशिएंट फॉर अस टू से कि हाँ यार ठीक है, मतलब कि ना एटलीस्ट किडनी कुछ तो मदद कर रही है। सो दैट्स व्हाई वी कॉलिंग इट partially compensated respiratory acidosis. Just a slight difference from the value from the previous question. अब इसका अगला देखते हैं। उसमें पेशेंट में आप देख रहे हैं कि पीएच बढ़ा हुआ है और पीसीओ2 कम है, तो अगेन एरोज उल्टा उल्टा चल रहे हैं। सो वेन एवर एरोज आर गोइंग इन ऑपोजिट डायरेक्शन, इट्स अ रेस्पिरेटरी प्रॉब्लम एंड डिसाइडिंग फैक्टर इज ऑलवेज द पीएच। सो इसको बोलेंगे रेस्पिरेटरी एल्कोलोसिस। आई वांट यू टू हिट द चैट बटन एंड लेट मी नो इसमें क्या लिखूं। बाइकार्बन नॉर्मल नहीं है ना, तो क्या लिखूं, अनकॉम्पेंसेटेड लिखूं या पार्शियली कॉम्पेंसेटेड लिखूं? इफ यू थिंक अनकॉम्पेंसेटेड, हिट द चैट बटन, राइट यूसी। And if you want to say partially compensated, write the word PC. So I'm waiting for your answers here for the current question in the discussion. Yes, guys. Very good. Very good. We'll hit the words there. The correct words are, because bicarbonate in this question is turning out to be less. That means that it's not normal. So इसको uncompensated नहीं बोल। अगर ये normal होता तो बोलते हैं uncompensated। किडनी कह रही है भाई मैं क्या करूँ, अपने आप से देख लो। लेकिन अगर किडनी मदद करके बाइकआउट बाहर फेंक रही है, दैट इज द कॉम्पेंसेशन, तो इसको बोलेंगे पार्शियली कॉम्पेंसेटेड। दिस वुड बी कॉल्ड एज पीसी, that is partially compensated respiratory alkalosis in a COVID-19. Yeah, 10:4 ka rule is satisfied. Sachin, you are right in that. But I had very good inputs there. The basic point is, in the same MCQ, I'll use a different ink to highlight this. Suppose in the same MCQ, the bicarbonate report was 24, it is normal. Then the same report will be answered by you as UC, that means uncompensated respiratory alkalosis. दैट्स द बेसिक पॉइंट टू बी अंडरस्टूड कि रेस्पिरेटरी प्रॉब्लम में बाइकार्बोनेट देख लो, अगर वो नॉर्मल होगी तो यूसी बोल देना, और अगर चेंज हो जाएगी, मैं तो इंक्रीज डिक्रीज भी नहीं बोल रहा यार, मैं बोल रहा हूँ अगर नॉर्मल होगी तो अनकॉम्पेंसेटेड बोल देना, अगर चेंज हो जाएगी तो देन इट इज गोना बी आंसर्ड एज पार्शियली कॉम्पेंसेटेड। ओके, नेक्स्ट इज गैस्ट्रिक आउटलेट ऑब्स्ट्रक्शन ड्यू टू गैस्ट्रिक एडिनोकार्सिनोमा। तो वैसे ही समझना है कि पेशेंट को वॉमिटिंग हो रही है, देयर इज लॉस ऑफ एसिड, क्योंकि गैस्ट्रिक आउटलेट ऑब्स्ट्रक्शन लिखा हुआ है, तो लॉस ऑफ एसिड होगा तो मेटाबॉलिक एल्कोलोसिस ही होगा। और इसमें आप देखो ना सारी चीज़ें तो बढ़ रही हैं, pH is more, PCO2 is more, bicarbonate is more. So because even if I don't go into the mathematical rule in this question, simply saying or reading the fact that there is loss of acid from the body will contribute to metabolic alkalosis to be a presentation in these patients. Yes. अब मेरी हेल्प करो थोड़ा सा, क्या लिखूं यहाँ पे, अनकॉम्पेंसेटेड लिखूं या पार्शियली कॉम्पेंसेटेड लिखूं? PCO2 नॉर्मल है ना, 45 है, तो क्या लिखेंगे? Yes, guys. Quick comments there with respect to whatever you think is the correct answer for this one. Yes. Fine, fine. तो दोनों ही responses आ रहे हैं, uncompensated भी और partially compensated भी। चलो इसमें विंटर्स फार्मूला लगाओ ना पहले, मुझे विंटर्स फार्मूला लगाओ, इसमें भी 15 ही तो ऐड करना है ना। You have to add विंटर्स फार्मूला in this question also. मेटाबॉलिक एसिडोसिस और मेटाबॉलिक एल्कोलोसिस के एमसीक्यू में विंटर्स फार्मूला लगाते हैं। वो विंटर्स फार्मूला में आप निकालो इसकी एक्सपेक्टेड पीसीओ2 कितनी होगी। बाइकार्बोनेट की वैल्यू 30 है ना, 30 में 15 जोड़ोगे तो 45 आ जाएगा। हो रही है ना मैचिंग, तो क्योंकि मैचिंग हो रही है तो बोलेंगे दैट इज पार्शियली कॉम्पेंसेटेड। बेसिक कॉन्सेप्ट है कि वो तो पहले तो नॉर्मल से समझा रहा था यार आपको, लेकिन अभी तो हमने मेटाबॉलिक वाले केस में यहाँ पे विंटर्स फार्मूला निकालना है। जब भी मेटाबॉलिक एसिडोसिस या मेटाबॉलिक एल्कोलोसिस होता है तो मेटाबॉलिक एसिडोसिस और एल्कोलोसिस वाले सवालों में विंटर फार्मूला हमेशा लगाना है। विंटर्स फार्मूला से माइंड में कैलकुलेशन करना, इसका निकालना क्या है, एक्सपेक्टेड पीसीओ2। तो जो भी बाइकार्बोनेट की वैल्यू दी हुई होगी उसमें 15 ऐड कर देना। जैसे यहाँ बाइकार्बोनेट की वैल्यू 30 दे रखी है, आप 15 जोड़ देंगे तो वैल्यू हो जाएगी 45 मिलीक्यूलेंट्स। तो इसका मतलब है कि जो एक्चुअल वैल्यू दे रखी है और जो एक्सपेक्टेड वैल्यू वो मैच कर रही है, जब ये दोनों वैल्यूज मैच करती है मतलब कॉम्पेंसेशन इज वर्किंग इन दिस केस, तो हम बोलेंगे दिस इज पार्शियली कॉम्पेंसेटेड। पीसी वर्ड आएगा यहाँ पे, पार्शियली कॉम्पेंसेटेड मेटाबॉलिक एल्कोलोसिस इन दिस पेशेंट। एवरी टाइम इन अ क्वेश्चन ऑफ मेटाबॉलिक और एसिडोसिस और एल्कोलोसिस में आपने हमेशा विंटर्स फार्मूला लगाना है, उसमें 15 जोड़ देना, वैल्यूज मैचिंग मैचिंग हो जाए तो कॉम्पेंसेशन बोल देना, पार्शली कॉम्पेंसेटेड हमेशा वर्ड हो जाएगा। अगर ये वैल्यूज मैच नहीं कर रही होती तो मिक्स डिसऑर्डर भी हो सकता था। हाँ, वन अनदर वे ऑफ फार्मूला इज, उसमें फिर टू स्टेप है ना, 1.5 इंटू वैल्यू ऑफ इंटू 8, 1.5 इंटू 8 करके फिर प्लस माइनस 2 करते हो ना। तो पहले मल्टीप्लाई करोगे, फिर ऐड करोगे, फिर सब्ट्रैक्ट करोगे, तो वो तो ज़्यादा हैसल हो जाएगी ना। तो मैंने आपको यहाँ पे जो बताया वो मॉडिफाइड विंटर्स फार्मूला है। आप दोनों में से जो भी आपकी मैथमेटिक्स स्ट्रांग हो उसके हिसाब से कर लेना। मेरी तो मैथ्स कमज़ोर है, इसलिए मैंने यहाँ पे ये मेंशन भी किया था। देखो, देर आर टू फार्मूलाज, एक विंटर है, एक मॉडिफाइड विंटर है, 1.5 इंटू बाइकॉर्ड प्लस 8, और उसके बाद में प्लस माइनस 2 यहाँ पे, 8 प्लस माइनस 2। So if you wanna go ahead with this, I mean, be my guest. But I think that one step addition is like reduces the load on the brain. So use these questions as a prop. पहले तो वो जो दो वीडियोस हैं मेरे एपीजी के एनालिसिस वाले, उनको सॉल्व करना है, और उसके बाद में subsequently you need to focus on these aspects that I said. Let's do it once more. Okay, this time we are doing a calculation. We will have to calculate soda bicarbonate ka correction in this patient. I'll just make a small improvement in the font of this question, and meanwhile you guys can do some basic mathematical calculations here. The question is regarding soda bicarbonate correction that we are giving to this patient, 60 kg patient in a case of uremia, and we have to give metabolic alkalosis. Yeah, you go with addition. Absolutely. Just go to the addition part. First, take up those questions in the basic two videos and then subsequently add the information that is being did. So, soda bicarbonate in 60 kg. Sir, जो formula होता है वो था 0.5 into weight into the desired value. The desired value will be 25 minus 24 minus the actual value of bicarbonate in the question. If I do this calculation, you guys can help me with mathematics here. It would be 0.5 into 60 into 24 minus the actual value of bicarbonate, which is 10. So 24 minus 10. You guys can help me here. About 420 milliequivalents. Also make a habit in all questions on metabolic acidosis to work out regarding the anion gap. So I'm going to do that mathematics here before you. 135 minus potassium kabhi nahi lena usme. Never take potassium in that. This is again high anion gap metabolic acidosis. 135 minus 105, that would be 20 approximately. So the final interpretation is, वैसे तो देखो मुझे यूरीमिया से समझ में आ गया था कि हैगमा ही होगा, but still मैंने mathematical calculation करी. So the final aspect is this guy is having hagma, high anion gap metabolic acidosis, and we are treating it by giving soda bicarbonate. Formula is 0.5 into weight into 24 minus the actual value in the patient. Yeah. इसमें भी कॉम्पेंसेशन पूरी नहीं है ना, इट इज़ नॉट कॉम्पेंसेशन ना, क्योंकि 10 प्लस 15 करोगे तो 25 आना चाहिए। ओके फाइन, पार्शल कॉम, क्योंकि वैल्यू कम हो गई, मतलब 25 से नीचे चलेगी तो ओवर कॉम्पेंसेट कर दिया, तो कॉम्पेंसेशन तो है यहाँ पे। मिक्स्ड नहीं बोल सकते इसको, इसमें भी पार्शल कॉम्पेंसेशन ही आएगा। परफेक्टली फाइन, बिकॉज द गाय इज हाइपर वेंटिलेटिंग, एंड दैट इज द रीजन वाई दिस इज कॉन्ट्रीब्यूटिंग टू पार्शल कॉम्पेंसेशन। ओके, बच्चे इसको अनकॉम्पेंसेटेड नहीं बोलेंगे, बिकॉज अनकॉम्पेंसेटेड अगर मैं बोल रहा होता तो PCO2 नॉर्मल होना था ना। अगर मैं इस सवाल में PCO2 आपको देता 35 40 तो अनकॉम्पेंसेटेड होता। आई रिपीट माई स्टेटमेंट, अगर PCO2 इस क्वेश्चन में नॉर्मल होता तो मैं बोलता अनकॉम्पेंसेटेड। अब मेरे को देखना है कि मैं पहले विंटर फार्मूला लगा लेता हूँ, तो अगर 10 प्लस 15 करूंगा तो 25 आना चाहिए, तो 20 है ना, कम है। एक सवाल में तो ज़्यादा आ रहा था तो मैंने मिक्स्ड बोल दिया था, ये तो कम हो गया तो ओवर कॉम्पेंसेशन हो रही है ना, तो ज़्यादा ब्रीथ कर रहा है उससे दिक्कत नहीं है। So if the value is equal or lesser, not a problem. But if it is higher, then it is a mixed disorder. Okay. The answer in this question is 420 milliequivalents on the basis of calculation that I've done. थोड़ा इजी कर लेते हैं, प्रेशर थोड़ा, मैथमेटिक्स डॉक्टर्स की हमेशा ऐसी रहती है हम लोगों की कि इट्स ऑलवेज अ चैलेंज, बट देन लेट्स जस्ट कूल अ बिट. A cytic tap is showing 600 neutrophils in a patient, and at the same time in the patient there is abdominal pain. तो ascites वो दिखाया है, और ascites के साथ में neutrophils are present, polymorphonuclear cells are present, man, neutrophils are present in the ascitic fluid. So that would mean that there is infection present, and that would mean that the answer for this would be great. Pritam, good evening. या SBP होगा, एस से BP थोड़ा सा स्पेलिंग मिस्टेक हो गया, इट इज स्पॉन्टेनियस बैक्टीरियल पेरिटोनाइटिस। ओके, yes, SBP, spontaneous bacterial peritonitis, which is transmigration of E. coli, which is responsible for this. शैलेश, अपना क्वेश्चन एक बार रीफ्रेज करो तो आई थिंक आपको क्लैरिटी हो जाएगी। थोड़ा सा टाइम लगेगा बट थोड़ा सा अगर उसको दोबारा से सुनोगे तो इट विल बिकम क्लियर इन कॉम्बिनेशन विद वट एवर आई हैव सेड, देन थिंग्स बिकम मच मोर क्लियर। ओके, मूविंग टू 64, दिस इज अगेन अ हॉट फेवरेट ऑफ अवर एग्जामिनर। साइड देखो, लाइट्स क्राइटेरिया पे सवाल आना है, सैग पे क्वेश्चन आना ही आना है। अब वो सैग को याद कैसे करना है, तो उसके लिए पहले तो मैंने निमोनिक यहाँ पे मेंशन किए हैं, तो पहले तो आज ना आप बैठ के इनकी प्रैक्टिस करना कि जैसे अगर वो बोलता है कॉजेज ऑफ लो सैग या कॉजेज ऑफ हाई सैग, तो सैग की लो सैग मतलब वैल्यू शुड बी लेस देन 1.1। तो उसको मैंने अलग अलग तरीके से समझाने की कोशिश करी है बट वो यूजुअली वर्कआउट नहीं होता। तो अभी फिर मैंने फाइनली आई पोस्टेड दिस ऑन माई इंस्टाग्राम ऑल्सो इन निमोनिक है पिंस, पेरिटोनियल कैंसर, इन्फेक्शन, नेफ्रोटिक एंड सीरोसाइटिस लाइक पैंक्रेटाइटिस। तो पिंस निमोनिक से याद करना है, कॉजेज ऑफ लो सैग इन अ पेशेंट। But when it comes to high sag in a patient, the mnemonic is CHIMP. That would be cirrhosis, heart failure, IVC obstruction, massive liver metastasis. And then it's gonna be like Budd-Chiari syndrome also added, because portal vein thrombosis बोले या फिर ultimately hepatic vein thrombosis, there would be Budd-Chiari syndrome occurring in the patient. The question is, ascitic protein value is less than 2.5 and SAG is more than 1.5. This would be a feature that is seen in cirrhosis. Nephrotic syndrome is an example of a condition जो है तो transudate but is gonna be having a low SAG. देखो, सिरोसिस भी ट्रांसुडेट होता है और नेफ्रोटिक भी ट्रांसुडेट होता है, बट दोनों में मैथमेटिकल यहाँ पे डिफरेंस आ जाता है। तो आपको ये याद करना है कि नेफ्रोटिक सिंड्रोम इज वन कंडीशन वेयर दे वुड बी ट्रांसुडेटिव प्लूरल एफ्यूजन एंड असाइटिस, but it will be having a low sag value that is less than 1.1, but the remaining ones that you need to remember would be values much more higher. मेटाबॉलिक एसिडोसिस में, हाँ फर्स्ट मैं तो टोटल कैलकुलेशन करवा रहा हूँ ना बच्चे। शैलेश, आपने जो क्वेश्चन पूछा कि आपने 15 तक कराया या पहले 15, पहले पहले कुछ घंटों में 15 तक करेक्ट करते हैं, फिर टोटल करेक्शन जो है 24, तो टोटल तो 24 ही है ना। तो आई मीन आई डेलिबरेटली डिड नॉट मेंशन इनिशियल करेक्शन, टोटल करेक्शन इज अप टू 24 ओनली। Okay, Ji, the correct answer for this one is cirrhosis. This is a table which is extensively asked with respect to causes. So a bit of practice of these has to be done. और जो इसमें मेन जो पिकअप पॉइंट रहता है वो ये है जो लास्ट में मैंने मेंशन किया हुआ है, इसको थोड़ा प्रैक्टिस कर लेना। बर्ड-चियारी सिंड्रोम अर्ली या लेट, I repeat it guys, as all NEET PG aspirants you need to be very clear about this. बर्ड-चियारी सिंड्रोम में ना लेट स्टेजेस में क्योंकि फाइब्रोसिस हो जाता है तो फिर प्रोटीन लीक नहीं कर पाता है, लेकिन अर्ली स्टेजेस में एसाइटिक फ्लूइड की प्रोटीन की मात्रा मोर देन 2.5 होती है। Whenever you will check out these questions ना, वो सैक की वैल्यू देगा आपको 1.1 से ज़्यादा, और फिर वो बर्ड-चियारी सिंड्रोम में अर्ली और लेट में घुमाएगा, दोनों ऑप्शन में दिए होंगे। तो आपने देखना क्या है सवाल में कि बर्ड-चियारी सिंड्रोम में लेट स्टेजेस में क्या होता है, फाइब्रोसिस होने की वजह से प्रोटीन लीक नहीं कर पाता है, बट इनिशियल स्टेजेस में प्रोटीन इजीली लीक कर जाता है क्योंकि ऑब्स्ट्रक्शन है तो प्रेशर बढ़ जाएगा, प्रेशर बढ़ेगा तो प्रोटीन लीक कर पाएगा। तो एसाइटिक फ्लूइड का जो प्रोटीन का प्रेजेंटेशन होता है दैट विल बी एसाइटिक फ्लूइड प्रोटीन की वैल्यू मोर देन 2.5 होती है। I hope guys it makes sense. Budd-Chiari syndrome is obstruction. So obstruction will cause an increase in pressure, and that increase of pressure की वजह से एसाइटिक फ्लूइड प्रोटीन की वैल्यू बढ़ी हुई होगी, बट एट द सेम टाइम लेटर में फाइब्रोसिस हो जाएगा तो उस वजह से एसाइटिक फ्लूइड प्रोटीन की मात्रा गिर जाती है। So you need to go through those questions on this topic, but then I've tried to mention two mnemonics here, PINS and CHIMP here, which I think are simpler as compared to the traditional BNP करके मैंने बताया, बट उससे फिर वो पूरा कवर नहीं होता, मैंने उसमें थ्योरी करी है। So point is, abhi I'm trying to like make it faster analysis. So this is the add-on which I would like you to add to your topic of ascites so that you can remember the things relatively better. If you're not a mnemonics person, तो फिर तो मैं बोलूँगा जो मैंने थ्योरी में पढ़ा है उसको पढ़ लेना रैपिड रिवीजन से। बट सपोज आप कहते हो कि सर ascites वाले में वो टेबल याद नहीं होता है and like I'm not able to figure out the causes, then this is the additional information which if added to that original table will make it like faster ability to recall. I mean, if you say you're not a mnemonics person, no need of going into it. But otherwise, like, yep, this would help you make it things relatively faster. Okay. Okay, Ji, the next one that we do is much more simpler. Lung cancer patient with prominent neck veins indicates a possibility of superior vena cava syndrome, because lung cancer, if it's causing prominence of neck veins, it could be pressing on the superior vena cava that will cause elevated JVP, and SVC syndrome would be a pause. But if he says there is prominent neck veins and electrical alternates given in a question, that tells us that now we're not talking about SVC syndrome, but the cancer has gone to the heart. And if the cancer will go to the heart of the patient, then we are talking about a possibility of cardiac tamponade or a massive pericardial effusion that is developing in this patient. So the one word difference will be seen in the one-liner question. If he does not mention regarding ECG finding of electrical alternates, then it is okay. Then you will answer it as superior vena cava syndrome. But if he mentions the word electrical alternates, then the story will change and the answer would be given as the way I have currently mentioned. Yes, perfectly right, Sagar, Narayan, and a couple of other doctors who have done a great job here. The next question was regarding digoxin toxicity with development of a third degree heart block. So there is a bradycardia. I mean, when I say third degree heart block, it means person is having a bradycardia. And because of bradycardia, if the BP of the patient is also falling, that is the cause of concern. So what we will use in this patient would be atropine, so that I can at least stabilize the heart rate of this patient. That would be 1 milligram of atropine to be given. But if it says digoxin toxicity with ventricular bigeminy, in ventricular bigeminy is a tachyarrhythmia, then the answer of yours would be given as lignocaine. If it is ventricular bigeminy, then it is lignocaine. Or if he wants to test your knowledge further, he can even ask you regarding phenytoin. Phenytoin is going to be like an anti-epileptic drug. This is the only example where a neurology drug is used in cardiology. That is phenytoin जो membrane stabilizing agent है, वो basically user होगा digoxin toxicity के management के लिए भी. So one we have to remember regarding the aspects of digoxin toxicity, जिसपे एक या दो एक सवाल तो फंसता है digoxin toxicity पे, इसलिए मैं मेंशन कर रहा हूँ. ब्रैडिकार्डिया हो जाएगा तो एट्रोपिन, अदरवाइज लिग्नोकिन कर देना. उसके बाद में मोनोमॉर्फिक वेंट्रिकुलर टैकिकार्डिया विद स्ट्रक्चरल हार्ट डिजीज. दिस आई हैव ऑलरेडी मेंशन्ड अर्लियर, दैट इज एमेड्रॉन. But if he mentions monomorphic VT in the absence of structural heart disease, then answer is metoprolol. Guys, इसको भी आपने रिकमेंडेड है कि इसको अपने नोट्स में आप ऐड करें कि स्ट्रक्चरल हार्ट डिजीज अगर नहीं मेंशन है, जैसे वो इस्केमिक कार्डियोमायोपैथी बोल रहा है, तो फिर तो उसमें तो एमेड्रॉन यूज करते हैं. लेकिन इफ इट इज एब्सेंस ऑफ स्ट्रक्चरल हार्ट डिजीज, देन द आंसर वुड बी गिवन एज मेटोप्रोलोल. पोस्ट एमआईवीटी में ना अभी ये ना पुराने एमसीक्यूज में ना लिग्नोकेन होता था आंसर. पोस्ट एमआई वेंट्रिकुलर टैकिकार्डिया का भी जो आंसर है, फर्स्ट आंसर इज एमेड्रॉन अकॉर्डिंग टू द करंट एडिशन ऑफ हैरिसन. एंड वो मैं मानता हूँ कि फार्मा में हो सकता है कि डॉक्टर साहब ने आपको लिग्नोकेन बताया होगा, बट आप हैरिसन के हिसाब से चलो ना व्हेन इट कम्स टू द फाइनल इंटरप्रिटेशन. अगर मैकेनिज्म ऑफ एक्शन ऑफ एनी ड्रग में डाउट है, then I can suggest that for mechanism of action, it is always recommended that you answer from mechanism of action perspective. For all conditions for mechanism of action, the answer would be followed from pharma, but otherwise from medicine, that the data has to be remembered. These are like two questions that I've currently explained to you at the moment. Let's move on to the next one. If he says monomorphic VT in a crashing patient, we have done this question right today only, that then we'll be giving a DC shock. And the DC shock that we'll be using in this patient would be defibrillation. It would be not synchronized variety, but a defibrillation that we're talking about. You guys can comment PDF of ABG analysis. Doc, it's already in the previous slides that I've discussed. So once the PDF would be available, you guys would be able to analyze the information better. Okay. Wide complex QRS tachycardia in a patient overdosing on antidepressants. The question is basically on amitriptyline toxicity. Yes, guys, hit the comment button. Amitriptyline toxicity contributes to metabolic acidosis and causes a ventricular tachycardia. And what you do in this patient is give soda bicarbonate. This is like upteenth number of times this has been asked in your exam. Earlier, like, he used to make it easier, saying antidote for amitriptyline toxicity. And now when you see the data, you can see that he's writing like amitriptyline toxicity ki jagah pe is like saying patient is overdosing on antidepressants, patient is having monomorphic VT, and because there's a metabolic acidosis, then it's gonna be soda bicarbonate. Okay, moving to the next one. Cardiac arrest caused by hyperkalemia would be managed with, then it's calcium gluconate. I mean, we obviously, like for cardiac arrest, if he specifically says how do you manage cardiac arrest in a patient, then I'll obviously be giving adrenaline to the patient. If he just says cardiac arrest causing hyperkalemia, I'll be managing this with adrenaline initially. because there is like a cardiac arrest happening. So adrenaline is the initial drug that I'll be using. But once I'm able to get the rhythm back to normal, because there's a chances of adrenaline, there is a chance of like this guy going into cardiac arrest again. I'll obviously will give CPR to the patient, that is understandable. Manager cardiac arrest is adrenaline only, but then subsequently we'll be using his calcium gluconate. If the question just mentioned what is the treatment for dangerous hyperkalemia, then answer is calcium gluconate only. But if he says cardiac arrest is occurred in the patient, then if there's a cardiac arrest, then the first thing in the ACS algorithm is epinephrine as soon as possible. Na? I repeat my statement. In the advanced cardiac life support protocol, I have explained that first thing to be done in any patient of cardiac arrest in CCU or ICU care or even in emergency scenario is adrenaline to be given. So if both are given, then this is the sequence in which is to be answered. Agreed CPR, but he talked about drugs only, and calcium gluconate was also there, and adrenaline was also there. So answer first would be adrenaline. Then least chances of infective endocarditis is seen with AST, atrial septal defect, because it's a low pressure shunt, and highest chances are seen with mitral regurgitation. Highest chances of infective endocarditis is seen with mitral regurgitation. As far as the sampling in infective endocarditis is concerned, if we go by Harrison 21 data, then the rule to be followed is 3 to 1. 3 to 1 would mean that we will be using 3 sets of 2 bottles each. These bottles would be aerobic and anaerobic. It is 3 sets of 2 bottles each at a gap of 1 hour. It is 1 hour gap, and each of these samples are to be taken from a different venipuncture site. This is what Harrison 21 says. But if he says specifically in the MCQ that it is an update, if he says 2023 update of Duke's criteria, if that word update is given, then the answer will change. In the update of 2023, you will say that you will be taking 2 sets of 2 bottles each. And the timing criteria has been removed. This time it is like you don't need to puncture the patient at a different site. It is at a single venipuncture, single site venipuncture, that would be sufficient. Like earlier it was like you have to prick the patient at gap of 1 hour, and you have to like every time you go to him you have to puncture at a different site, but he says that is causing inconvenience. So it is like 2 sets or 2 bottles each. When it comes to typical organisms would be like Staph aureus or Coagulus negative staphylococcus. So it's typical 2 sets or 2 bottles each, single site venipuncture, that would be done. That is one of the update that I would like you to remember. Then he also says the fact that blood culture is overrated. Blood culture reports in a lot of cases will turn out to be negative. Blood culture is overrated, guys. He says blood culture micro में blood culture पढ़ते हैं, आधा time तो blood culture report sterile आती है. So he says that you can do a better test than blood culture. The better test as compared to blood culture would be metagenomic sequencing. Like we can take 2 sets of 2 bottles each, that's okay. But instead of doing a culture on that bottle, we can do metagenomic sequencing. Metagenomic sequencing would be superior as compared to going in for PCR or detect IgG class of antibody as compared to blood culture, because blood culture yield is on the lower side. So he says metagenomic sequencing is the one which is recommended. Over and above this, the additional thing is mentioned is that don't use only echo. He says you can use cardiac CT also, like CCT. Cardiac CT can be used. Cardiac CT is superior as compared to echocardiography, because echo में छोटा छोटा vegetations होता है, so that vegetations may be missed also. So we can be using a cardiac CT. In fact, he says like this, 3 investigations he mentions. One, he says you can do a PET scan. Instead of doing a PET scan, we can do a CCT, that is cardiac CT. And in contrast to cardiac CT, we can be doing is a echocardiography of the 2 varieties, transesophageal or transthoracic echocardiography. So in the update, what you will mention is that he is mentioned regarding typical 2 sets or 2 bottles, metagenomic sequencing to be superior to blood culture, PET CT, cardiac CT to be superior to these. And then additional point what he has mentioned is ओवर एंड अबव दिस, मतलब जो एडिशनल पॉइंट है अपडेट में, व्हाट आई से नेक्स्ट, वो थोड़ा सरप्राइजिंग लगता है सुनने में, बट दैट इज हाउ इट इज. ही हैज मेंशन्ड द फैक्ट कि भाई क्योंकि इन्फेक्टिव एंडोकार्डाइटिस के जो क्राइटेरिया थे ना, दे वर लास्ट अपडेटेड इन 90s, and then for 2 decades they were undated or they were not updated. So that is the reason why this update was like out from a blue. उसने एक नया चीज़ ऐड किया सर्जिकल क्राइटेरिया कि जब हम पेशेंट का मान लो पेशेंट का वैल्व रिप्लेसमेंट कर रहे हैं, तो वैल्व रिप्लेसमेंट के टाइम पे भी तो जो कार्डियोथोरेसिक वैस्कुलर सर्जन है जो या इंटरवेंशनल कार्डियोलॉजिस्ट है वो डैमेज वैल्व को आइडेंटिफाई कर सकता है. सो इज एडेड द वर्ड सर्जिकल क्राइटेरिया. ये पहले कभी बुक में नहीं लिखा होता था, बट नाउ देयर आर सर्जिकल क्राइटेरिया प्रेजेंट. सर्जिकल क्राइटेरिया मीन्स दैट वी कैन सी डायरेक्ट एविडेंस ऑफ डैमेज वैल्व, like we can see regurgitation occurring. So at the time of valve replacement, the interventional cardiologist, or like if it's an open surgery being done, like we are doing say a cardiac valve replacement, so direct evidence of valve damage can also be seen. This was never present in the criteria earlier, but this is like an update when I have explained to you. ट्रांस इसोफेजियल इको पहले करते हैं, फिर ट्रांस थोरेसिक करते हैं, क्योंकि बहुत बार वेजिटेशन एट्रल साइड पे होती हैं और कई बार वेंट्रिकल साइड पे होती हैं. तो दोनों में से कौन सा करना है, तो पहले करेंगे ट्रांस थोरेसिक इको एंड देन करेंगे इसके लिए ट्रांस थोरेसिक, एंड देन वी कैन डू अ ट्रांस इसोफेजियल इकोकार्डियोग्राफी इन द पेशेंट. सो दैट वाज द क्वेरी दैट केम कि पहले क्या क्या करेंगे. Atria, transesophageal echo is like for atria. Transthoracic is mainly for the ventricles. The vegetations can be present on either side. So transthoracic and then a and then first a transthoracic and then a transesophageal echocardiography would be done. Okay, guys. तो ये तो क्राइटेरिया वाली बात हो जाती है. Let's move on to the next question. And yes, you can like the session if you feel like, and otherwise इसको share भी कर लेना अपने friends के साथ में. So yes, guys, waiting for your comments for the next one and the mandatory liking and the sharing part. आजकल वो चीज़ बोलनी होती है Instagram social media point of view से. Okay जी, fine. Okay, thanks Sagar. Best for management of a type 2 diabetes mellitus in a patient who is not eating for past 3 days with low blood pressure, random blood sugar of 600, and there's gonna be urine ketostatics of 2 plus with bicarb 24. तो चलो एनालाइज करते हैं. टाइप 2 पेशेंट है, खा नहीं रहा है 2 दिन से, तो हाइपोग्लाइसीमिया पहले तो मुझे लगा, बट रैंडम ब्लड शुगर तो 600 हो रही है. ओके, दैट्स अ कॉज ऑफ कंसर्न. Urine ketostatics of the patient is 2 plus and bicarbonate is normal. Bicarbonate is normal. Guys, this is not diabetic ketoacidosis. This is not a case of diabetic ketoacidosis because bicarbonate तो नॉर्मल है ना. कीटोन्स तो स्टारवेशन में भी पॉजिटिव हो जाएंगे ना. अगर 3 दिन से कोई नहीं खा रहा है तो उसकी बॉडी में शुगर की सप्लाई बंद हो जाएगी, तो ग्लाइकोजन डिप्लीट हो जाएगा. तो स्टारवेशन की वजह से, आई मीन द वाई द कीटोस्टिक्स इज पॉजिटिव इन दिस पेशेंट इज पॉसिबली बिकॉज द पर्सन इज नॉट ईटिंग. देयर इज स्टारवेशन दैट कुड हैव रिजल्टेड इन कीटोन्स turning out to be positive in this guy, and this guy is not having diabetic ketoacidosis. This patient is having a blood sugar of 600. मैंने बहुत बार इसको बताया है कि जब भी ब्लड शुगर 600 होती है, 600 या 600 से ज़्यादा होती है, then the complication that should be taken in this case is hyperosmolar coma. एंड हाइपरओस्मोलर कोमा के पेशेंट में इंसुलिन ड्रिप का रोल नहीं होता है. उसमें मेनली आपको आईवी फ्लूइड देना होता है एंड ग्रेजुअली द पेशेंट विल इंप्रूव. सो यहाँ पे लाइक आईवी फ्लूइड पहले लिखा है, आईवी फ्लूइड फॉलोड बाय रेगुलर इंसुलिन. सो दिस इज व्हाट इज डन इन केस ऑफ डायबिटिक कीटोएसिडोसिस. और सीधा इंसुलिन ड्रिप तो देंगे नहीं, सीधा तो इंसुलिन ड्रिप देंगे नहीं, और बोलस तो कहीं पे भी नहीं देते हैं. तो यहाँ पे आंसर सिर्फ होगा, द आंसर वुड बी ए, दैट इज आईवी फ्लूइड वुड बी गिवन टू दिस पेशेंट. बोलस तो वैसे ही बंद हो गया, बोलस तो कभी देते ही नहीं है. बोलस इंसुलिन हैज बीन विड्रॉन, वी डोंट यूज बोलस इंसुलिन एनी मोर. तो वो तो वैसे ही बाहर हो जाता है. आई मीन द बोलस इंसुलिन इज नॉट यूज्ड एनी मोर गाइस, सो द बोलस पार्ट इज एनीवे आउट. So what is left in this case is simple IV fluid. Recommended read is listen to hyperosmolar coma and diabetic endocrine में ना आप सिर्फ एंडोक्राइन इमरजेंसीज पढ़ना. आपको 2 ही चीज़ें करनी है. एंडोक्राइन 2 घंटे में खत्म हो सकता है. सिर्फ उसमें पढ़ना क्या होता है, इन्वेस्टिगेशन चॉइस ऑफ ऑल एंडोक्राइन कंडीशंस एंड ऑल एंडोक्राइन इमरजेंसीज का ट्रीटमेंट चॉइस पढ़ना. Nothing more than that. Believe me, in 2 hours, the entire endocrine topic can be finished, guys. It is just get the investigation choice right and read regarding hyperosmolar coma and diabetic ketoacidosis ka different algorithms which are to be remembered. The correct answer for this is option number A. मैं क्विक मेंशन कर देता हूँ, बहुत सारे एमसीक्यूज ऐप में आपको ऐसे मिलेंगे जिसमें एबीजी करा ही नहीं होगा उसने. He will say unconscious unresponsive patient. He will say blood sugar is elevated. 300 350 की शुगर होगी. He will mention urine ketones positive, but एबीजी किया ही नहीं. सीधा आईवी फ्लूइड मार्क नहीं करना है, सीधा इंसुलिन मार्क नहीं करना है, पहले एबीजी तो करवाएंगे ना. अनलेस एंड अनटिल द ट्रायड इज सेटिस्फाइड, मार्क ही नहीं करना है. लॉट्स ऑफ टाइम इन द ऐप आप देखोगे क्वेश्चन में बड़ा स्मार्टली वो क्या कर रहा है, हम आईवी फ्लूइड मार्क कर रहे हैं, बोल रहा है एबीजी करो भाई, क्योंकि एसिडोसिस तो सेटिस्फाई नहीं हुआ. तो सबसे पहले तो रैंडम ब्लड शुगर की वैल्यू 250 से ऊपर दी होनी चाहिए डायबिटिक कीटोएसिडोसिस के लिए. The second thing to be done for this would be that we need to demonstrate either ketonemia. The test that we do for ketonemia, I'll just write in a few seconds from now, or the test that we do for ketonuria, I'll write in few seconds from now. But a lots of time, the trick in the question will be that the bicarbonate value in the question would be missing. And if bicarbonate is missing, you cannot call it diabetic ketoacidosis. So always take care of that. What test should be done for demonstration of ketonemia is a blood test by the name of plasma beta hydroxybutyrate. If it says what is the test to be done for ketonemia, then it is plasma beta hydroxybutyrate. And if it says ketonuria, then obviously for ketonuria it is easy. That is urine ketosticks would be used. That is ketosticks that would be used. That is one. If he says in a question कि patient में thready pulse है, मतलब पल्स ही गायब होगी डिहाइड्रेशन की वजह से, तो उसमें फिर हम क्या करेंगे, तो यहाँ पे आंसर होगा नॉर्मल सलाइन बोलस। बोलस अगर थ्रेडी पल्स है और पेशेंट ड्राउजी हो रहा है तो पहले हम नॉर्मल सलाइन बोलस देंगे ताकि टिल पल्स कम्स बैक टू नॉर्मल, टिल वी गेट अ बाउंडिंग पल्स, टिल पल्स नॉर्मलाइजेस। ऑन द अदर हैंड इफ ही सेज डीके विद हाइपोटेंशन, तो उसमें फिर क्या करेंगे, उसमें हम नॉर्मल सलाइन बोलस की जरूरत नहीं है, फिर हम नॉर्मल सलाइन ड्रिप देंगे। ये आप आंसर कर रहे थे, नॉर्मल सलाइन ड्रिप, और इसके 1 आवर के बाद में, इसके 1 आवर के बाद में इंसुलिन ड्रिप चालू करते हैं। दिस इज द कॉमनेस्ट क्वेश्चन दैट इज आस्क्ड नाउ डेज, दैट आई एग्री टू इट, बट दिस क्वेश्चन दैट आई डिस्कस्ड बिफोर यू वाज अ वेरिएंट। एंड मोस्ट ऑफ द टाइम जो क्वेश्चंस ऐप में दे रखे हैं उनमें या तो जैसे हाइपरऑस्मोलर कोमा दे देगा तो वहाँ सीधा आईवी फ्लूइड देना। अगर वो बोलता है थ्रेडी पल्स तो फिर आप बोलस कर देना, और अगर ओरली ले सकता है तो फिर तो फ्लूइड का रोल ही नहीं है ना, फिर तो उसको बोलेंगे भाई जो भी खाना वाना खाओ और सबक्यूटेनियसली, आई मीन ओरल इनटेक विल बी अलाउड, और उसमें हम सबक्यूटेनियस इंसुलिन यूज कर लेंगे। बिकॉज डायबिटिक कीटोसिडोसिस में इनिशियली पेशेंट कैन बी ईटिंग ओरली ऑल्सो, माइल्ड वॉमिटिंग कैन बी देयर। तो इनिशियली लाइक अगर वो पेशेंट ओरली ले पा रहा है, इज एबल टू रिटेन सम फ्लूइड, देन वी कैन गिव सबक्यूटेनियस इंसुलिन टू द पेशेंट ऑल्सो। तो great, great. And normal saline with yeah, normal saline with regular insulin drip that would be given to the patient. ये 1 hour याद रखना, one after normal saline it is insulin drip to be given. So standard question on DK, I'll repeat this again. एंडोक्राइनोलॉजी में ना हमेशा डायबिटिक कीटोएसिडोसिस पढ़ लेना और सारे एंडोक्राइन इमरजेंसीज पढ़ने। एवरी टाइम ही सेज, इनफैक्ट मस्ट नो जो है वो डीके है, डीके को कम से कम 2 बार ही सुनना सो दैट यू डोंट मिस इट एट एनी पॉइंट ऑफ टाइम। And he says electrolyte imbalance with decay with extensive vomiting and prostration, a person will be having hypokalemia. It has to be hypokalemia because of the GI losses, plus insulin देंगे तो sugar will go inside the cells and potassium will also go inside the cells. If he says what is the initial treatment for acromegaly, then we need to shrink the size of the tumor. Like he gave a question in which spade-like hands were given. He did not ask screening test which is IGF-1 or investigation choice which is glucose challenge test. वो बोला करेंगे क्या, to so to shrink the pituitary, what we will be doing in this patient is give a somatostatin analog in this case, and the somatostatin analog to be used as lanreotide. pH and potassium have an inverse relation, that is okay, पर GI losses हो गए ना तो physiology will override, patho will override physiology. वो तो pH and potassium have inverse relation, I agree to that. But here what I wanted to follow is that if there is GI losses, then potassium will be less in the body because patho overrides physiology. भाई body में जब हम बीमार होते हैं, if a person's body will fall sick, then physiology goes out of the window. Physio is when you and me are alive and kicking. Now when you and me are talking, physiology is working. But if you and me become sick, then there is no physiology ना, then there is no inverse relation happening. Then तो अगर आदमी उल्टी करेगा तो उसका पोटेशियम कम हो जाएगा। Okay guys, you have been silent for a while. पैग विसोमाइट जो है बच्चे वो तो तब देते हैं ना जब पर्सन को रेकरेंस हो जाती है। इफ पैग विसोमाइट इज टू बी आंसर्ड इन अ क्वेश्चन इफ देयर इज अ रेकरेंस ऑफ द ट्यूमर। So yes guys, AIDS positive patient with features of lobar pneumonia, CD4 count is 100. What is the leading organism? Waiting for your answer for this one. Yes guys. एड्स पॉजिटिव पेशेंट है, लोबार निमोनिया हो गया नहीं यार, वही है ना ये क्वेश्चन जो है इसमें लोबार निमोनिया है ना, लोबार निमोनिया वुड नॉट बी आंसर्ड बाय यू एज pneumocystis jirovecii. If it is going to be lobar pneumonia, it would be answered by you as pneumococcal pneumonia. I repeat that again, pneumocystis jirovecii जो है ना, That will always cause bilateral infiltrates. Pneumocystis jirovecii, the X-ray will always be showing presence of bilateral infiltrates, and they would be like perihilar scanty infiltrates present. So here the answer would be given as pneumococcus only. Okay, sorted for 79. Let's move on to 80. ECG finding of ST depression is seen with which drug? Yes, guys, we can speed things up. You guys can help me out with these questions in the end, which are easier ones. ST depression seen with which drug? These are like those questions which have to be like verbatim, and you have to be able to replicate them. Okay. Yes, very good. That would be seen with digoxin. Administration of digoxin can contribute to development of ST depression in a patient. And ECG finding of ST depression with prominent U waves would be seen with. Yes, guys. ST depression and prominent U waves would be seen with which of the following conditions? Yeah, Jatin, you can attend that. Not never a problem. Yes. Yes, prominent U waves is a feature that is seen with hypokalemia. ये तो बड़े simple से questions हैं यार. Prominent U waves would be seen with hypokalemia. That's one of the key things that is present. And hypokalemia में arrow नीचे जाता है तो ST depression would be present. So hypokalemia would make it easier for you. The word prominent U waves would have sorted for you. Yeah, Jatin, you can join. Okay. Yeah, underkalemia. Okay, that is fine. नेक्स्ट इज आरटीए पेशेंट, उसको सांस लेने में दिक्कत हो रही है 48 घंटे के बाद में, और पेटिकल ब्लीड भी है, SpO2 80% है. तो कंसिडरिंग दैट देर इज अ लंग प्रॉब्लम एंड देर इज डेवलपमेंट ऑफ पेटिके ऑल्सो, the diagnosis in this case would go in favor of fat embolism syndrome. If this petechiae were not given, I would not have thought of fat embolism. I could have thought of pulmonary embolism as well. Then is a nephrotic syndrome patient who's having shortness of breath after long distance flight. What is the best investigation to work up this case? Then if I say shortness of breath after long distance flight in an individual, that means कि prolonged immobilization की वजह से उसको pulmonary embolism हो गया होगा. Shortness of breath after long distance flight, that means person was sitting in the plane for long duration, तो बैठे बैठे उसको calf veins में clots बन गए, और वो जो क्लॉट्स थे वो क्लॉट्स टूट के फिर लंग्स में चले गए, तो उसे पल्मरी एम्बोलिज्म हो गया. तो अगर डीप वेन थ्रोम्बोसिस की वजह से पर्सन को पल्मरी एम्बोलिज्म होता है, तो फिर उसके वर्कअप के लिए जो टेस्ट हम करेंगे, दैट वुड बी CTPA, that is CT pulmonary angiography will be used in this patient. CT pulmonary angiography is the main test for diagnosis of pulmonary embolism. Yes, the word is CTPA, otherwise your answers are perfectly fine. ओके, नेक्स्ट इज अ पेशेंट जिसको जॉइंट रिप्लेसमेंट सर्जरी हुआ है और उसको सेकेंड डे पे प्रोमिनेंट नेक वेन्स हैं, लो ब्लड प्रेशर है. सो जॉइंट रिप्लेसमेंट सर्जरी के बाद में सांस लेने में दिक्कत हो रही है. दैट मीन्स देयर इज अगेन अ क्लॉट फ्रॉम हिज फेमोरल वेन और इलियक वेन दैट वेंट अप इनटू द लंग्स एंड इज कॉजिंग पल्मरी एम्बोलिज्म. और पल्मरी एम्बोलिज्म में बीपी लो हो जाता है क्योंकि लंग्स में ब्लड जाएगा ही नहीं, तो लेस ब्लड विल कम टू लेफ्ट साइड ऑफ द हार्ट. दैट इज वाई पल्मरी एम्बोलिज्म वुड बी अकरिंग. कंसिडरिंग दैट वो कहता है कि भाई इसमें करेंगे क्या. यस, आई एम वेटिंग फॉर योर आंसर्स हियर. Pulmonary embolism in a patient, and there is gonna be pulmonary embolism with hypotension. If the BP is falling, then we have to do thrombolysis. अगर BP नॉर्मल होता तब तो ठीक था, बट लो BP हो गया ना, तो इसलिए इसके मैनेजमेंट के लिए हमें L-टेप्लेस यूज करना पड़ेगा. पल्मरी embolism के पेशेंट में इफ इट्स हाइपोटेंशन मीन्स इट्स अ लार्ज क्लॉट, and that large clot needs to be broken down using L-tablet in the patient. If in the question the mention of hypotension was not given, then heparin was okay. If the question simply said how do you handle pulmonary embolism patient and the blood pressure value was given to be normal, not a problem, then I can use heparin in a patient. But if it is treatment of a patient with low BP, then it is L-tablet with heparin. हेपरिन दोनों में यूज करते हैं, बोथ इन पल्मरी एम्बोलिज्म विद नॉर्मल बीपी एंड लो बीपी. बट इफ इट इज क्रैशिंग पेशेंट, इफ ही सेज हेमोडायनामिक इंस्टेबिलिटी, अगर बीपी क्रैश कर रहा है तो एक बड़ा सा क्लॉट पल्मरी आर्टरी के अंदर फंस गया है, उस क्लॉट को जब तक हम दवाई से तोड़ेंगे नहीं, देयर वुड बी नो इंप्रूवमेंट. सो दैट्स व्हाई लाइक इट इज L-tablet दैट वुड बी यूज्ड इन दिस पेशेंट. नेक्स्ट इज अ केस ऑफ शॉर्टनेस ऑफ ब्रेथ आफ्टर सेंट्रल लाइन इंसर्शन. क्विक आंसर्स है, दो ऑप्शन दे रहा हूँ, न्यूमोथोरैक्स और एयर एम्बोलिज्म. सिलेक्ट वन प्लीज. न्यूमोथोरैक्स इज वन एंड एयर एम्बोलिज्म इज द सेकंड वन, विच एवर यू फील इज अप्रोप्रिएट. Yes. The number one cause for shortness of breath after a central line insertion would be answered by you as pneumothorax. Air embolism comes second, but सबसे पहला जो cause है shortness of breath after central insertion is pneumothorax in a patient. Air embolism थोड़ा less likely होता है ना, उसमें तो large amount of air should be going inside and then the problems should be occurring. Otherwise, shortness of breath after central insertion would be with pneumothorax. Okay, the next case is showing a absent air entry, absent breath sounds in a patient, a deep sulcus sign. You can check out in this X-ray also, like a deep sulcus sign is present as compared to the contralateral side. So considering deep sulcus sign and absent breath entry and breath sounds, we know that we are dealing with a case of pneumothorax. And this patient is deteriorating to the level that his lips can turn blue. There can be crashing of blood pressure, because if you're having large amount of air present here, this will press on the SVC and the IVC. And kinking of the SVC and IVC will cause crashing of the blood pressure of this patient. So what we do in this patient is, जो option number C है, wide bore thoracocentesis. Thoracocentesis तो pleural effusion में करते हैं ना. Thoracocentesis is done in cases of pleural effusion, that is hydrothorax in a patient. तो हम कोई thoracocentesis तो कर नहीं रहे हैं. So yes guys, waiting for an answer here. Okay, giving more people a chance to work it out here. In the patient, what are we gonna do? We are gonna first put a wide bore needle and do a needle thoracostomy, because it will make a hole through which the air will escape, and then subsequently we'll put in a chest tube, क्योंकि हवा सिर्फ needle डालने से तो निकलेगी नहीं ना. If it's a large amount of air which you can see present here, which is causing compression of one lung, then I need to evacuate this air. And how do I get rid of this air is that I need to put in a chest tube. So the correct answer for this one is option number B. That's a needle thoracostomy plus a tube thoracotomy. We need to get rid of that air, and then subsequently we'll put in a chest tube in this patient. And C जो है that would be for no wide bore से नहीं है, thoracocentesis. It is not wide bore, तो आपको distract करने के लिए. वाइड बोर जो वर्ड है वो तो डिस्ट्रैक्ट करने के लिए ना, कि वाइड बोर नीडल डालते हैं न्यूमोथोरैक्स के लिए, तो वो जानबूझ के कर दिया वाइड बोर नीडल थोरैकोसेंटिसिस इन द क्वेश्चन. वो स्मार्टनेस दिखाया ना, वाइड बोर वर्डल थोरैकोसेंट. भाई पस है, मान लो गाड़ी होती है ना, पस तो निकलती नहीं है, तो वी कैन डू थोरैकोसेंटिसिस इन द पेशेंट. thoracotomy, tube thoraco, okay, plus a tube thoracotomy. So it would be tube thoracostomy only. I agree to that. That would be a bit of a word, right? Okay, pulmonary embolism in short. Okay, fine. We do a quick workup here. Pulmonary embolism is gonna be like a condition in which there's gonna be a big clot in the bang in the middle pulmonary artery. We're gonna do a 1 minute evaluation of this, and then the workup part. There's a big clot, guys. And जैसे ये blood clot यहाँ पे land करेगा ना, जैसे ही clot ने रास्ता बंद किया, so the pressure in the pulmonary artery will rise, क्योंकि आगे तो blood जा नहीं रहा है. So there's gonna be increase in the pressure in the pulmonary artery. And अगर pulmonary artery में pressure बढ़ जाएगा, तो it will also contribute to right ventricular failure. Like I modified the diagram, so most of the time he will mention even elevated JVP for these patients. He might mention the person is having elevated JVP, and because एक ही lung में blood जा रहा है, इस साइड पे तो ब्लड जा ही नहीं रहा ना, तो दे वुड बी अ ड्रॉप इन SpO2. सो he'll say sudden onset respiratory distress, but they would be finding some right ventricular failure described in the question, like elevated JVP or small sign or widespread second heart sound. And the bad news is the clot which is present here will also cause a septal deviation. Because of the septal deviation, what will happen is कि जो LV का cavity का size है, that will become smaller, so it will receive less blood. If less will come in, less is going to be going out. So therefore, the systolic blood pressure of this patient will begin to fall. So what you can see in this representation is massive pulmonary embolism, as I've shown, can cause a crashing of blood pressure of a patient, as is shown in the figure. We'll talk about sudden onset respiratory distress in any patient having immobilization. Or instead of immobilization, he can mention a person who's having cancer, any cancer. All cancers have a hypercoagulable state. Or he can mention patient who's undergone cancer surgery. Or he can mention patient who's undergone joint replacement surgery, like total knee replacement, total knee replacement. Or he can mention patients having protein C deficiency since birth, or protein S deficiency since birth. Protein C and protein S deficiency will contribute to hypercoagulable state. Then is gonna be like factor 5 latent mutation. So these are like the situations that would be given in a question, whether it's gonna be orthopedic surgery or immobilization. There's gonna be right ventricular degeneration occurring in this patient. And अगर इंट्राजुगुलर वेन है ना, तो इंट्राजुगुलर वेन वाला जो कैथेटर है यार, उसके साथ में तो फिर इट वुड बी मेनली एयर एम्बोलिज्म ना, देन इट वुड नॉट बी। बट बहुत बारी तो इंट्राजुगुलर वेन में प्रेफर्ड होती है ना, बहुत बार तो सबक्लेविन डाल रहे होते हैं। Lots of time we put a subclavin, no? So that's why the subclavian catheter wala can damage the lung of the patient. So if he says intrajugular vein, it's okay, but most of the time it does not mention the site. And traditionally we put only in subclavian in contrast to intrajugular vein. Okay. So in this patient, guys, the main aspect is pulmonary embolism is gonna be like the sudden drop of blood pressure in this patient. That's one of the main aspects. And the investigation of there are two MCQs that they'll always ask you: screening test for this condition, that is D-dimer assay, and the investigation choice for this condition, that is CTPA. And in case he says what non-invasive investigation is done to identify the cause, that is deep vein thrombosis, then we'll do a Doppler. The Doppler will help you identify the cause, that is the clots which are present. And the treatment part is what I've already explained to you. If it's a hypotension, it's with Eltaplis. If the hypotension part is not there, then it is plain heparin for the patient. So this is gonna be the main scenario which should be remembered. एंड सर ऐसा नहीं है, ज़रूरी नहीं है कि जुगुलर वेन में डालते हैं। बहुत बार जो पेशेंट्स होते हैं, सिक होते हैं, गर्दन की मूवमेंट हम ज़्यादा नहीं करा सकते। ओल्ड एज में सी स्पाइन की डिसेबिलिटी होती है ना, लॉट ऑफ पीपल इन ओल्ड एज वो क्रिटिकली सिक, they cannot move their neck, so it's very difficult to move a neck like this, get a jugular vein, and then put a central line. So emergency may put a subclavian line in those old people who are critically sick. And though we prefer to put intrajugular vein in the central line in the jugular vein, but lots of sick patients who need a central line in place may be having comorbid conditions due to especially degenerative spine disease, due to which we may not be able to get a vascular access. Okay, moving to the next one, Hammond crunch sign. If he says Hammond crunch sign is gonna be seen in, yes guys, quickly. Hammond crunch is that like somebody walking on snow. Yeah, that's perfectly fine, Shalish. That is what we do. Subclavian is preferred in the OT and IGV in the ward. Yep. Okay. Yeah, Hammond crunch sign is seen in patients of, then answer would be pneumomediastinum. It would be sound as if somebody is walking on snow with as if somebody is walking on freshly fallen snow with leather boots on. So that's Hammond crunch sign, and that would be seen in patients of pneumomediastinum. And yeah, I mean, the main aspect is Hammond crunch sign is an auscultatory finding that would be seen with respect to pneumomediastinum. Okay, next is another condition in which pneumomediastinum would be, okay, I'll not give you hints here. There is like alcoholic is having very severe epigastric pain. He's having forceful retching minus any vomiting, and at the same time, there is inability to pass the NG tube. So I expect you guys to tell me, like you guys read GI very well from surgery. So yes, guys. Okay, okay. So इसको ध्यान से पढ़ो guys. I don't think so that the answer is Boyer-Haave syndrome, क्योंकि Boyer-Haave syndrome में तो there is gonna be chest pain ना, not epigastric pain. Yes, इसमें तो epigastric pain है ना, inability to pass NG tube. So NG tube is not being passed because stomach अपने axis पे घूम गई है. So the answer in this question is to be given as stomach volvulus. The answer in this question is stomach volvulus. This is not a case of Mallory VS, and this is not a case of Boyer-Haave syndrome, guys. Please read it carefully. I know that अभी तो relax mode पे बैठे हो, but आगे competition तो है यार, tough है ना, तो इसको stomach volvulus है. Triad का नाम बोलो. What is the name of this triad? Yes, what is the name of the triad? आंसर नहीं आया यार, ये तो ट्रायड वाइड तो आप तो रट्टा लगा के बैठे होते हो. दिस इज गोना बी कॉल्ड एज बोरचार्ड्स ट्रायड. वेरी गुड. दिस इज कॉल्ड एज बोरचार्ड ट्रायड. वो जो मैकुलर ट्रायड होता है तो बोयर-हाव सिंड्रोम के लिए होता है ना, दैट इज मैकुलर ट्रायड. दिस इज कॉल्ड एज बोरचार्ड ट्रायड, whereas macular striate is used for diagnosis of patients of Boyer-Haave syndrome. This would be Borchardt triad. Okay, ji, 88 is sorted. Next is the question in which you guys were saying forceful retching followed by chest pain and then subcutaneous emphysema. This is Boyer-Haave syndrome. So don't assume कि अल्कोहलिक को वाला सारा क्वेश्चन जो होगा Boyer-Haave syndrome ही होगा, क्योंकि अगर उसमें मेंशन होता कि पेशेंट को एपिगैस्ट्रिक पेन और एनजी ट्यूब नहीं जा रहा है, देन द आंसर वुड बी गिवन एज व्हाट वी डिस्कस्ड ऑन द प्रीवियस स्लाइड, एंड currently it is like Boyer-Haave where we have macular striate for diagnosis. अगले में comment करो quickly. These are easier ones, right? I mean, the GI part is always a favorite of everybody. So, yep, guys, the next one is gonna be epigastric pain radiating to the back. This would be a feature of acute pancreatitis. Yes, this would be acute pancreatitis. Very good. I think most guys mentioned it correctly. Then is drug of choice for tumor lysis syndrome. TLS will always be occurring whenever we are giving chemotherapy, like in Burkitt's lymphoma, acute myeloid leukemia. Those are the kind of cancers in which tumor lysis syndrome can be occurring. The most common cancer causing this is tumor lysis, is Burkitt's lymphoma. The drug of choice for this condition is rasburicase. Though if he says what is the initial treatment of this patient, then initial would be prevention of this with adequate hydration, that is IV fluids. So normal saline would be given in this patient to achieve brisk diuresis. It is mainly like tumor lysis syndrome is IV fluids like normal saline. Hydration or rasburicase is perfectly the correct answer. Then is that key question on extensor purpura, like he'll give the image where on the buttocks of the child, back of the thighs of the child, there is a purpura present for which we'll have to give steroids. Henox-Collin purpura is the answer in this case, that is HSP. And for management of HSP, we need to give steroids. The main indication for steroids in these patients would be if they're having concomitant kidney involvement. Sometimes HSP can be having kidney involvement and there can be hematuria also. But if person is having GI vasculitis, GI symptoms also very severe, the vasculitis of the GI tract which is causing severe abdominal pain, even then steroids are required. Indications for steroids in Henox-Collin purpura are kidney involvement and GI involvement. EXT कब steroids देंगे, then that is the indications which are to be remembered. It is IgA, basically immunoglobulin A. Then what is not found in MEN2B syndrome is a repeat of NEET PG. So MEN2B now is called as MEN3. और इसमें जो पैराथ्रोइड एडिनोमा होता है that will be losing its position. I mean, the parathyroid adenoma is not a feature. It is seen with MEN1 as well as MEN2, but is not a feature of MEN2B. That is parathyroid adenoma. Very good. Then is calculation formulas. I've told you two calculation. One is for soda bicarbonate that we've already discussed, weight into 0.5 into 25 minus the actual value. But for hyponatremia, it is gonna be 140 minus the actual value. So you just have to remember that for sodium correction, the answer will depend upon men and women. In men, what you need to do is multiply the weight of the patient by 0.6 into 140 minus whatever is the actual value of sodium given in the question. Just apply the mathematical formula, like weight is 60 kg, 60 into 0.6 into whatever is the actual value. If it is going to be a female, it is weight into 0.5 into 140 minus actual value. I am mainly focusing on total corrections which are to be remembered. बट फॉर सोडा बाइकार्बोनेट ऐसा कोई डिफरेंस नहीं है जेंडर वाइज. सोडा बाइकार्बोनेट में स्टैंडर्ड है वेट इंटू 0.5 into 24 minus the actual value in the patient. So the main aspect to be remembered would be that it is like soda bicarbonate, there is no gender wise data, but for sodium correction it is the gender wise data that has to be remembered in mind. But these are two calculation formulas which are like scoring questions again, where he'll just ask you total correction बता दो. तो आपको पर डे भी नहीं पूछ रहा, वो पर डे का तो अलग अलग बात होती है. मैं तो पर डे में तो मैं फोकस ही नहीं कर रहा, मल्टीप्लाइड बाय 8 से. आई एम सेइंग जस्ट गेट द टोटल कैलकुलेशन राइट, दैट अलोन वुड बी सफिशिएंट फॉर इवैल्यूएशन. Then is the question of Wallenberg syndrome that does not involve which cranial nerve. Wallenberg syndrome is involvement of vertebral artery slash pica. In this condition, there is involvement of multiple cranial nerves like 5, 7, 8, 9, 10, 11. All of these are originating from the lateral aspect, but does not involve which. Then it's gonna be the 12th nerve, because this 12th nerve involvement would be medial medullary syndrome. 12th nerve involvement is always medial medullary syndrome, where the involvement will be of the anterospinal artery. Yes, anterospinal artery. Epigastric pain radiating to the back is not aortic dissection. If it is chest pain going to the back, then it is aortic dissection. Epigastric pain going to the back is pancreatitis. If it is chest pain going to the back, then you have to think in terms of aortic dissection in a patient. Yep, it's chest pain radiating to the back. Then is apolipoprotein E is associated with development of Alzheimer's disease. Apolipoprotein E is related to two diseases. One is cerebral amyloid angiopathy and second is Alzheimer's disease. Both are having A beta amyloid deposition, but in cerebral amyloid angiopathy, A beta amyloid is deposited in the blood vessels of the brain, and these blood vessels will become weak. So there would be brain hemorrhage, and it will cause an intracerebral hemorrhage in a patient. But in Alzheimer's disease, the A beta amyloid will be deposited with respect to the neurons, and because it is deposited with respect to the neurons, the presentation in this case would be dementia. The basic point is A beta is coming both times, one in the blood vessels of the brain, second is with respect to neurons. If he says blood vessels, it is brain hemorrhage. If it is going to be neurons, then it is going to be related to the dementia component. So those are like, slight subtle differences that you need to remember. And apolipoprotein E is associated with development of Alzheimer. Then what is protective for Alzheimer disease is only two things. One is NSAID usage and second is apolipoprotein E usage. Everything else, advanced age, smoking, वगैरह, everything is hypertension is worsening the possibility of dementia and Alzheimer. But apolipoprotein E2 allelic variant is protective for Alzheimer and smoke and NSAIDs also. अदरवाइज सभी डिजेनरेटिव फैक्टर्स होंगे अल्जाइमर्स के लिए. अल्जाइमर का इन्वेस्टिगेशन चॉइस बता दो मुझे. व्हाट इज द इन्वेस्टिगेशन चॉइस फॉर अल्जाइमर्स डिजीज? Imaging modality of choice for Alzheimer. Yes, guys. Imaging modality of choice would be answered as amyloid PET scan. It is amyloid PET scan as the imaging modality of choice. अगर amyloid PET scan नहीं दिया होगा, फिर आप आंसर कर सकते हो functional MRI. We can answer fMRI, that is functional MRI for the patient. But otherwise the investigation choice for Alzheimer is amyloid PET scan. अगर नहीं हो तो then answer is functional MRI in the patient. Yeah, amyloid PET scan is what is recommended. बाकी एडुकेनुमैब आपने खुद से पढ़ना है गाइस. वो ना एडुकेनुमैब इज यूज्ड इन माइल्ड कॉग्निटिव डिक्लाइन. इट इज नॉट यूज्ड इन एस्टैब्लिश्ड अल्जाइमर, बट इट इज यूज्ड टू प्रिवेंट द डेवलपमेंट ऑफ मैनिफेस्टेशंस ऑफ अल्जाइमर इन माइल्ड कॉग्निटिव डिक्लाइन. या MMSC is for screening, that is for dementia ना, that is only a test for dementia. Then entry level criteria for diagnosis of SLE is obviously anti-nuclear antibody, which everybody can answer. But my next question would be like, what is the best screening test for scleroderma? Yes, guys. Yeah, 4 out of 11 features and more than 1 by 80 is the diagnostic criteria. What is the best screening test for scleroderma? The answer would be given as anti-nuclear antibody. Screening test for scleroderma is anti-nuclear antibody. The best test for confirmation of diagnosis would be anti-SCL70, which can be written as topoisomerase antibody. रूमैट इज़ वेरी सिंपल गाइज. आई थिंक 1 से 2 आवर्स का ही डिस्कशन है, मे बी 3 होगा, उससे ज़्यादा तो नहीं हो सकता इन रैपिड रिवीजन. सो जस्ट वो एंटीबॉडीज़ का रट्टा लगाना है, तो उसमें कोई इशू नहीं है. ओके, व्हाट इज़ द मोस्ट कॉमन एक्स्ट्रा आर्टिकुलर मैनिफेस्टेशन ऑफ रूमेटोइड आर्थराइटिस? रूमेटोइड. Yes, guys. So we'll do 101 today instead of doing 100. Yes, most common extra articular manifestation of this would be rheumatoid arthritis is rheumatoid nodules. The extra articular manifestation is rheumatoid nodules. ये कहाँ पे मिलते हैं? तो extensor distribution में मिलते हैं. They would be on the olecranon process or on the occiput or on the back of the patient. That is the most common extra articular manifestation of the patient. But if it changes to what is the ocular involvement in rheumatoid arthritis, then it is not uveitis. तो नॉर्मली तो हम यूवीआइटिस पढ़ते हैं ना, नॉर्मली जितने भी ऑटोइम्यून डिसऑर्डर होते हैं सभी में यूवीआइटिस होता है. व्हाट इज द ऑक्यूलर इन्वॉल्वमेंट इन आरए प्लीज? कैन आई हैव द आंसर प्लीज? Yes, keratoconjunctivitis sicca. That is a very characteristic manifestation that for cases of rheumatoid arthritis, don't answer uveitis. It is keratoconjunctivitis sicca, which is the first answer, followed by scleritis and all those things. But first is keratoconjunctivitis sicca. Then is what is the best test for localization of a gastrinoma? Screening investigation choice for localization of a gastrinoma in the gastronoma triangle. Your answer would be dotatate. This is gallium-68 dotatate PET CT scan. This has become a hot favorite of our examiner. तो इसको याद कर लेना कि gallium-68 dotatate PET CT scan कहाँ पे ऐड करना है, कहाँ पे आंसर करना है. जितने भी पैंक्रियाटिक न्यूरोएंडोक्राइन ट्यूमर्स हैं, जितने भी पैंक्रियाटिक न्यूरोएंडोक्राइन ट्यूमर्स हैं, जैसे कि इंसुलिनोमा हो गया, ग्लूकेगोनोमा हो गया, सोमैटोस्टेटिनोमा हो गया, सारे के सारे जो पैंक्रियाटिक न्यूरोएंडोक्राइन ट्यूमर्स हैं, सभी में आंसर आपका आंसर वुड बी गिवन एज गैलियम. दिस इज अ अपडेट गाइस, सो प्लीज नोट इट डाउन, क्योंकि ये आपके ओल्ड वर्जन में नहीं है, नए रैपिड रिवीजन में तो है लेकिन ओल्ड वर्जन में नहीं है. gallium-68 dotated PET CT is for all pancreatic neuroendocrine tumors including somatostatinoma. It is also the imaging modality of choice for Zerlinger-Lesson syndrome and is also now the imaging modality of choice for pheochromocytoma. I've used the older version in the app. I've said MRI. I don't dispute that. MRI was what was given. But in the latest edition, he says that pheochromocytoma ke liye bhi imaging modality of choice is to be answered as gallium-68 dotated PET CT scan. Main test for pheochromocytoma is obviously the 24-hour. चलो आया ही है तो मेंशन कर लेते हैं. प्योक्रोमोसाइटोमा के लिए जो टेस्ट करते हैं ना यूरिन में, वो है 24 आवर यूरिनरी फ्रैक्शनेटेड मेटानेफ्रिन्स. इट इज नॉट फ्री मेटानेफ्रिन, इट इज 24 आवर यूरिनरी फ्रैक्शनेटेड मेटानेफ्रिन वैल्यू फॉर इवेल्युएशन ऑफ प्योक्रोमोसाइटोमा. क्वेश्चन फॉर यू गाइस, यूरिनरी वेनियल मेंटेलिक एसिड लेवल्स कहाँ पे करते हैं? दिस वाज आई थिंक नवंबर इनिशिएट, सो यू गाइस कैन हेल्प मी. Technetium, okay, I'm writing that, doctor. Technetium, you answer my question. यूरिनरी वेनाइल मेंटेलिक एसिड जो है उसको कहाँ पे करते हैं? टेक्नीशियम 99, सिस्टामेबी, स्पेक्ट-सीटी. दिस इज गोना बी डन फॉर पैराथ्रोइड एडिनोमा. इमेजिंग मोडालिटी और चॉइस में ये दो स्टैंडर्ड क्वेश्चंस है विच आर ऑलवेज आस्क्ड यू. स्पेक्ट स्कैन तो हम कार्डियोलॉजी में भी यूज करते हैं, बट टेक्नीशियम 99, स्पेक्ट-सीटी इज फॉर पैराथ्रोइड एडिनोमा. Yeah, even for carcinoid tumor localization, I can be using a PET-CT because tumor is very small, na? Okay, yes guys, veneal metallic acid level कहाँ पे use करते हैं? Very good. It would be used for diagnosis of neuroblastoma. Urinary veneal metallic acid levels that would be used for evaluation of VMA levels is for neuroblastoma. These are like very standard questions which would help you increase your discussion or decrease your yield. So guys, we were planning to do 100, but I've done like today like a one, I can say 101. Actually, I speak on much more questions than that, like, you know, much more than that. So I can say like in the previous almost 4 hours of our discussion, what we have done is like about 300 bits. That's the points that I've tried to explain to you. If I divide it, like I've done like about, you know, 70-80 bits per hour. So I would like you to, you know, whenever you're free, subsequently, like listen to this at 2x so that you can get the points right. And spect no geeky medics. This is spect city no. So thank you guys for hearing me out. This took a while for me to complete, but then it's all worth the effort in the end. So keep hammering, as I say always. I mean, you just have to break on to the other side. It's a long road ahead. I agree to that. It puts a lot of mental pressure, and especially on a, I would say, on a holiday when everybody else is enjoying, it becomes a little overbearing to remember all these things. But you guys are gonna do subsequently great. So there'll be many more sessions, guys, but I think abhi to information overload ho jayega. So thank you so much, and God bless you. So I'll be like we'll do multiple sessions, guys, subsequently with बहुत time hai. But then at the same time, like I had to, you know, tell you guys to buck up and fasten your seat belts and get into the groove. So that was the main objective for this. Yeah, doctor. I'll be doing more sessions subsequently. So thank you so much. I try to focus on those aspects which are like must know facts at the moment. There are about 300 bits discussed today. If you look at the entire information provided, thank you so much for joining. Bye bye. God bless you.